Okay, in summary, what we did yesterday is this. So what we did yesterday is this. I mean, that the last thing we did is about the basal ganglia. See, don't give yourself any headache, and I can bet that one with you. Most of what you need is just in this diagram. So if you know you are going for the exam very soon, take this diagram and master it, because what they are going to do is to, most of the time, is just to give you the diagram and now talk about a lesion and ask you to identify which part of the brain it is, the lesion is. So all you need to do is just, and it's very easy to identify. These are your lateral ventricles. This one that is here, you will always see, that's how it's always going to be. It won't change. That is your caudate nucleus. Then these big ones, they are the thalami. Then underneath the thalami, you have your subthalamic nucleus or nuclei. Can you see them? Then you will see a particular region that look hyperpigmented. That will be your substantia nigra. That one has a substance in it. So sorry, I need to put it that way. Past compactor. Something is there. So you can just look at it that way so that at least you can remember. Do you get it? Then this one that look like a lens like this, that's your lentiform nucleus. So this outer part of it is the putamen, while the inner part, these two inner parts, they are the globus pallidus. So one of them is external, the innermost one is the internal. So that's all. So, and that's everything you just need to note here. This one that is behind the third ventricle here is your hypothalamus, and that's all. So, if you can master that, revise it over and over again, you will not regret it in the exam. It will look like magic. So, I told you about the lesions. To identify the lesion, you can use the name, it will help you. Before we look at them, anytime you hear the word striatum, striatum is just the combination of putamen and caudate. And this is the caudate, this is the caudate, this is the putamen. Dr. Antonia asked yesterday that we should identify it. So I drew this around it. So this is the caudate, this is the putamen. And that's striatum. You need to note that too. So if we have yeah, like a lesion on the substantia nigra. I jokingly said something yesterday that I look at it as nera, and since the time I've been looking at it like that, I don't mix it up. So in Yoruba land, if you say something is like onera, onera means it's very difficult for me. It's quite not easy. So you notice that in all the problems that you are going to be seeing in question, there is one that movement is very difficult for them, and that is Parkinson disease, Shikina, Parkinson disease. So that's all. So movement is very, very difficult for them, and they have some attributes that we'll be looking for in questions. They must put those attributes there. If they don't put those attributes there, we are not going to agree that that question is actually about the Parkinson disease. One of them is about their gait, apart from the bradykinesia. Kinesia means movement. Brady means reduce movement. That's all. So rigidity, we are going to see rigidity. Then they have a particular attribute called resting tremor, that it will just be, their hand will just be shaking like this and likes. So they have a gait, you call it fascinating gait or shuffling gait. Shuffling gait is what USMLE, you'll be seeing them putting in question and the likes. And that's just a summary of it. We are still going to do it better later. Striker, if you are going to be a striker on the field, you must be able to hunt another player down. So striatal lesion or Tintin disease, you can look at it that way. It won't disappoint you. And there is something you will see in the question that will tell you this is Tintin. If you are going to be someone that wants to hunt another person down, you must be aggressive. Aggressiveness is a feature that when you put it at the back of your mind, it won't disappoint you. In nailing that question down to what do we call it, Huntington disease. Most especially when you can see that this patient is not on any substance. So this is Huntington disease. So once we are seeing aggressiveness and the like in question, we'll start thinking towards Huntington disease. Can you see how simple it is? Subthalamic is the one amidst all of them that we are going to be writing here that has H in it, letter H. And the condition that is associated with that is hemibalismus, contralateral hemibalismus. So they talk about hemibalismus. My brain should automatically say this one is starting with H, hemibalismus. Hemibalismus is just telling you that this patient might just be holding something, one limb, the thing will just fling off, and that's all. That same way I describe it, that is how most of the description will be. So we just start thinking that subthalamic nucleus is injured here. So internal capsule. Now there is something about internal capsule. I forgot to. No, I didn't forget. I started it yesterday, but the question we were supposed to solve yesterday was actually about the internal capsule. Now I needed to. I'm going to unravel something about it now. When you read the question, one thing about the internal capsule is that it can either be pure motor, pure uh, sensory. It's not really too common. Another thing you can see is just the combination of the two. We call it sensory motor deficit. So when you read the question and you just realize that everything you are seeing here is just uh, something like just motor, 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 is likely you are dealing with internal capsule. There are three levels of lesion you are going to be using to look at your neuro. Just three levels. The first level is around the cerebrum, all those cerebral hemisphere. Any lesion you see there is going to come with some cortical deficit. We call them cortical deficit. When we get there, I'm going to show you. So I'm just going to mention it now. The second level is at the internal capsule level. The internal capsule level, they can either be pure motor or sensory motor. Sometimes you can also have like sensory, depending on which limb of the internal capsule is affected. Just look at it like that. Keep it like that. Don't bother yourself much. The third level is at the brainstem. Anytime that one is involved, you will always see cranial nerve deficit in question. So you are reading this question, you are just saying, this patient is having weakness, is having this. You can also see cranial nerve 6, cranial nerve 7 is also involved. Just know you are dealing with brainstem. You read this question, they are telling you that this patient is this, but the patient is also having difficulty talking. The patient is also having maybe something relating to maybe the use of the hand, the use of the finger, or blah blah blah. Apart from weakness and the likes, you know, start thinking towards something like cerebral hemisphere. But you just start seeing only weakness, weakness, something related to pure motor. And you can't see any cortical deficit or anything there. You can't see cranial nerve. You start thinking towards internal capsule. So those are the three levels you will be using to look at the question, so that you can now be like, okay, this is about the brainstem. Cranial nerve. Which cranial nerve is this? Okay, this is the cranial nerve. Okay, this is the part of the brainstem. We are going to look at everyone very well. So I just want you to have an idea about the internal capsule. What about the lentiform nucleus? The lentiform nucleus is only related to, they are going to relate it, only going to relate it for you to something like this Wilson disease. When we get to psychiatry, we will be talking about other stuff. So Wilson disease and Shikina. So that is also called hepatolenticular degeneration. And what is causing that is copper abnormality, that abnormality abnormality of copper metabolism. So do you get, or you say pathology related to copper metabolism? So it's all about copper, and that's all. Shaking up. So now let us go through. Then, okay, in the pathway, I told you not to bother yourself with the pathway, and truly don't bother yourself with the pathway. Don't bother yourself. Forget it. Don't bother yourself at all. Just remember two things. One is about the neurotransmitter. You only talk about 2/3 basic neurotransmitter here. The dopamine and GABA, dopamine, GABA, dopamine, GABA, dopamine, GABA, or dopamine slash glutamate and GABA. Shikena. GABA is inhibitory. Dopamine is stimulatory. Glutamate is also stimulatory. So they may just ask you a question, just say, which of the following is a stimulatory neurotransmitter in the basal ganglia? The answer will just be dopamine. Which of the following is the inhibitory neurotransmitter in the basal ganglia? The answer will be GABA, Shikena. If you can pick that one, you are already okay. Don't bother yourself and this one. You are not a neurologist. The second important point you want to note is, in case they want to do any surgery, they are asking about the surgical procedure. So these are the two areas they always want to ablate. They always want to maybe do something on. Globus pallidus internus. You don't have so they don't really do surgery on globus pallidus externus. So please, internus, then subthalamic nucleus. So if you look at all of them, they look a bit in. Subthalamic nucleus is actually deeply in. Globus pallidus internus is also in. You can look at it that way if you wish. If it doesn't make sense to you, please ignore it and look at it any way you like. But don't forget these two structures. So if they talk about, okay, which area do you want to ablate, and you see that kind of question, you don't know what to choose, just remember that Festus mentioned that these are the two regions most of the time you see them asking procedure on. Any of them you see in the question, just pick it and go. Whether it's globus pallidus you see, please pick it. If it's subthalamic nucleus you see, pick it and go and forget about that question. You are more than 95% likely to be right. And that's all. So instead of you sitting down and start cramming the pathway, and that's just the question they will ask you. Why do you need to give yourself a headache? All right. So let's go through a few questions. Um, so I just wanted to pick your pen and paper so that you can analyze the question. So we've looked at this first one. The second one was the one we were looking at. So I want you to look at the second question again. A 62-year-old man comes to the office with left arm clumsiness. Physical examination reveal motor weakness involving the left arm and leg. So just motor weakness. The patient's speech is slurred. So likely the what do you call it? The muscle involved in the use of the like the tongue and the likes may also be involved. They are not saying that the patient cannot talk. Okay, so we are not dealing with aphasia here. Aphasia is a cortical deficit, it's a cortical manifestation. So the patient's speech is slurred. There is drooping of the left lower face. All right. On passive flexion of the uh, left arm, there is initial resistance followed by a sudden release of tension as flexion is continued. A lesion affecting which of the following brain structure is most likely responsible for this patient condition. All I can see in this question, even though you are seeing something that look like drooping of the face, that you might want to be thinking, okay, is this patient having something like look like what do you call it, the uh, facial nerve deficit or something like that. So let us just put that one aside. We have drooping of the face, and all the other stuff that we can see here, they are just what do you call it, motor manifestation. But the diagram they are giving you is all on basal ganglia. Let me show you the diagram again. Basal ganglia 1. So this is the diagram they are giving you here. So let me project it for you. They are just projecting this diagram. Everything about the diagram is about the basal ganglia. There is nothing cortical here, and we can't see anything brainstem here. So you don't even think about the cortical, you don't think about the brainstem. You start thinking towards these guys. That's all what they are telling you. So if you now look at that question, the only possible answer you have to that kind of question is going to be the internal capsule. If it's going to be the caudate nucleus, you already know how the patient will manifest. So this one is related to Huntington disease. If it's going to be related to putamen, it's also going to be related to Huntington disease. And this is your globus pallidus, lentiform nucleus altogether, is going to be related to something like, what do you call it, Wilson disease. Do you get it? Why this C is related to insula? This is more like the insula. And this one is related to what do you call it, all these cognitive function tools and the likes. So you don't group this option C as part of basal ganglia. Do you get it? So all the basal ganglia you have here are just these guys, your A, B, D, and E. So the only possible answer that you can have here is going to be B, and just pick your B and go, because you know how the option A is going to manifest, you know how option D is going to manifest. The same thing for option E. So the only one that look like whatsoever they are describing there is the internal capsule. All right.
Dr. Festus.
Yeah.
Yeah. So please, I'm not too sure why it's B.
Okay.
What did we say is
A is your caudate nucleus.
caudate nucleus? Okay, so that is out. What is D?
D is your putamen.
Okay, and then E.
This should be the globus pallidus internals.
Okay, but why the internal capsule for Parkinson?
Okay, that was a mistake yesterday. This does not, we can't see resting tremor. There is no resting tremor. There is no fascinating gait or shuffling gait. And there is no bradykinesia in this patient. The only thing they talk about is weakness. So maybe because all of us were tired anyway. So this cannot be about the Parkinson disease. Do you get my point, Dr. Franciwa?
So basically, what we are saying is that it's a pure motor lesion.
So pure motor lesion. This question look well, maybe because of the way they said the question anyway. But I just wanted to get my explanation and don't base my explanation on this question. Do you get it? I explained something there. Most of
Okay.
the internal capsule manifestation, because people make mistake with questions. Do you get it? These are questions that they frame out just to bring something out of it. Do you get it? Then I don't need to be perfect too. So most of these things they are more complex than the way we are trying to simplify them. Do you get it? That's actually where the what makes neuro. Do you get my point? So you just need to look for a way
Yeah.
to simplify the neuro for yourself. If you say you want to be looking at it in its complexity, you will be getting confused. Do you get it? So make it as
Yeah.
simple as possible for you. You don't need to be 100% perfect. All right. So this question is
Okay,
all
sure. Thank
about
you.
this basic. This is the diagram they are giving you. Which other options will best explain the manifestation you can see in the patient? The only option that explain this is this internal capsule, shaking. Pick it and go. All right. I don't want to be dragging this. Let us forget about this question and move on, please. So the next question, because we have a long way to go, and this is 72 pages we are going, we can't use one question to be holding us down. So let's go to the next one. This is another question. A 65-year-old man comes to the office due to, I hope I'm projecting that, okay. Comes to the office due to bothersome tremor. So this patient is just having tremor. I don't know the kind of tremor this patient is having. The patient was diagnosed with idiopathic Parkinson disease 10 years ago and has since been successfully treated with levodopa carbidopa. However, over the last several months, he has developed frequent freezing episode characterized by a sudden loss of mobility. This patient will just not be able to move. More recently, the patient tremor worsened after he reduced his levodopa dose following the development of involuntary body movement, the movement that he cannot even control. On examination, he has bilateral resting tremor that is worse on the right, bradykinesia, cogwheel rigidity. Can you see the way they are describing the Parkinson disease for you?
Yeah.
Yeah, they now tell you that his symptoms have significantly degraded his quality of life. This is someone they've been giving levodopa, carbidopa, which are great drugs. We are going to look at them for the treatment of Parkinson's disease. And he is now interested in discussing surgical options. Okay, you are now trying to do surgery. Okay, that's good. This patient will benefit most from a treatment targeted at suppressing neuronal activity in which of the following brain structure. We don't look at the pathway, and this is all about the pathway. I just gave you like a nugget. There are two areas they always want to do surgery on most of the time: the globus pallidus internals and the subthalamic nucleus. Just look at it. Which of them do I have in this question? Pick it and go. Shikina. Do you get it? So just pick any one of them you see. That's just the only thing I can tell you. All right. So don't give yourself any headache with that. So the answer there will just be subthalamic nucleus. Why are they
Doctor,
doing it? Don't bother yourself. So when you are done your pass, you can go and be looking at that. Let me show you another basal ganglia.
Doctor, Festus, I have a question. So the globus pallidus interna, is it in both tracts? Because you have it in both pathways.
So
The
we are not, see, we didn't look
globus
at any
interna.
pathway. I just gave you 2 points. Do you get it? So forget about the pathway and just look at them. Which of them am I seeing in the question? I didn't look at it, and I don't want you guys to be bringing complexity out of this thing. Just pick it like that. If I thought you want to go and dig deep into it, you can go and do that. because we just need to simplify this for ourselves and forget about it. They might not even
Okay.
ask you, do you get it? Yeah.
Mm-hmm.
So I'm going to project this basal ganglia to you. Then I'm going to read the question. Just pick your answer and let me know. So let me see. The question here is this. A 71-year-old man comes to the physician because of involuntary shaking and gait abnormality for the past year. He also reports depressed mood and diminished smell and taste. Examination shows a shuffling gait, resting tremor in the left hand, and rigidity in both hands. What's the diagnosis in that?
Parkinson disease.
Okay, so if it's Parkinson's disease, which part of the diagram do you think that lesion is?
B.
B. So what do you see in B?
Substantial nigra.
What do you see in it that makes it to look like substantial nigra?
It's
Looks
pigmented. It's
It's
pigmented.
pigmented, shikena. That's all. And these are the simple questions they are likely to be giving. Do you get it in the exam? All right. Let me see another question. Uh, you don't need to solve this. Yeah, another diagram. Okay, let me project another one for you. So see this question. A 62-year-old man is brought to the emergency department by his wife because she thinks he has had a stroke. He has hypertension and type 2 diabetes. Current medication include enalapril and metformin. He has smoked 1 pack of cigarette per day for the past 35 years. His blood pressure is 162/95. A CT scan of the brain shows a lacunar stroke involving the left subthalamic nucleus. Now, say the patient most likely presented with which of the following? How do you think a lesion in subthalamic nucleus will present?
Hemibalismus.
Just check
Bamismus.
your option and pick your hemibalismus and go. Because this one has letter H in it, the answer will be hemibalismus. Shikina. So don't give yourself headache. So look at something like this. I don't have this. I don't think I have this diagram. So let's look at this. By the time you are solving your question, you can go and bring out all manner of questions. Okay. It's like angle 4. So where is like angle 3? Sorry. Wait, let me check for this angle 3. So this is likely to be 3 then. This is likely to be 3. Okay. Okay, let me see what is in that beside angle 3. Sorry. Okay, let me just project this and let's see how the question look like. So they just give you something like, I think this one can definitely going to be from Ambrose. So let me read the question for you. You just make a guess about the answer. They tell you that a 62-year-old man is brought. No, not that. A 48-year-old man is brought to the emergency department by his wife because okay, well, I hope that's the diagram for the question. Anyway, a 48-year-old man is brought to the emergency department by his wife. Let us meet our mics, please. Because of sudden onset of slurred speech and left-sided weakness that began about an hour ago. His wife says the symptoms were preceded by progressive worsening headache and visual disturbance. He has a history of alcohol use disorder and has smoked 2 packs of cigarettes. His blood pressure is 12/10/92. He is only oriented to serve and has difficulty answering questions. A CT scan of the head without contrast shows a large hyperdense fluid collection in the right putamen. I think they are now asking you where is the putamen there. So which of them is the putamen in the diagram you are looking at?
Yes, that's
Which of this
okay.
diagram is the putamen?
See,
It looks like C, but I don't know.
it's not clear, but it looks like that.
See.
It looks like C. It's not really clear.
Which one is not? It's just a schematic diagram. Though I
Okay.
agree with you, this one does not look like my brain. It doesn't look like your brain. It doesn't look like anybody's brain. But they just drew this thing just to pass the information across. Do you get it? Definitely, this
Yes.
is C.
See.
Because what else are you going to say it is? Which other structure? So nothing else. Because this question is all about this. And immediately you see the question and where they are putting all the arrows, you already know definitely this is C. Putamen. We can only agree that this is putamen and move on. Abi, it can't be E. Do you get it? Because that does not look like a nucleus. Do you get it? So it's not. So the answer will definitely be C. I think that's the question. Let me project another image for you. I hope you are getting it, everyone. The way the question on Mr.
Yes.
Ganglion comes. Lovely. So see this question. Immediately you see this. This is actually another question. Do you get it? All right, let me read the question to your hearing just for you to have an idea of how they will look like. Um, sorry, I need to be going back and forth. Okay, they just tell you that a 65-year-old man is brought to the emergency department by his wife for the evaluation of suspected stroke. He has a history of chronic hypertension. The patient's wife reports that he is right-handed. A non-contrast CT scan of the brain shows an acute cerebral infarction. A photograph of a transfer section of the brain is shown to you. The area that is affected by the infarction is indicated by the arrow. Which area is that? Anyone?
Internal capsule.
Internal
Internal.
capsule. Lovely. Now, say this patient most likely presented with which of the following? How do you think someone with internal capsule will present?
Motor.
Motivation.
Motor. So,
Motor.
No.
Command.
Pure
lovely.
motor weakness.
Pure motor
Motor.
weakness or motor,
Command.
sensory and motor. So, anyhow.
Very much.
So, in fact, immediately you see if you are carried away by the story they will give you in the exam, you will not answer one question. In 10 minutes, you will be analyzing what you are not supposed to. Can you see all the story they wrote? The only question is, please, can you tell us if at all there is a lesion in internal capsule, how will the patient present? Shikena. That's just the question. So if you are carried away by their story, when you go in there and you now start analyzing their story, you are not likely to finish. You will get them right though, because when you read the question finish, you will eventually know that this is where the question is going to, but you are going to waste time. In 1 hour, you might just be on number 20 something. And out of those 20 something, let me say you've done 28. Out of the 28, you might get 0.28 or get 27 out of 28. But what about the remaining 12 questions? Whereas someone that is not carried away by the story, we finish the whole 40 in 1 hour. And out of the 40, the person may get 33 or 35, 33 or 34 right. Do you get it? Because those questions are very, very simple. So the answer is to that question is weakness of the right leg. Though I don't know why. So did they give you the side? Okay, this is the left, right? So then it's going to be on the right because you talk about crossing. Do you agree with that? Do you
Yeah.
agree with that? Though I've not
Yes.
mentioned it, but I know that one way or the other you've heard about that before. So if there is a lesion here, do you get it? Then the patient will be manifesting
That's
it on
good.
the right. All right. Okay, let's stop. I think we can stop questions of basal ganglia. So let's go to another aspect of neuro. So go back and solve some questions by yourself. That's just how simple their questions will be looking like. So no issue. Ah, okay. Question. Someone wanted to ask a question. You can go ahead.
Sorry, I'm very sorry, sir, to interrupt your
No
class.
problem.
Um, Increasingly,
Okay.
as I read each question, I see two answers stand out clearly to me.
Okay. Which one and which one?
Like, I'm giving an example. For example, this projection now, B and D will stand out to me, and I'll pick D. I don't know.
Which
It
question is
happens
that?
all the time. I'm giving an example.
Okay, when you read a
Yes,
simple question, right?
yes. So it's because you talked about overanalysis. I think that's my problem.
Don't
For
me.
example, this answer is B. To me now, B and D will stand out. I will think, and end up picking D. Increasingly,
Yeah.
that's sorry to interrupt
No,
us.
you are not. You are not. It's actually a problem that some people that overanalyze questions usually face. I used to have that problem before. So there are two sides to it. When you overanalyze questions, do you get it? You will be seeing you will be seeing some options that will look like the correct answer. So you are now going to be hooked on which one do I go for. Sometimes you may be lucky to pick the right one. Sometimes you may not be lucky, but you don't allow that one to discourage you. Do you get it? Anytime you see something like just pick one or two lessons there and be like, okay, this is why the B is wrong, why D is correct. Okay, just pick it and move on. Do you get it? Don't let that one break you down. It's something that is normal. That's how white guys set their questions. Most of the time when they give you 5 options, the 3 out of the 5 options will be completely wrong. Why 2? You will need one powerful point to separate them. That's how they are. All the white exam you are going to write. 3, if there are 4 options, 2 complete options will be completely wrong. That you'll be like, it can never be this, can never be this. But if you are not very careful, you may be hooked on is the answer between A or B. So you might need 1 or 2 clincher to just give it that and just go. Do you get it? So those clinchers are what we are just giving you. That we just make this one A and A. And not just giving you differential. It can also be A, it can also be B, it can also be C. Because if you go with all those differential into the exam, that's the problem you are going to be having. Do you get it? Do you get my point?
Yes,
Yeah.
thank you, sir. Thank you.
I feel like showing you this diagram for basal ganglia 5. So I don't know if it's there. Basal ganglia 5. Okay, I don't think it's there. Anyway, let us move on. So that's all about the basal ganglia, everybody. Don't be, don't worry at all. And that's all. We come down to another area. We call it cerebral cortex region. So this cerebral cortex, this one, they will ask you a lot of questions on it. And I want you to pay attention to it. It's not difficult at all. The first thing you want to do when you see brain like this is to first of all determine your direction. You want to determine, please pay attention to me, everyone. You want to determine your direction. So the direction, wherever this, your temporal lobe is pointing to, this is the temporal lobe. This one down here is the temporal lobe. This one that looks like someone's foot is the temporal lobe. So wherever it's pointing to, that is going to be your anterior. So definitely, based on this diagram, because I can see this one pointing in this direction, I already know that this is my anterior. Then this is my posterior. Someone is like, yes, what is so special about it? We're going to see some questions. Or they will just give you some diagram. When they give you the real brain and you don't check for that, you are going to miss the question. All right. The next thing you want to determine when you see the diagram is your central sulcus. Sulcus is just that indentation that deepening you see. That central sulcus usually span through. So you see it is extend from here. You will see it will go through. That's the second thing you want to determine. And the importance of that central sulcus is that anything anterior to it is regarded as motor. Most of the time, structures posterior to it is usually regarded as sensory. So if you read the question and the question is all about sensory loss, you will need to locate your central sulcus and go behind it. If you read the question and the question is about motor, you need to locate your central sulcus and go to its front. And that's all. That's why it is very, very important for you to note that. All right. Immediately immediately behind or after the central sulcus, the region you have there, we call this primary, you can call it primary sensory. Okay, they call it primary somatosensory. If somato is going to give you a headache, you can remove the somato there and just call it primary sensory area. But if you know you shall want to be as specific as the book, call it primary somatosensory. That's good. Why, if you go to its front, you are going to call that one primary motor area. This is primary motor area. Do you get it? So once we locate our our sulcus, central sulcus. Just go behind this primary sensory or primary somatosensory, come to its front, you are going to see primary motor. Now, we also have what we call somatosensory association cortex or sensory association cortex. Anyone that suits you, just simplify it for yourself. It's for you. So this somatosensory association is just behind the primary sensory area. Do you get it? Okay. So what if I thought there is a damage to this area? How will the patient present? The way the patient will present is, one, it depends on which parietal lobe, because these are all parietal lobes, which parietal lobe is involved. If the right parietal lobe is involved, the patient will have hemispatial neglect syndrome. Don't be bothered by the name of this syndrome. You can easily get it right. There is nothing quite peculiar about the name. Hemispatial. If a patient is having the hemispatial neglect syndrome and you ask that patient to draw a clock, this is the cycle. The patient, you draw the cycle for the patient and you ask the patient to put the numbers in the wall clock in that cycle. The patient will put all the numbers on one side: 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and come and put 11 here and neglect this other side. That is what you call hemispatial neglect syndrome. If you ask the patient to comb his hair, the patient will comb one side and forget about the other. If you ask the patient to wash a plate, the patient may wash one side of the plate and forget about the other. That is just how you look at it. Anything they look at, they will look at one side and forget about the other. And that is what we call the hemispatial neglect syndrome. When you see that in question, just know that the right parietal lobe is affected. Shikena. Well, how are you going to? it's just somehow anyway. Uh, I I I wanted to say something before I now realize I'm going to be wrong. I wanted to say that I would have said, why are you leaving the other? Why did you leave the other? Okay, mom, so person washed the plate and left the other side. And you also want to narrow it to the left, but that one will be wrong. This is about the right parietal lobe. Maybe you just look at it and be like, Shegun, you can't be right with this way you are drawing your work log. You can't be right. So this is right parietal lobe. Damage to the right parietal lobe will give hemispatial neglect syndrome. What about the left parietal lobe? It's going to give what you call the uh, Gerstmann syndrome. Gerstmann. Sorry, please give me. Sorry, 1 minute, please. Sorry, please. I needed to quickly reply someone. Okay. Sorry. So that's about the right. What about the left? We have what we call the Gerstmann syndrome. So this one has its own manifestation. A gravia, a calculea, finger agnosia, left, right, disorientation, blah, 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 and the like. So I will just try to explain each of them in a very simple way. A gravia, what this one is telling you is that these patients, they usually have problem to write. If you ask this patient to write, they won't really be able to write. But write in the sense that we usually, they use a term to qualify that writing spontaneously. That is, okay, I'm talking, you are writing, or you are just writing. But if you ask them to copy, they can copy someone else. But for them to write it by themselves, they can write it. So that's just a gravia. Then simple calculation, they can't do it. 1 plus 2, 2 plus 4, 5 plus 6, they can't do all the stuff. They have a calculia. Then there is something we call finger agnosia. What is that finger agnosia? If you ask them to name their own fingers, this is the little finger, this is the index finger, this is the ring finger, this is the middle finger, this is the thumb, blah. Just ask them to just name the finger. They cannot name the finger. Do you get it? So, and that is that about the finger agnosia. They don't even recognize them. And the last one is left to right disorientation. And what is this one all about? They don't know the difference between left and right. So all this, you see, say that the patient is having a damage to the left parietal lobe. That's Gerstmann syndrome. These guys do not really care about you knowing much about this. Just pick what you can pick there and just go. If you look at it, it deals with, okay, can I calculate? Can I recognize finger? Can I write spontaneously? Do I know the difference between left and right? So that's left parietal lobe damage, shaking up. Do you get it? They hardly test all these Gerstmann. They can put them, you may see them in book, one or two questions, but they hardly test them. Okay, that's just about this somatosensory association cortex. What about the, so we are done with this. What about the primary somatosensory cortex, this region? So if it's damaged, how do you think the patient will present? 2-point discrimination, they can't do that. If I take my two finger and I use my two fingers to touch you at the same time, just two fingers, your brain should be able to tell you that I'm using two fingers to touch you. Two fingers to touch you at the same time. The patient inability to do that is showing that they have problem with 2-point discrimination. Then we have this stereognosis, the ability to recognize things by just touching it. Do you get it? Just by touching it. If I touch a phone, my brain should be able to say this is a phone. If you just put like a letter, you write letter A, and maybe you use something to build letter A on the paper or something, like all those grades. So I should be able to touch it and be like, okay, this is letter A. If I touch a car, my brain should be able to say that this is a car. Their inability to do that, you call that stereognosis. Then extinction, inability to perceive multiple stimuli at the same time. If someone is blowing air, someone is talking, or there's just multiple stimuli coming to me, am I able to say that I felt this, I felt this, I felt this? So that shows that my primary somatosensory cortex is working very well. So if you look at this, it deals more with passive, passive, passive or recognize. So when you see something cannot recognize, cannot perceive, cannot recognize, cannot perceive, just say primarily the somatosensory area is damaged. Do you get it? Can't recognize number or letter. Trace on the palm. If I take their palm and trace, you use the back of your pen or the bottom of your pen to trace letter A and say, what letter did I write on your palm? You should use A. If they can do that, it shows that they have what you call, they've lost their graphesthesia. Do you get it? So tracing something and that's tracing is to send signal to the brain that this is what you trace. So we can just peg this primary P on perceive. Do you get it? So P, perceive, or sense. They can't sense anything. So whereas when you talk about the somatosensory association cortex, it deals more with this. Am I dealing with right parietal lobe or I'm dealing with left parietal lobe? Okay, let us just drop that one there. Let's ignore the sensory. Let's come down to the motor. Now I want you to pay attention. Most of your questions they are related to this motor area. That's where most of your questions will come from. So, okay. Primary motor area is just deals with you planning to carry out a particular motor. You want to pick your pen. The primary motor area needs to be activated to tell you that this is how you must do it. It's not going to send signal to the basal ganglia. That's when we now calculate everything. To what direction must you go? In how many centimeters must you move your hand and different kind of thing. But where the whole planning will start from will be the primary motor area. Okay. That's where it's going to start from. Let's come down to the frontal lobe primarily. I'm ignoring this premotor cortex. It's actually linked to that one. Let's come down to this frontal lobe. So with respect to this frontal lobe, we have what we call the frontal high field. So this one perform conjugate eye movement. So the ability to move the eye together on one side. So frontal high field. So this frontal high field part of the frontal lobe is also important in conjugate eye movement. That's enough for you to pick. Just ignore the rest. So if they say there is a lesion in the frontal high field part of the frontal lobe, you just realize that the whole eye will just deviate to one side. It's just going to deviate to one side, just going to be looking at one side. And most of the time, that side that is deviating to is usually the side of the lesion, shaking out. So if they say the whole eye, there is no lesion on the nerve supply to the lateral rectus, to the medial rectus, where the whole eye is just deviating to that side. How come? What is causing it? You start suspecting the frontal eye field. So probably there is a lesion. It might be a tumor in that particular hemisphere where that eye is just pointing to. So we come down to the prefrontal cortex. Prefrontal cortex help to mediate something like inhibition, orientation, good judgment, and elimination of primitive reflexes. If this prefrontal cortex is damaged, all what you will be seeing in question will be disinhibition, disorientation, poor judgment, then recurrence of primitive reflexes, shaking up. And that's all. So most of the babies have this prefrontal cortex not well developed. It's over time they develop their prefrontal cortex. That's why you see them in the bed where they don't care. You talk to them and be like, what is this? They still do whatsoever. You all manner of they are jumping from chair to chair. They may go to the TV and just be punching the TV. At least your brain should tell you that this thing can break. Their brain is not telling them the thing can break. They have poor judgment because their prefrontal cortex is just developing, shaking. So if you see something, the only term I want you to pick that will be helping you with prefrontal cortex lesion is this disinhibition. It will help you a lot. It will help you. When you read the question, you start seeing disinhibition. Disinhibition, I'm going on the road. I see a particular place where they are selling some stuffs. I enter and I'll bring out my genitalia and start urinating there. So how come I'm not saying that I'm pressed? If you are pressed, at least you should be able to hold it and leave this area. So if a patient is having that is disinhibition. You can also relate it to all manner of sexual harassment and the likes. So disinhibition. So that's all. So if you can note this disinhibition, it will help you with locating or narrowing the lesion to the prefrontal cortex. Now, we come to what you have all known very well. We call it Broca area, Wernicke area. Expect a lot of questions from these areas. Broca area, Wernicke area, and this arcuate fasciculus. So what is the Broca all about? I want to make a sound. I can talk. Do you get it? I can talk. I can say it. Do you get it? It's for production. So Broca area is working well. Okay, what about the Wernicke? If you talk, can I comprehend it? Can I talk fluently? Am I making sense? Do you get it? If at all I am talking, am I making sense? Do you get it? If at all I'm listening, can I comprehend what you are saying? That is for Wernicke. Please get my point. I can make a sound out. I can talk. It has nothing to do with whether it makes a lot of sense or it's not making. I can blow all manner of grammars and different kind of things. That is Broca. Do you get it? But when I talk, am I making sense? Do you get it? Am I making sense when I'm talking? That is Wernicke. If at all I listen to whatsoever you say to me and I can bring out meaningful points from it, it shows that my Wernicke is working. My Wernicke is working well. We now have the third one. We call it arcuate fasciculus. Can I repeat after you? You talk to me, you say, Festus, can you say somatosensory? And I can repeat it the same way, somatosensory. It shows that my arcuate fasciculus is doing well. Why do you peg it on arcuate? Arcuate fasciculus is like a wire that connects the Broca to the Wernicke. So for me to be able to repeat the same way you say it, it shows that that connection is really working well. Do you get it? It's working perfectly well. I can hear you very well. I understand how the sound should be made, and I'm making the same thing. So if the arcuate fasciculus is damaged, the patient will not be able to repeat the way you expect the patient to repeat it, shaking. So problem with repetition, you peg it on arcuate. You are reading this beautiful question, you ask the patient to say potato, he's saying poraro or parrot or something. You just say the arcuate fasciculus is damaged. You ask the patient, and they will have excluded ear problem in the patient. This patient is not having problem with hair, he's not having ear wax, he can hear very well. So this is all about the brain. So you just peg it on Aquate. Do you get it? So the question is all about the patient cannot talk at all. That's broker. The question is all about the patient is having problem comprehending. You peg it on Wernicke, shaken up. Now, we have different types of aphasia. We have what we call the broca aphasia. What is broca aphasia? Broca aphasia is just telling you that the broca region is affected. There is something about it. If you say broca region is affected, so most of the time when you hear the word that broca, it's usually the whole broca like this. Everything about broca. And if you look at this diagram very well, you will see the wire, the aquifasciculus, enter into the broca. So that one is also damaged. So broca aphasia, most of the time we present with inability to talk, to make sound very well. Sometimes too, they also have problem with repetition in one way or the other. They may just put it somehow, just like that, just put it somehow there, like that. So they will not really be able to talk very well. Sometimes they talk, the thing is just that they can't really talk the way you expect them to talk. The broca area, just start thinking towards broca aphasia. Okay, so it's going to affect the broca area and the aquate. If we come to Wernicke aphasia too, Wernicke will also affect the Wernicke and also affect this wire that is entering into it. So most of the time you see problem with repetition in broca aphasia, Wernicke aphasia. So if you now want to peg it on only the broca itself, no aquate fasciculus is involved. You want to peg it on only the Wernicke, no aquate fasciculus is involved, they give it another name. And the name they give that one is what we call, am I dealing with motor area or I'm dealing with sensory area? So if you say that broca is for production, that is for motor, then we call that, they call it transcortical motor aphasia. Transcortical motor aphasia is only the broca, aquate is not there. Transcortical sensory aphasia is only the Wernicke, aquate is not there. Shaken up. So you can easily name it by yourself. And if I thought it's going to be giving you a headache, please ignore it. Do you get it? So, but these are the aphasia, kind of aphasia you are going to be seeing in question. When you read the question and you can see the aquate is involved, the broca, his production is also impaired, you start thinking towards broca aphasia. You realize that aquate is involved. There is also problem with comprehension. You say Wernicke aphasia. Then you see purely comprehension. You just call that transcortical sensory aphasia. Purely production, transcortical motor aphasia, shaken up. And that's all about all the aphasia they will be giving you. Wow. Do you get my point, everyone?
Yes. Dr. First, you said is transcortical sensory is broca.
I didn't say transcortical sensory. Transcortical sensory is for Wernicke. That's what I said.
Well, that's what I wanted. Okay, sensory motor is broca.
Exactly.
Okay, thank you.
That's for all those transcortical. So when you are reading the question, it might take by the time we solve all the questions I have, I will try to solve all of them with you. I hope that you'll be able to get very thorough clarity to how the questions will be given to you. Do you get it? So when we are in summary, when you start seeing conjugate inability to perform conjugate eye movement, you start thinking towards frontal eye field. Then you start, if there is disinhibition, you start thinking towards prefrontal cortex, problem with speech production, broca area, comprehension, Wernicke, inability to repeat, aquate fasciculus. So that's just about that. Now let me come to this occipital lobe first. We have what we call primary visual cortex. One thing about
Pastor, sorry. Is it because of where their location is? That is why we are pinning them to sensory and motor.
sensory means they are receiving. This one is they are producing. You produce is motor. You receive is sensory.
Okay.
All right. So primary visual cortex. I want you to get the gist behind the primary visual cortex so that when you see it in question, you can easily identify it. You just need to integrate it to the daily activity. If you don't do that, you have a lot of things to cram and you won't remember most of them. Just imagine someone sitting before you. The person is seeing, is clear. No, what do we call that stuff? This corneal opacity. In the lens opacity, what do we call it? No cataract, no cataract, nothing. Everything is clear. You even take your light to shine it on the light on the eyes. Everything, the pupillary constriction, everything is awesome. You now ask this patient, please, can you pass me the cup before you? And the person is taking the hand somewhere else, cannot even just the person just speak like come. There is a cup, there is a plate. Let me say, there is a cup, there is a plate. The person now touch the plate and now passing you the plate. You are like, wow, can't you see that this is not a cup? They will still be arguing with you that, wow, this is a cup now. This is a cup. The thing about it is this: they can't see, but everything about the eyes is good, but they will still be arguing that they can see. At that moment, you know that they have primary visual cortex problem. That argument, you know, you are not seeing. Agree. So if it's just the eye, the primary visual cortex is good. Their brain will tell them that, no, sir, doctor, I can see. But these guys cannot see, and they will still be pretending like they are seeing. That is when you nail the diagnosis on primary visual cortex. Never make the mistake of thinking otherwise. They are not
But
saying.
please, can you? Okay.
Yeah, say what you want to say.
Yeah, I was saying just come again with the primary
Okay,
visual cortex.
they are not. The thing about the primary visual cortex is that it's all about vision. So they will paint the scenario in the question for you that this patient is not seeing. Do you get it? Everything about the eyes will be very good. Talk about everything. The pupillary, the consensual, the direct, everything will be good. There is no corneal opacity. There is no corneal opacity. There is no lens opacity. Everything is awesome. When you ask them to, the question may say that they bumps onto objects. They will not agree with you that they are the one not seeing those objects. They will say that they are just the one arranging them anyhow on the floor. Do you get it? That they are seeing, at least I know where I'm going. How come you arrange them on the floor? They will not agree that they are the one not seeing. At that moment, you peg the diagnosis of primary visual cortex, not the, don't think about any nerves. It is the cortex, because they are not seeing, but they are still arguing. So that's that about that area. Let's leave that. Primary auditory cortex too is going to also look like that. So just something similar. You just see them arguing with you. Then this is your limbic area. So just for you to have an idea. Okay, I think that's okay about the cerebral cortex region. So let us go through questions just for
Sorry,
us to have.
you said primary auditory cortex is the same thing?
It's also going to look the same. I'm not talking, this is auditory, it's about hearing. They are not
Okay.
hearing, but they pretend that they are hearing.
Yeah, hearing. Okay.
Everything about the auditory canal, the middle, the inner, everything is okay. Inner ear, middle ear, outer ear, everything is okay. So they will just be pretending that they are hearing. So that pretense is all what you will see that will give it out. That's a powerful point. Okay. So let us just go through few questions. So I will be flipping through the diagram and the question for you till everything stays better with you. Okay, before I solve question, there is one more thing I need to let you know about the broker. Where the broker is located. So it's just more like around the lowermost part of the frontal lobe. Do you get it? Just the inferior part of the frontal lobe. So that's another point. In case you see that, you don't ask where is it located. Is there another point here I've left out? Okay, when we read the question, we have an idea. So the question we see that we are not supposed to solve, I will tell you that we are not solving it now. Okay, a 54-year-old man is brought to you by his daughter. She says that her father has been acting strangely over the past 2 years. He makes inappropriate sexual jokes, has little regard for social rules, is often irritable, and is borderline aggressive at times. Just borderline. So the patient denies that his personality is any different from normal. So when speaking with the patient, the physician noticed that he has minimal verbal output and repeats, it is what it is. It is what it is when asked questions about his strange behavior. On physical examination, he appears unkempt but otherwise has no significant finding. And that's all what you are going to be saying. Question: the patient most likely has a condition that predominantly involve which of the following structure. Now, if you look at this now, this patient is having something that like all this aggressiveness, then no regard for societal role, making inappropriate sexual jokes. That is this inappropriate sexual jokes. Now, which category do you want to peg it?
Disinhibition.
Disinhibition. So there is definitely something related to that prefrontal cortex in this question. Are you getting my point, everybody? You already just know that there is prefrontal cortex is involved in this question. If you like, you can use that alone and just go through the other options. Just one point that you've already mastered. Just go through the other points. You are like, okay, is there any other one that's also having prefrontal cortex here? You can't see anyone. Just pick your answer. Just pick that one and leave. Don't overanalyze the question. Okay, let us assume that there are still some other options that also have this, what do you call it? That's also having this prefrontal cortex there. So you now need to look for the other things they put in the question and peg it on one of them. So let us say this. This patient, when speaking with the patient, the physician notices that he has minimal verbal output. This person talks actually, but just very little. And when you ask them, when you ask this patient any question, this patient will just be saying, it is what it is. It is what it is. It is what it is. What do you mean by it is what it is? So this patient repeating it is what it is, you can peg that, just saying it is what it is, you can peg it on this, also on the prefrontal cortex. The ability to, like, the patient is having poor judgment. So you can look at it that way. Do you get it? Poor judgment on questions that you are asking. Because the patient is saying it is what it is what it is. We are not sure, is the patient understanding the question or just saying whatsoever the patient likes and all manner of stuff. You can just peg it on it. Do you get it? So that's just that one about it. So you can't really say it is about Wenike. You can say it is about Akwit. You can say this is all about broker, because they are not telling you that this patient cannot talk, or they are not telling you that this patient not talking much is as a result of lesion to the broca area. We can't categorically nail it on it, even though it may be the problem the patient is having, but you can't really stick out your neck, and that's actually what makes. So you just need to simplify it for yourself. So for this question now, the only one, the option you are going to go for is just this here. Based on, you can see that this patient is making inappropriate sexual joke, disinhibition, and you peg all the other symptoms and signs they can pick in this patient. Just peg them on them and just move. This cannot be on anything about all these basal ganglia and the likes, because the question has nothing to do about basal ganglia. So this is all about the cortex. So let us see another question and look at it. So they are giving you a diagram here. I'm going to put the diagram forward to you. I'll now read the question to you. Don't overanalyze the question I'm going to be giving you. Just look at it in a very simple way and pick your answer. So, sorry. Wow. So we have a lot of diagrams to look at in the cerebral cortex. Just be ready. So you have this kind of diagram in exam. This is the diagram they are giving you. Just gave you this diagram. What is the first thing you want to do when you see this kind of diagram?
Look at the temporal part if it is an anterior.
Definitely, this is our anterior. This is going to be our what? Our posterior. Right? So what's the next thing you want to check for? You want to look for?
The central sulcus.
So which one do you think is likely to be our recentral sulcus here?
Between C and D.
So between C and what?
D.
And D. So definitely this is likely to be. This is not the real brain. So you can just look at it like this. At least this one still makes sense. All right. So we already have an idea of what we are dealing with. Let me now read the question to your hearing. If at all we are making mistake, we'll be able to see. All right. So just pay attention to the question, everyone. They are telling you here that a 55-year-old right-handed man, I'll tell you something about the handedness. Right-handed man comes to the emergency department due to persistent right arm tingling and numbness for the past several hours. The patient has no headache, muscle weakness, slow speech, difficulty ambulating, nothing of them. It's just all this tingling and numbness. He has a history of hypertension, paroxysmal atrial fibrillation, ischemic stroke without residual symptom. Anticoagulant was discontinued 2 months ago after he developed a gastrointestinal hemorrhage. Now say blood pressure is what 150/90, pulse is 92 and regular. Why patient is being evaluated? His right arm paresthesia spread to the entire right side of the body and he developed right-sided confusion. Now tell you that followed by a bilateral tonic-clonic seizure, which of the structure in the left cerebral hemisphere is the most likely site of origin of this patient's seizure. So where do you think this patient's seizure is starting from? Anyone?
C.
Okay, you are saying C. Everything after the of the central your central sulcus is called what? Is it sensory?
Motor.
So everything behind it should be sensory. So D should be where the seizure is starting from. That's where it started from and now spread to the other area. That question is very logical. The reason why I say it's logical is that you don't understand the meaning of seizure. That's why you answer that question like that. So when you talk about seizure, you can have the motor, you can have sensory, you can have all manner of stuff. The one you are pegging it on is just about the what do you call it? You are just pegging it on motor alone. Do you get it? It can also be related to the autonomic. It can be related to anything. Do you get it? So this patient was initially having something related to sensory, just having the tingling sensation and numbness. Later it spread to the other area. And all those other areas now start manifesting their own attribute. So when it got to the motor, the patient started having motor manifestation. Do you get it? So
Yes.
that's how you look at it. That's just what the question is talking about. So if you don't know how to identify your central sulcus, you will not be able to know that the answer will be D. You are going to be picking another thing entirely. Do you get it? So just note that one very well. Do you get the point, everybody?
Yes.
Yeah. Is anyone not getting it? The yes
No, it's
is clear. Okay. The yes is looking anemic. So let us see another question. Okay, I will just be showing you the diagram if I thought so that I won't be flipping to and fro. So this is the second diagram. Sorry, you just need to go through all this question for you to master it very well. So I don't want you to look at it like you are wasting your time. So this is another diagram now. They give you something like this in question. Just be looking at the diagram and tell me your answer. They just say a 54-year-old man is brought to the emergency department by his wife after he developed difficulty speaking. When asked about the offset of his symptom, the patient slowly responds with "I, weak, money," and become very frustrated. His wife says that he was able to grasp a pen without any problem while completing medical release forms, but had trouble signing his name, cannot sign. On examination, he is able to state his first name, but with difficulty, and correctly point to different body parts on demand. All right. He also has mild weakness involving his right arm and face. The patient's speech difficulty are most likely caused by a lesion affecting which of the following brain area? So which area are you thinking about? Speech.
B.
B.
What do you mean by B? Which area is B?
The bronchial area.
Bronchi area. You just pick your B and you go. Very easy. So if you pay attention to now start saying, why is the patient signing? Why is the patient not doing this? Why is the patient not doing that? You will start be over-analyzing the question. You don't need to do so. Just read the question briefly. Go to where one day wants you to pick it and go. This E is likely to be what?
Renegade.
The F is likely to be what?
Primary visual.
All right.
Primary visual
Okay.
cortex.
So let me read another question to your hearing. Okay, I'm coming. Okay, lovely. Let me ask you this. Okay, let me project this question to you. Sorry, you just need to be exposed to as many questions as possible in neuro to master it. See this question. A 62-year-old man comes to the office with his wife due to the behavioral changes. The patient was becoming increasingly impulsive and irritable over the past 1 to 2 years. He recently lost his job after making inappropriate comments and touching female co-workers. Now say the patient has also lost interest in his hobbies and appear withdrawn during social gathering. His other medical problems are hypotension and hyperlipidemia. A thorough neuropsychological assessment is conducted. Inability to perform which of the following will be most. So, based on this question, which area do you think the patient is having lesion?
The prefrontal.
Do you all agree with prefrontal cortex, everybody?
Yes.
Yes.
Okay.
Yes.
Wow. Doctor, only 3 people agree. So, do you all agree? Just to be sure, so I don't break my
Yes.
Yes, we
Yes,
agree.
we
All right,
agree.
well done. Just for me to be sure that you've gotten it. Okay, if that is prefrontal cortex, now what are you looking for? What are you actually looking for in the options? Let us list them.
Poor judgment.
Poor judgment,
Disinhibition, poor judgment,
disorientation.
Orientation.
Oh man,
reflex.
so you already have an idea. Look at this. They now say that, let us start from here. Recognizing familiar faces. Does it have anything to do with what do you call it? Does it
No,
have anything to do with
no, no.
so what do you think this one is likely to be related to?
That's have to do with
Right.
the
That's the
occipital
visual,
lobe.
primary visual
Temporal
cortex.
lobe.
Okay, that's very correct.
Recognizing familiar
Somatosensory. No. Recognizing.
Recognizing is
Recognizing us,
memory.
That
not
primary
seeing.
visual, primary visual cortex.
Yeah, that's occipital, Abby.
Recognizing
Yeah.
familiar faces. It's not that maybe the person cannot see.
Yeah.
Do you get it?
Oh,
That would be
that's going to be
primary
the
visual cortex.
Temporal lobe.
right parental lobe lesion.
Okay, this is actually likely to be related to something related to what do you
Temporal
call it?
lobe.
All this somatosensory area, or those primary sensory, because this is actually recognizing. It's not about this patient cannot see them. Person can see them, but cannot just place their face somehow. Well, let's just put that aside. Identifying which fingers is touched. So which one is this area?
Agnosia. That's
Frontal eye
left
field.
If if I
left
should
left
No. Primary somatos.
identifying which
somatosensorial
finger,
system.
identifying
Somatos
which finger is touched. Which finger? I
It's
was
left parental.
is
Left
left
parental
parietal lobe.
lobe lesion.
okay. The
Somatosensory
area.
association.
So the answer is just somatosensory association cortex.
Somatosensory area. Yeah,
Do you get it?
left
That's what you call finger agnosia. I explained it.
agnosia.
So I was saying if I touch the little finger, they will be able to say, okay, this is little finger, this is ring finger, this is middle finger, this is index finger, and this is the thumb. Their inability to say that shows that that's somatosensory. I jokingly say something before. Perceive. You can look at this one as perceive. The ability to, when you touch them, they will be able to say 2 points are touching me. They can recognize an object only through touch. So that is stereognosis. They are actually far more than this. Do you get it? They can perceive multiple stimuli at the same time. Extinction, blah blah blah. So that's just primary somatosensory cortex. However, when you come to the association, that's when you talk about that Jesma syndrome. But USMLE hardly asks you what is the syndrome here. It's not about it. It's not a syndromic exam. They can put all these things in question and just ask you, where do you think the lesion is? Just say, okay, this is left parietal lobe, a graveyard. They can copy another person, but they cannot write spontaneously. Acaculia, they cannot do simple arithmetic. 1 plus 2, 2 plus 4, 3 plus 6, they can't do that. Finger agnosia, if you touch their finger, they don't know which one you are touching. Right to left disorientation. Which of these, where is your right? Where is your left? They don't know. They don't know all those right and left. Difference between right and left. So that is just for this damage to the left parietal. However, for the hemispatial neglect syndrome, which is pegged on damage to the right parietal lobe, you will just see that they neglect the contralateral side of the wall. Anything they see, they neglect the other side. Do you get it? So that's just what you just need to pick. Do you get my point? So now look at this differentiating between right and left. Where is that one? Lesion to which area is that?
That's also primary
Primary
sensory,
somatosensory and sensory.
but affecting the right
Primary
frontal lobe.
Association cortex.
Okay, well, let me just be telling you what it look like. So this is looking more like somatosensory association cortex. Do you get it? So
was
that's
primary
for this.
somatosensory.
So that's actually
Differentiating.
somatosensory association cortex. So that's for this thing. Then comprehending the meaning of a sentence. So what do you think is likely to be? That's likely to be Wernicke. Do you agree with me? Yeah. So
Yes.
now
Yeah.
describing the similarity between watch and ruler. I give
Oh,
you a watch and I give the patient a ruler. I just say, okay, oh yeah, can you just tell me?
Primary somatosensory.
It has to do with judgment.
That is judgment.
No, that's
So this is judgment.
that have to do with judgment.
This is what we call judgment. I ask you, what's the difference between a car and a bicycle? The brain should be able to say that, okay, car has 4 tires, bicycle has 2 tires. Then car is likely to can carry more passengers. Bicycle cannot carry more than 2, at least. Then car can move faster, bicycle cannot. That is what you call judgment. In abroad, if you want to get to some top this thing, your judgment is what they test. Most of their the exam they are going to give you test your judgment. They may ask you a question and be like, if you are made the head of a department, a particular your department went for a competition, and okay, let me say you send someone for a competition and the person won the competition. The following year, who are you going to send? They want to see your judgment. It is that your judgment they will use to give you the role. They don't really care, because some people are very intelligent, but they have poor judgment. They are going to wreck the company. So you need that good judgment. So that's all what they look for. So this is judgment. It's describing similarities between watch and ruler, because you are not giving them, oh yeah, touch it, oh yeah, touch the ruler, oh yeah, touch this. No, that's not what. You just ask them as a question. Can you tell us the similarities between a watch and a ruler? 2 of them are used for measurement. One is measuring time, the other one is measuring length. Do you get it? So that's just how you look at it. So the answer is just B. That's just how you'll be looking at the question. That's judgment. All right, look at this question, cerebral cortex 3. I want you to answer all the questions on cerebral cortex. So sorry, I just need to do that for you. I will be glad if you do that, because I will know you've mastered it. There are some questions that are there that I may eventually ignore and just tell you that don't worry about this question, because they may just look a bit complex, either the way they frame the question or the question. Just tell you don't bother yourself. Okay, that's just the diagram. I want you to be looking at the diagram while I read the question to your hearing. Cortex 3. They ask you in this question, just say a 62-year-old man with hypertension and atrial fibrillation is brought to the emergency department because of sudden onset visual changes. Now say he stopped taking all his medication 2 months ago. Blood pressure is 170/90, pulse is 108. He is alert oriented to person but does not follow command. His speech is fluent with normal cadence, but he uses frequent non-existent words, and the content of his speech is nonsensical. When you see that this patient talk very well, but majority of what he is saying they are rubbish, where do you think that lesion is likely to be?
Wernicke.
Okay.
So if it's Wernicke, where do you think is more likely to be Wernicke?
It's going to be more towards the sensory side.
The temporal lobe.
Should be around the.
Let me
Around
read
the
the question
temporal.
first. Let me read the question. He appears unaware of his speech impairment. Do you get it? Speech impairment. That's one thing about most of the cortical stuff. He is unable to read a text out loud. Peripheral vision is diminished in the right upper visual field bilaterally. This patient's presentation is most consistent with injury to which of the following labeled area?
Maybe mammalian bodies.
What is in the question that is telling you that this should be mammillary body? Eh? Is there anything in the question telling you that this should be about the mammillary body?
It's
So we broke our face here.
temporal area.
So, well, the thing about this question is that, let me look at the diagram for you. Give me one. Let me close down some pictures here. 1 minute, please. So that we'll be able to open new ones. The thing is filled up. Okay. So where is your Wernicke area in this diagram?
Thinking of C.
Okay. So this is the Wernicke area, right? You are thinking this is the Wernicke area. This is your insula. Okay. Your Wernicke area is supposed to be around this region. Do you get it? So
E.
all I want you to do,
Yes.
all I want you to do is to draw this like this. Just draw this line. So is your Wernicke area below this line or above the line?
It's
Below.
below.
It's
So
below.
now what we are going to do is to now come to this diagram. Your Wernicke area is likely to be around this region. Do you get it? It may extend. Don't forget that these are just diagrams. The way it is in the real brain, you don't know. So these are just diagrams. The only answer you can pick here is just this area. Option B, not option C. Do you get
So
this?
it's like splitting it open.
It's like you are splitting it up. So this is like, don't mind the way I am drawing this line. The line might not be as long as that. Do you get me? My line might just be here. The thing might just be like this. This might just be the line. Do you get me? And this place will just be your Wernicke, while this place is just going to be your Broca.
Broke.
Do you get it? And you now have your arcuate fasciculus connecting them. But this question, Wernicke is affected, some other area are also affected. That is typical of what do you call it? It's typical of cortical lesions. Do you get it? It's not just going to be one area you will see in the question, but you just need one of the major area that will just tell you that this is the region. You cannot have a lesion here and they will be talking about inability to comprehend, and you will be thinking that then the lesion must definitely be here. The lesion might be here and the thing might have taken over so many regions here. Only God knows what the kind of lesion the patient is having. So don't give yourself headache. This one where you are seeing Wernicke, the patient is having inability to comprehend. You already know that definitely this region is part of what is affected. Shike, now you just pick your answer and you go. Do you get my point, everyone?
Yes.
Yes.
Which option do you want to go and pick? You want to go and pick C. That's your, it has nothing to do with Wernicke. Do you get my point, please? So your Wernicke is just, sometimes you may see some question that, sorry, let me remove this. You may see some question that what they will just be describing to you will just be like the Wernicke is just around this area, like around the angle there. That might just be what they will be describing. But just know that this is the region of your Wernicke. You don't need to be too specific. Do you get it? Pick your answer and go. Leave the rest when you start your residency in Europe. Shekina. Do you get it? So we are not opening the real brain here. Only God knows how the real brain look like when you open the Wernicke. Do you get it? But just for you to have an idea of how you think with respect to question. All right, let me show you another diagram. Cortex. Okay, let me read this question to you. Just listen to it and pick your answer. A 54-year-old man with hypertension and congenital blindness comes to the physician because he is unable to recognize objects by touching with his right hand. Cannot just recognize by just touching. The symptoms started about 2 hours ago when given a house key. He can feel the object in his right hand, but is unable to identify. Which area do you think is affected?
Primary somatosensory.
Primary somatosensory. Does anyone have any contrary opinion here?
No.
All right. So this patient condition is most likely caused by a lesion to which of the following location? Now see, A, ipsilateral inferior frontal gyrus. Ipsilateral inferior frontal gyrus. Then ipsilateral superior temporal gyrus. So is this lesion the primary somatosensory area? Where is it located? Is it in frontal lobe? Is it in temporal lobe or parietal lobe?
Front,
Parietal.
Is where?
prefrontal gyrus or what? That's where it's located. No,
No.
post gyri or something.
We're talking about the
Behind the
parental,
gyri is the parietal.
parental lesion.
The
Is the
parental lobe.
parietal
Is
lobe.
parental lobe.
Okay, don't let us be confabulating.
Parental lobe. Go
So
circle.
if no, it's
Go
true.
circle.
I feel bad here that
No, it's
we
don't
can
feel
still
bad.
be
We
saying
are good.
that no, it's actually the truth. So if you don't know it, just assume that probably maybe you don't know it, because I feel bad that we are saying this one is located here, there, and like. So this is, and I said something here that this is the frontal lobe. Now let us look at the frontal lobe here. I was saying it though. Now let us look at the frontal lobe here. These are your own frontal lobe. All this region here, they are just for the parietal lobes. So this one has nothing to do with the whatsoever we are describing has nothing
You're
to do with the
projecting
frontal lobe.
the picture.
What do you say?
You're still projecting the other,
Eh,
or you
sorry,
just
sorry.
yeah.
Let me
Thank
remove
you.
that.
First one. I think that's what the confusion was.
There is nothing that's where the confusion was. This is the same
Doctor.
diagram. Do you get it? Please let us just mute all our minds. This is the frontal lobe. Do you get it? Just this region like this. Something like this. You can look at this as your frontal lobe. This is going to be your parietal lobe. While this is your occipital lobe, then this will be your temporal lobe. So your primary motor area, you peg it on the frontal lobe. Your primary somatosensory area, you peg it on your parietal lobe. All right. So probably maybe I was the one that didn't make that point before, but just note that now in case, so that you don't make that same mistake again. So let me show you the same question again. A 54-year-old man with hypertension and congenital blindness comes to the physician because he is unable to recognize objects by touch. So you already know this is definitely primary somatosensory area, Shikina. The symptoms started about 2 hours ago. When given a house key, he can feel the object in his right hand, but is unable to identify it. And that's what I explained to you. The patient's condition is most likely caused by a lesion to which of the following? Where is now your primary somatosensory area located? So it's actually in the parietal
Superior.
lobe. Do you get it?
Yeah.
Parietal lobe. So even if you don't know which exact part it is, then definitely this is going to be the contralateral superior parietal. Just pick your answer and just go. That's the only answer that fits into whatsoever little knowledge you have. So you can't, because we did not sit down and say this area is in this one. That one is in temporal gyrus or superior temporal gyrus. These are the stuffs that make the USMLE very complex. You don't need to put all those stuff. You should be able to extrapolate. Do you get it? You only need the skeleton. You go and fill in the gap. When you get into, you see question, just be like, this is likely to be the answer. And you get it and you get it right. Do you get it? If I come now, I list all these things for you. Some people will sit there and start cramming them. When you cram them, you are likely to forget them. So you don't need to start doing a contralateral superior parietal lobe. And that's the answer. You just pick it and go. So if this
Please,
question is, I'm
Dr.
coming. So if
Festus,
I'm coming,
please.
please. If this question is all about, please let me be lying so that I won't be missing the information up. So it will
Okay,
also
I'm sorry.
help. So if this question is all about what do you call it? The premotor area, or just just something related to the motor. So, this one is likely going to be the correct answer. Something like this option D. Do you get it? So that's that about that. Then ipsilateral inferior frontal gyrus. This is likely to be related to the Broca area, something like that. Do you get it? I'm not talking about the ipsilateral now. I'm just making reference to this inferior frontal gyrus. Do you get it? If I thought they talk about any, what do you call it? Any area in that kind of this region, I will be thinking towards something related to the Broca, because you see it at the inferior part of the frontal lobe. So I will just be thinking, I hope this is not what they are trying to test here. Then one thing about all those Broca area, Wernicke area again is that you see those areas in the dominant hemisphere. Now, how do you determine your dominant hemisphere in question? Your dominant hemisphere is you peg it, you use the patient right handedness to determine it. Someone that is right-handed, the dominant hemisphere is the left hemisphere. Someone that is left-handed, the dominant hemisphere is the right cerebral hemisphere. So it's just interchanging. So if they tell you that this patient is right-handed, then the Broca area will be on the left cerebral hemisphere. The Wernicke also is going to be related to the left cerebral hemisphere. If they tell you this patient is left-handed, the Broca area will be on the right cerebral hemisphere, and the Wernicke area is also going to be on the right cerebral hemisphere. So in case they are using handedness to test this area, that is just the logic you are going to use. Do you get it? Okay, Dr. Lawrence, you wanted to ask a question?
Yes, sir. It's just about the question you asked us before this last one. I was able to understand from the orientation, excuse me, um, the frontal plane, that's what we use when we are, when you slice, what's it called? The anterior and posterior, when you slice it into two, that's what we actually use to understand the basal ganglion structure. But now using it to identify the Wernicke area is what I'm still a little bit lost when it comes to the orientation.
Okay,
You understand what I'm saying?
I think so you are talking about that
The question I said you
sagittal plane.
shouldn't remove. Yes, the plane that we use for the basal
Yes,
ganglia is
yes,
like slicing the brain,
yes.
uh, yes, into two. But how to now know after it had been sliced where the Wernicke structure is? You were saying it is likely, I think E, is that thing I'm still a
There
little
is
bit,
a fissure here.
yes,
Can you see it here? So you can see this separation here, this line.
yeah,
We call it the
yeah.
Sylvian fissure. All right. So there is a fissure here. If you cut this brain like this, do
Mm-hmm.
you get my point? So what you are
Yeah.
going to have is you will have a line, something that will look like this, that will look like this, something that will look like this. This is just something that you are likely going to have. This
Yeah.
severe fissure is actually this one, this
Oh,
that
okay.
here. So anything that's going to be below it, we will be relating it to, okay, something below it, then something
Oh,
above it will relate to that. So just for you to have an idea, do you get my point? Just for you to
yes.
have an idea. So
Thank you.
let me stop the question. Okay. Is someone else having question?
Yes, sorry, Dr. Festus, to drag you back. I just wanted to clarify. You said if the patient is left-handed and the broker and the Wernicke will be at the right. Is that correct?
Okay. The handedness, you correlate it to the dominant hemisphere. So dominant hemisphere is where you see these areas.
Hmm.
So
Okay.
if someone is now left-handed, the dominant hemisphere will be the right cerebral hemisphere, and that's where you will see the area. What of
Okay.
if the patient is left-handed? The dominant hemisphere is going to be on the right, and that's where you see the area. If the patient is right-handed, the dominant hemisphere is going to be on the left, and that's where you see the area.
All right. Thank you.
Right. So I want you all to pay attention so that you can. So this cerebral cortex 4. So see this. Okay. Sorry. This thing that will just be dragging someone's back is somehow. So this is the what am I still showing you? Sorry. I want to show you the diagram. So this is the diagram they are giving you. So let me read the question to you. Just make a guess about what is likely to be. They tell you that a 55-year-old man is brought to the management department because of sudden onset difficulty speaking for 1 hour. He has hypertension, dyslipidemia, type 2 DM. Current medication includes atorvastatin, lisinopril, metformin. He's tall. On examination, the patient speaks slowly in simple sentence that consists of only one word. He seems to have difficulty understanding grammatically complex sentences and appear to be frustrated at the inability to speak fluently. He is able to follow command. When another individual tries to enter the room, the physician asks the patient to hold the door. He does so immediately based on his symptom. Which of the following label area in the schematic diagram you are looking at is most likely affected? So which area do you think is affected in this patient? This
D.
patient
F.
this patient is making small sentences now. This patient cannot understand grammatically
F.
complex sentences. How come you are not thinking about Wenike?
F.
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 When it.
Dr. Kenne,
Hmm?
you said Wenike, right?
Yes.
Okay. How many of the sentences made by this senator do you understand? That senator that used to blow grammar in Nigeria.
Hmm.
How come
None.
you don't say you have a lesion in the Wenike? The question already say grammatically complex one. If someone blow grammatically complex, how many of us will understand? So
Okay. So
that's not
it's
it. So you are not going
E.
to make reference to that. So the answer will be something related to which
Bro.
area? Brocailo. Okay.
Okay.
F.
Do you get the logic there, Dr. Kenne?
Yes, I do.
Lovely. So that's how we are going to be looking, because the question already say grammatically complex. I'm very sure all of us here will not understand them too.
They even asked him to hold the door and he could
And
understand that.
he could understand that and he could do it easily. So no problem. All right. So let's leave that. Let me show you the last diagram. So the last diagram here is this. Oh, before that, there is a question that has nothing to do with that. I will just read the question to you. A 73-year-old man is brought to the emergency department 30 minutes after the sudden onset of right-sided weakness. His wife reported that he does not seem to understand simple question. He has type 2 DM and has smoked 1 pack of cigarette daily for 45 years. The patient speaks fluently, but he answers questions with nonsensical phrases. So if this patient is answering questions with nonsensical phrases, um, uh, what do you call it? Which area will you be thinking about?
Wenike.
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 Okay.
Wenike area.
All right.
Wenike.
All right. Wenike area. So they now add something to it and cannot repeat single word. This patient cannot repeat. So which area is that?
Accurate.
Accurate.
Aqueous
Accurate.
fasciculus. So you now have two lesions here. Something related to aqueous fasciculus, something related to Wernicke. What is the diagnosis?
Wenike aphasia.
Wernicke aphasia, stricken. So the answer will be E. All right. Let me show you another diagram. I don't think I have the diagram. Let me just forget about that. So we are done with this cerebral cortex. Go back, rehearse questions on this area, and you'll be very fine. Just rehearse few. Don't give yourself unnecessary headache. There will always be 1 or 2 questions you don't understand. Don't try to impress yourself by understanding them all. Try your best. They will serve all the ball into your court. They play them into your court. You will realize that. So this is cerebral perfusion. So the concept you want to know here is just very simple. This is the brain of a patient. So, and you have this our carotid artery. Just enter and they bring blood into it. Let us change the color. Just bring blood into the cranium. All right. Then they now divide and shall divide the way they want to divide. Within this cranium, you have the brain. There is a pressure within it. We call that pressure intracranial pressure. The blood is entering this one with mean arterial pressure. Think about it. If the intracranial pressure is high, the blood perfusion, most of this vessel will not be able to perfuse the brain very well because the pressure in that area is higher than the pressure they are carrying, which is mean arterial pressure. Let us assume that the mean arterial pressure is low, then perfusion will drop. Most of the blood will not go into this area. Or you say the intracranial pressure is high, that perfusion by this vessel will not occur. This intracranial pressure is against the mean arterial pressure. Do you get it? It's against the mean arterial pressure. So now, how are we going to know what we call perfusion pressure, or you call it cerebral perfusion pressure, the pressure with which the vessel here is perfusing the brain? We now need to ask ourselves, please, what is the pressure with which it is coming? We say it is mean arterial pressure. Thank you. Which pressure is against it inside the intracranial? Say intracranial pressure. Okay. Tell me the difference between them. You say the difference is 10. That 10 is the pressure with which the vessel will be perfusing the brain. You are bringing 120 mean arterial pressure. The intracranial pressure itself is 60. Then this vessel, despite the fact that it's carrying mean arterial pressure of 120, it can only perfuse this brain with the difference between the two. And that will be the 60 again. Do you get it? Okay, let me use this one as 130. So it's now going to be perfusing the brain with 70. That's the pressure with which this one will be perfusing the brain. 70. Shikena. So it's just the difference. So you now need to ask yourself this question. What are those things that can raise the intracranial pressure? What are those things that can raise the mean arterial pressure? So things that can raise the intracranial pressure, they are just something like tumor. You imagine that there is a tumor here. That tumor start growing. The pressure within that cranium will be high. Intracranial pressure will start rising. As the intracranial pressure is rising and mean arterial pressure is not rising, the difference between the two will be falling. So let us assume that the intracranial pressure rises to 90 because of a tumor. Then mean arterial pressure is still the same thing as 130. The cerebral perfusion pressure will now drop from 70 to 40. So the cerebral perfusion pressure will drop. And if the cerebral perfusion pressure is dropping, what it means is that the brain tissue will not be getting enough oxygen and the patient will start having all manner of manifestation. So that's just the difference we'll be thinking about and play around. There is nothing. But in case you need the formula is cerebral perfusion pressure will be equal to mean arterial pressure minus intracranial pressure. Shaken. Let us assume that the difference between these two is 0. What does that one mean? It means that there is no perfusion to the brain. The mean arterial pressure is equal to the intracranial pressure. And usually see that one. It usually leads to brain death. Shaken. Very easy. Let us assume that the mean arterial blood pressure, this patient is having hypertensive emergency, and the mean arterial pressure is 50. Intracranial pressure is something like, let us put it at 70 before or 60 before. You just realize that the cerebral perfusion pressure is now going to be something like 90. So the pressure with which the blood is perfusing the brain is now very, very high. Majority of the small vessels in the brain will start bursting because the pressure in them is high. They are not built to withstand those pressure. They start bursting, and the patient will start having all manner of complication from that hypertension. Do you get it? Can start having hemorrhagic stroke, can start having this, can start having that, all manner of stuff. Do you get it? So that's just the difference. They can now start playing around these three values for you. They can give you the mean arterial pressure in the name of the blood pressure of this patient is 220 all over 120. And they tell you that the cerebral perfusion pressure is 60 millimeter of mercury. They now say the intracranial pressure is 60 millimeter of mercury. They now ask you to calculate the cerebral perfusion pressure. Shikena, that might be the only question they will give you under cerebral perfusion. And someone has sat down, has crammed everything, just give this small calculation. The person is lost. So what is your mean arterial pressure from this value given to you?
100.
I.
There's nothing like I. What's the value? 120 plus
Um, plus
One
pulse
third
pressure.
of
Third of
100.
pulse pressure.
1 over
one third
3
of
of
100.
100.
So what is the 1/3 of 100?
That's going to be 33.
So let us just
So
put it
that's
at 33
153.
plus. That's
153.
so the answer will be 153 minus 60. So 153 minus 60 will give you what? 93, right?
Yeah.
And that's the answer. Shikena. So you just check the option, you just put 93, 90, 91, 90, 80. Just put it and just pick your 93 and go. And that might just be the only question they will give you. So don't expect too much. So now let us look at the another aspect of this cerebral perfusion. It's about the gases that are there. Out of all the gases, the one that determines the cerebral perfusion is actually the partial pressure of CO2. Out of all of them. So you just want to master the partial pressure of CO2 very well. P, CO2. Now, it is only in the lung that hypoxia is going to cause vasoconstriction. In other tissue, most of the time, what you have is vasodilation. Do you get it? So when the PCO2 level is high, the patient will have vasodilation. When the PCO2 level is low, the patient will have vasoconstriction of those cerebral vessels. All right, come to this same diagram here. The same diagram. The same diagram. Sorry. The same diagram, using the same diagram. So this is the diagram. If the PCO2 level is high, all you want to remember is that Festus said that hypoxia causes vasoconstriction only in the lung. It's only in the lung you say hypoxia causing vasoconstriction. In all other vessels, it's vasodilation you rather have. So in hypoxia now, what it means is that PCO2 level is high. That's just the way you want to interpret it. You can look at it that way. PCO2 level is high. Now, let us come to this PCO2 now. If the PCO2 is high, what the patient will have is vasodilation. When the PCO2 level is low, what the patient will have is vasoconstriction. So when there is vasoconstriction, you are limiting the perfusion into you are reducing the blood flow, because when there is vasoconstriction, you are reducing the blood flow to the brain. You are reducing the blood flow to the brain when you narrow the vessel. How are you going to apply this? You think maybe it's just a stuff. There is nothing stuffy there. You are in emergency. They brought this patient. This patient has maybe cerebral edema. The edema of the brain is making the brain intracranial pressure to rise. How are you going to reduce that intracranial pressure? The way you can do it is to induce what you call hyperventilation. Remove majority of the CO2. When you remove majority of the CO2, because hyperventilation will remove, it will not make CO2 to accumulate in that patient. CO2 will just be removed by that machine. As the machine is removing majority of those CO2, the partial pressure of CO2 will drop, and there will now be induced vasoconstriction. So the blood will not be perfusing the brain as such. The intracranial pressure will start dropping. Shikena. And that's all. So you just want to apply that. So when you see them talk about they relate it to someone with raised intracranial pressure, which of the following do you want to do for the patient? Just be like, I want to induce hyperventilation. When you induce the hyperventilation, you remove majority of the CO2. Since the vasodilation we have is as a result of accumulation of CO2, let us remove majority of those CO2 so that the vessels will go into vasoconstriction, and that will reduce the rate at which blood will be perfusing the brain, so that the so that the edema will start resolving. Shaking. All right, so that is one way of doing that. You now
Sorry,
imagine that
Dr.
they give you,
Festus.
please, I'm coming. I will always ask. You guys disrupt my line of thinking. So I wanted to say something. So I only paint a scenario, just one scenario. That is for someone that's having cerebral edema. Let us assume that there is another patient that you want to increase the cerebral perfusion. So what you just need to do is reduce the rate at which the patient will be losing the CO2. So how can we do that? Get this patient a face mask. Put that face mask. It might be anything. Just put it in the around the nose and the mouth of the patient. So the patient will be having what we call rebreathing, because the patient is releasing out the CO2. The patient will now be breathing in majority of those CO2 back. And before you know, the CO2 level will start rising and the vessels will start going into vasodilation, and that will increase the cerebral perfusion. So you just need to pick your pen. I want you to pick your pen now and a paper. Just write something like, increase in partial pressure of CO2 will cause vasodilation of cerebral vessels, and that will lead to increased blood flow into the brain. You now put star, that is down, like you want to make a point. A patient with cerebral edema, I want to reduce the blood flow to the brain. Therefore, I need to remove the CO2. I can do that using ICU. What do you call it? Yeah, you can use their machine in the ICU and that mechanical ventilator and set it in such a way that there is hyperventilation. The hyperventilation will now be removing majority of the CO2, and those vessels will go into vasoconstriction. So if the question talks about this patient needing more cerebral perfusion, so you can increase the partial pressure of CO2 in the patient blood, and that will cause vasodilation of the cerebral vessel, and that will take more blood to the brain. So that's the point there. Any question?
Yes, Chief, I have a question. I just want to clarify. So, increase in partial pressure of CO2 means that there's hypoxia.
Okay, now I only related that to hypoxia because normally you have the PO2 and PCO2. When this one is dropping, this one is likely to be rising. When this one is rising, the other one is likely to be dropping. Do you get it? So that's just what you have. But I want you to pick PCO2. It is only in a rare occasion that we put here that the partial pressure of oxygen will be the one that will be determining the perfusion of the brain. It is the PCO2 you are always pegging it on. Please don't forget that. Cerebral perfusion pressure is directly proportional to the partial pressure of CO2 until the partial pressure of CO2 is greater than 90. Well, I'm going to show you in the diagram anyway. But what you want to pay attention to is this cerebral, it's actually the partial pressure of CO2. Dr. Lunati?
Yes, I've read that thing over and over again. You said the partial pressure is directly proportional to PCO2 until PCO2 is greater than 90. Please, can you explain
I've not
that?
even explained it. What I explained before, have you all
Okay.
gotten it?
Okay, I just thought you said it and you've
No,
gone.
I only mentioned, I said I'm going to show you that in the graph. But what I explained before, have you all gotten it?
Yes, every other thing is good. Yes,
Okay,
thank you.
so I can move on now, right? So the last thing I'm going to talk to you here is about this graph. And this graph is just what you will use to understand this hypoxia, increased cerebral perfusion, only if the oxygen is greater, is less than 50. Very, very hypoxic. Okay, you have these two graphs. This is the one for, this red one is for the oxygen, this is it green is for the CO2, and this is the mean arterial blood pressure. So all we are trying to do is just to look for something like you are bringing the two together. But I want you to pay attention to the partial pressure of CO2, since it is the one that determines the cerebral blood flow. Do you get it? So as the partial pressure of CO2 is increasing, you are supposed to be having vasodilation. So they give you a graph like this where the partial pressure of CO2 is increasing. Then what do you think will be happening to the cerebral blood flow? It will also be what?
Increasing.
Along with it. Can you see it? Now, God is so wonderful. What God did is this, that if we allow the cerebral perfusion, the partial pressure of CO2, as the partial pressure of CO2 continues to increase, the perfusion of the brain is also supposed to increase with it. If we allow this relationship to continue unchecked, this patient all the vessels will just be bursting, because there are some situations whereby you discover that the partial pressure of arterial partial pressure of CO2 is very, very high. So that is what brings into what we call autoregulation. So what happens in autoregulation is this. When the partial pressure of CO2 rises up to a particular level, so you notice that no any other increase is really going to do anything to the mean arterial blood pressure. Because this mean arterial blood pressure is now what determines, it's actually what determines, what do we call it? It's actually what determines the cerebral perfusion. Let me explain this area again. Let me clean this so that you'll be able to see how we will merge it with cerebral perfusion. You have these three parameters in this graph. This is the partial pressure of CO2. As this one is increasing, cerebral perfusion is supposed to increase. This is another parameter, mean arterial blood pressure, that also determines cerebral perfusion. Do you get it? Do you agree with me? Those two terms, mean arterial blood pressure
Yes.
determines cerebral perfusion. We brought a
Yes.
formula the
Yes,
other time. Good.
yes.
Partial pressure of CO2 also determines cerebral perfusion. Those are the two parameters. If the partial pressure of CO2 continues to increase, you notice that the cerebral perfusion is just going to continue to increase forever. But most of the time, we usually say something that the cerebral perfusion pressure, God is so wonderful. He just said that God just did this thing. Let me put another color, yellow. So what you have with cerebral perfusion is that as the partial pressure of CO2 is increasing, the cerebral perfusion also is going to continue to increase like this, increase like this, increase like this, until it gets to around 90. When it gets to around 90, any other uh, increase you see in the partial pressure of CO2 will not cause any increase in the cerebral perfusion pressure. That's why they wrote here is that cerebral perfusion pressure is directly proportional to partial pressure of CO2, so that it's going to increase as the PCO2 is increasing until PCO2 starts becoming greater than 90. That's when you stop. They stop becoming proportional. So it's also going to be increasing. But if this PCO2 continues to increase like this, you will not see any other increase in the cerebral perfusion pressure. But this graph is just showing you that, okay, around that 90, this thing just flatten out. They are relating it to what do you call it, cerebral perfusion. Now, this graph they are drawing here, let me merge the two graphs together for you. The one for the cerebral perfusion and the one for the partial pressure of CO2. So this horizontal axis is the partial pressure of CO2, while the vertical axis is actually the one for the cerebral blood flow, which you can equate to cerebral perfusion. All right. As you are increasing the partial pressure of CO2, you are supposed to be having increase in the cerebral perfusion, which is cerebral blood flow. And you can see that as this CO2 is increasing like this, the cerebral blood flow is also increasing because you are having vasodilation, vasodilation, vasodilation. Immediately the CO2 gets to this area around 90, there was no more increase in the cerebral perfusion. It's just flattening out. So after 90, if you check the question, they give you a question. And what you are seeing in that question is that the partial pressure of CO2 is 95, is 100. You are not going to see any other increase in the cerebral perfusion pressure. You will not see it. It will increase again because it stopped increasing. They stopped becoming proportional around this area of 90. Do you get it? So that's just what we have there. Then if you relate this one to partial pressure of oxygen, arterial partial pressure of oxygen, it's more like opposite, because if the partial pressure of oxygen is high, what it means is that partial pressure of CO2 is low. They are just more like opposites. All right. So this partial pressure of oxygen, if it continues to drop, and drop, it has no influence on the cerebral perfusion pressure. You don't really relate it. You only start relating to it when, you only start relating to cerebral perfusion, partial pressure of oxygen when it's around, less than 90. Do you get it? So let me assume, less than 50, I wanted to say. Let me assume that this patient is having a lot of oxygen in the blood. You say the arterial partial pressure of oxygen is very high. It has nothing to do with the cerebral perfusion pressure. It only starts affecting cerebral perfusion pressure when it is less than 50. That is all what you just, but you don't make reference to that. This point is even inferior to the point about the PCO2. So the main determinant that you want to put at the back of your mind for cerebral perfusion is partial pressure of CO2. As the partial pressure of CO2 is increasing, as it is increasing like this, if it's increasing like this, cerebral perfusion also will be increasing alongside with it. As the partial pressure of CO2 now continue to increase after 90, it's still increasing again like this, it still continue, the cerebral perfusion will just start flattening out. There is no more increase. When you bring these two graphs together, they put this one on the horizontal axis, put this one on the vertical axis, you notice that the partial pressure of CO2 is increasing. Cerebral blood flow is also increasing until this one increases to 90. After 90, there is no more increase in the cerebral blood flow. That's the point you want to note. If they give you high partial pressure of oxygen, the partial pressure of oxygen in the blood is high, it has nothing to do with cerebral perfusion. It starts influencing cerebral perfusion when it's very low. Around what value do you talk about this low? When the value you are getting is less than 50. That's just a point. This is the point. This point about the partial pressure of CO2 has no, I'm not really pegging it on any value, 90 or no 90. What you are going to use to answer all your question is the partial pressure of CO2 is what determines the cerebral perfusion. Shekena. Don't look for too much points. That's the one they will test you on. This is just more like, they can just give you the graph, and even looking at the graph, you can easily interpret it that every other increase in partial pressure of CO2 after 90 has nothing to do with the cerebral perfusion. That's why it's flattened out. Do you get my point? All right. Then any other drop, any other increase, when the partial pressure of oxygen is very high, can you see it's very high? It has no influence on the CO2, on the cerebral perfusion. So the last one is this mean arterial blood pressure I want to talk about. Mean arterial blood pressure, that one continue to rise. As the mean arterial blood pressure is rising, cerebral perfusion also is rising. But if we continue to make the mean arterial blood pressure to rise, and cerebral perfusion is also rising, forget it. This patient will have majority of the blood vessels in the brain, they start bursting. So what you now have is that they have put what we call autoregulation on the mean arterial. All these things we are talking about, they're actually autoregulation on the mean arterial pressure. Because as I'm talking to you now, my blood pressure may be rising. If my blood pressure is rising, my cerebral perfusion will also be rising. You remember the formula we wrote here. It's also expected to be rising. Okay, but when it rises up to a particular level, around this, I think it's around, what do you call it, 65 or 70, there is no more increase in the cerebral perfusion pressure for a very wide range until it gets to 150. You now imagine the mean arterial blood pressure of that patient is now more than 150. Then you are going to start having sudden increase in the cerebral blood flow or cerebral perfusion. And that is what will lead to unnecessary bursting of blood vessel in the patient brain. What does that one tell you? How come you are not bothered when you see high blood pressure of 170, 100? How come you are not bothered when you see blood pressure of 180, 120, or 110 or 100? But when you start seeing something like 220, 140, you just know that in the next 5 minutes, this patient may die. Because at that moment, and if that BP is not brought down, the patient is going to suffer all manner of bursting of the vessel, because there will be more blood will be flowing to the brain, and that will now raise the intracranial pressure, because you start having seeping of fluid into the brain parenchyma. You now have rise in the intracranial pressure. That rise in intracranial pressure is now going to have deleterious effect on the brain. The patient may start becoming confused, acute confusional state. The patient may start having cerebral edema. The patient may start having stroke and start having all manner of stuff. This is the graph that explains that. There's someone that is just having 170, 100. You are not bothered. You just say, Mama, please just be using your drug. Because you know the body has a wide range of autoregulation. Just small increase in BP will not give the patient brain injury. Just small increase in BP will not start damaging the brain. Before the brain will start becoming damaged, the mean arterial blood pressure must be in the value of close to 150. They usually put it at 145, around 145 and above. That is when brain starts suffering some injury, and you call that hypertensive emergency. That is for the mean arterial blood pressure. So you need to understand, when you see the graph, you just have this way of looking at it, that God, you've done this patient so great, or great things, that you put a wide range of pressure, mean arterial blood pressure, that any fluctuation within this range should not give this patient any injury, because cerebral blood flow will not increase. But if it's lower than this, the patient will start feeling dizzy, blah, blah, blah. If it's greater than this range, the patient will start having all manner of complication. And that is that. Do you get my point about the mean arterial blood pressure and PaCO2?
Yes, please.
We come down to the homunculus.
Yeah.
With respect to homunculus, the way Dr. Oluranti said that, okay, this is now they are now cutting the brain. That's how you have it here. All you want to remember here, there are just 2 points. Only 2 points you want to remember here. Just 2 points. They are not more than 2 points. Medial part of the brain like this, you have the leg there. The lateral part of the brain, you now have the arm, hand, and the likes, then the face, lowermost, around the lower part of the brain. So we talk about the anterior, this medial part of the brain is like the woman being, like I'm imagining myself just resting this is my pelvis. It's around this region. My legs are dangling like this. Then this is my trunk. This is my neck. And this is my face. I now spread my arm like this, just to be like, Omo, let me rest myself. Do you get it? This is my face. So it's like the person is lying on the rock just to rest himself. So if the question tells you that this patient is having weakness on the leg alone, weakness on the leg or something related to the leg alone, lower limbs alone, you just know that this is homunculus that you are dealing with. You start thinking towards what you call anterior cerebral artery. That's what supply this medial part. If all what you are seeing in the question is all about the upper limb and the face, you start thinking towards middle cerebral artery. So I call it LAV, the lower limbs, the arms, and the face. Just like that, just come out like that. The lower limbs, the arm, and the face. That's what you have. So the arm and the face, anything that is affecting that, I'll show you some questions. You start thinking towards middle cerebral artery. If anything is affecting the lower limb, you start thinking towards what? The anterior cerebral artery. What of if is lower here, posterior cerebral artery? I'm going to show you how that question will come. So, but majority of the question they will give you will be pegged on the anterior and the middle cerebral artery. Let me quickly show you. I won't be going back and forth again. We are wasting time. I just want you to listen. If you listen, if I thought there is any area that you think can easily go back to the video and listen to it. But all you need to do is just to pay attention. Just see this question. It tells 78-year-old man, left-handed woman with hypertension and hyperlipidemia is brought to the emergency room because of sudden onset right leg weakness. Then urinary incontinence. Right leg, urinary incontinence. Neurology examination showed decreased sensation over the right thigh. Everything lower limb. Muscle strength is 2/5 on the right lower extremity. Right again. Then 4/5 on the right upper extremity. Right upper extremity is looking normal. How come everything is about the right leg? At that moment, you start thinking towards homunculus. Strength and sensation in the face are normal, but she has difficulty initiating sentences and she is unable to write her name. Well, this is a 78-year-old. Only God knows which age degenerative disease the patient is coming down with. So I may just take that information slightly. The most likely cause of this patient condition is an occlusion of which of the following vessel. I will just ask myself, where is the lesion? They say on the right. So if this lesion is on the right lower limb, then I will be dealing with the left cerebral hemisphere. Which part of the left cerebral hemisphere is it going to be? The medial. And that medial part is supplied by anterior cerebral artery. So the lesion this patient will be having will be on what? Left anterior cerebral artery. Shikena. So let me show you another question. They show you this one. A 69-year-old right-handed man comes to the physician for a routine health maintenance examination. On questioning, he has had some difficulty speaking for 3 months. This patient is not really speaking, and he is a right-handed man. So I will just come here and just be like, right-handed man. So my dominant hemisphere for this right-handed man is going to be the left cerebral hemisphere. Since this is a right-handed man, that is where I'm going to have my Broca area and Wernicke area. I already know where my Broca is. I know where my Wernicke is. Now, see, during a conversation, he often has difficulty repeating what his interlocutor has said. He has hypertension and takes hydrochlorothiazide. His vital signs are within normal limit. The patient speaks fluently in full sentences and demonstrates normal comprehension. When asked to say the word kindergarten, he replies, Sintermavin. No, that's wrong. Kintaflagging. No, that isn't either. Cantolagging. No. How about kindergarten? The most likely cause of this patient's symptom is occlusion of a branch of which of the following vessel. This deals with arcuate fasciculus. That is what is affected. And this arcuate fasciculus is the one connecting the Broca with the Wernicke. Where am I going to see this arcuate fasciculus? I say I'm going to see it in the left cerebral hemisphere. Since this patient is a right-handed patient, that is where the arcuate fasciculus is going to be. Which artery is going to be supplying this arcuate fasciculus? Is going to be the middle cerebral artery. Which middle cerebral artery am I going to be thinking about? They gave me left and they gave me right. Which one am I going to be picking? Since I already
Left.
localized this to the left cerebral hemisphere, so the middle cerebral artery will now be the left middle cerebral artery. Just by using your handedness, you are done with the question. Sikila. Let me show you another question so that we don't waste our time. A highly agitated 54-year-old man is brought to the emergency department by his family because he is unable to effectively communicate. He speaks clearly and with conviction, but his sentences are incomprehensible. What? I can comprehend whatsoever you are saying. You can talk very well. Your broker is doing well. However, I think I'm having issue with that your Wenike. He does not appear to understand the doctor's question, does not follow oral or written instructions, and cannot repeat simple phrases. Definitely, this patient is having what we call the Wenike aphasia. So this patient is having something related to the Wenike and something related to the Hackwaite fasciculus. Now, see, branch occlusion of which of the following artery is most likely responsible for this patient condition. I will also be thinking towards something like middle cerebral artery. But is this one going to be right or the left? I do not know, since they did not give me anything about handedness of this patient. And the options are also in that regard. They never tell you whether it's left or right middle cerebral artery. Middle cerebral artery is middle cerebral. It may be right or left, since handedness of this patient was not given. The answer will be C. Let me show you another question. A 64-year-old man comes to the emergency department due to left lower extremity weakness. This is about the left lower, just one of the two limbs is affected, not the two of them. If it's the two of them, you start thinking about another thing entirely. So this is just one of them. The patient was asymptomatic when he went to bed the night before, but he has had difficulty standing after waking up today. He has had no headache, double vision, or back pain. Medical history is significant for hypertension, DM, and myocardial infarction. Temperature is 37, blood pressure 140/90, pulse is 110, irregular. Left lower extremity examination shows motor power of 0. This patient cannot even do the flicker. And deep tendon reflexes are 3+, and Babinski sign is present. Now say that right lower extremity examination is normal. So everything is about the left. I start thinking towards something like the right cerebral hemisphere. Which part of this right cerebral hemisphere am I now going to be thinking about? I will be thinking towards the medial part of the right cerebral hemisphere, since this is all about the what do you call it? The lower limb. Now say that right lower extremity examination is normal, and abnormality in which of the following structure is the most likely cause of this patient's symptoms? The answer will be the right anterior cerebral artery. Please give me 1 minute. So that is how you look at the question in a very simple way. Don't do too much stuff. So look at this one now. This question, just pay attention to me. A 58-year-old man comes to the emergency department due to 3-hour history of abrupt onset, weakness, and numbness in the right lower extremities, as well as urinary incontinence. And I'll tell you, 2 months ago, the patient was hospitalized due to left-sided weakness that resolved spontaneously. Now, this patient is having um, um, something related to the right lower extremity. Definitely, this is likely to be related to homunculus. Okay, definitely. Okay, don't let me say definitely, likely. Because if we read the question and we are bringing in all manner of cranial nerves and the like, we start thinking about another thing entirely. Now, see, at that time, MRI of the head and MR angiography of the head and neck were normal, but the patient was found to have atrial fibrillation. And oral anticoagulant was prescribed at discharge, but the patient has been non-adherent with the therapy. Blood pressure is 162/94. Okay, and pulse is 102 and irregular. Physical examination shows weakness and sensory loss in the right lower extremity. Right, definitely I'm dealing with left cerebral hemisphere. All right, you know, say Babinski sign is present on the right. Speech is normal and there is no facial weakness. This is not about cranial nerves. Examination of the right extremity and the left extremity is unremarkable. Now say an embolic occlusion affecting which of the following vascular region is most likely cause of this patient current condition or symptoms. Definitely, we are dealing with um, um, what do we call it? Anterior cerebral artery. This patient is having something related to the right lower limb. Then we are dealing with what? Left cerebral hemisphere. Which part of the left cerebral hemisphere? The medial part of the left cerebral hemisphere, because that is where your lower limb, the patient lower limb will be. Then something is occluding the anterior cerebral hemisphere, likely an embolus. Now let us check this. So we have two options that are for anterior cerebral hemisphere. Which one are we going to choose? You can't answer this question until I explain something to you here. This is the anterior cerebral, this is anterior cerebral artery, anterior cerebral artery, anterior cerebral artery. There is a vessel connecting two of them together. You call that vessel anterior communicating artery. Now, you imagine that this is where the occlusion is, proximal to the anterior communicating artery. This patient will not give any symptoms. Why? The other anterior cerebral artery through this anterior communicating artery will be supplying the two anterior cerebral artery. As the blood gets to this junction, it will split into two and go like this, go like this. When it gets here, supply. So this patient shouldn't have any symptoms. The patient has symptoms only if the occlusion is distal to the anterior communicating artery. So even if there is a splitting here, blood can still not go down. So you are trying to look, is this lesion proximal to the anterior communicating artery or distal? If it's distal, the patient will have symptoms. Based on this, my explanation. If it is proximal, the patient will not have any symptoms. So that's just that one. Let me solve two more questions, then we call it, we peg it there. You can go and answer as many. So the answer here is going to be anterior cerebral artery distal to the origin of anterior communicating artery. Shikena. That's why the patient is having symptoms. Look at this question. A 74-year-old woman is brought to the emergency department by her son after he found her acting strangely. She was asking to open the window blind, even though the blinds were already open, and was bumping into objects when walking around the house. Mama, why are you doing this? The patient insists that her vision is fine. Don't tell me rubbish, I can see, and came to the hospital upon her son's insistence. On physical examination, the patient is alert and oriented, but lack appropriate eye contact. He doesn't even know where to look. Bilateral, direct, and consensual reflexes are normal. Everything about the eyes is okay. Definitely, this patient is having what we call cortical blindness. Cortical blindness. So you start thinking towards something related to the posterior cortex. All right. Or visual cortex. So on confrontation visual field testing, she reports the wrong number of fingers in all four visual quadrants. The patient indicates the wrong direction when asked to point to the door and gives an incorrect visual description when asked to describe the physician. This patient most likely has an infarction involving the brain region supplied by which of the following artery. This is how cortical blindness people present. Something is wrong with their posterior cortex, but they do not know that something is wrong. They can't see. They don't know that they can't see. They still pretend like they see, but they themselves don't know. When you carry out all manner of tests on the eyes, everything is okay. There is no opacity in any region. The reflexes are awesome. So, but this patient is still not seeing. You start thinking towards posterior cortex. So the answer here is posterior cerebral artery infarction. So let me solve one more. Then we peg it here. Okay, I think I've solved this question before. A highly agitated 54-year-old man is brought to the emergency by his family because he is unable to effectively communicate. He speaks clearly, and with confusion, but his sentences are incomprehensible. He does not appear to understand the doctor's question and does not follow oral or written instruction and cannot repeat simple phrases. Branch occlusion of which of the following artery is most responsible for this patient? So this is actually middle cerebral artery. So you are dealing with Wernicke aphasia there. So that's all about the homunculus. Not difficult. Just look at it, pick it, and you are okay. Okay, I will leave that area and come down to what we call the water.
Dr. Foster, sorry, please, I have a question.
All right.
So, if the Wernicke area is supplied by the middle cerebral artery, does it also supply the Broca's area,
Okay. It's also supplied the Broca's area,
the middle cerebral
the
artery?
middle cerebral artery. And all the questions we see, you can check that one, confirm that. It's also supplied to the Broca area. You can just type arterial supply of the Broca area. So if you see any contrary stuff, just let me know. No problem. Let's continue so that we can cover as many points as possible, everyone. All right. So watershed zone. What is it about the watershed zone? All right. This is not a term that you are just hearing for the first time. When we were doing the GI, we also mentioned the watershed zone before. I mentioned it where two vessels are meeting. That's actually the watershed zone. So the thing about it is that anything that's going to affect the watershed zone must actually affect the two vessels supplying that area. Do you get it? It must affect the two vessels supplying that area. All right. So what we have here is this. This is the anterior part of the brain. This is the anterior part of the brain. It has anterior cerebral artery as its blood supply. This is the posterior part of the brain. It has posterior cerebral artery as the blood supply. This is the middle part of the brain. It has something like middle cerebral artery as the blood supply. Where those two vessels meet, that is actually where you call every two vessels meet. That's where you call the watershed zone. So this area where the middle cerebral artery territory is meeting with anterior cerebral artery territory, that is actually where you call your watershed zone. This is one watershed zone. Where the middle cerebral artery and the posterior cerebral artery is also meeting, do you get it? You also call this area watershed zone. Are you with me? This is another watershed zone. These areas are cortical areas. Then we call them cortical border zones. This is a anterior cortex. This is middle cortex. This is posterior cortex. Then we are having a zone that where they border themselves. So you call this cortical border zones. Shikina. How will I know that this region is affected? That the region they are talking about, that this region is the one affected? The description is so classical. You call it wedge shape. Wedge shape lesion. Just the way it is here, wedge shape. Wedge shape. Sorry. Just something like this. Like this. Like this. Wedge shape. So this will be like this. Wedge shape. This is also like this. Wedge shape. Just know that this is actually the watershed zone is affected. There is now another zone that this one is actually found deeper within. You call that zone internal border zone. This one is found between the superficial and the deep vascular territory, most especially of the middle cerebral artery. So we have some vessels that supply this region. They are the deep vascular vessel or deep vessels. We also have superficial vessels. So they meet around this area, and this is actually their deep, or you say internal border zone. So these are the two watershed zones. What are those things that can affect this watershed zone? Severe hypotension, severe hypotension, severe hypotension, severe hypotension, severe hypotension. Check all the options. Is there anything like severe hypotension here? Now relax. I just mentioned a point the other time. We did it in GI. They will give you a question and tell you that a patient has infarction at the splenic flexure. That is where you have one of the watershed zone. In which other area on this brain image can this patient also have infarction? And they now put on manner of arrow there. You look at splenic flexure, that's the watershed zone. Where else can I have watershed zone? Here. These are the regions you just check for. Just any one that is pointing to any of these regions, either this area or this area or this area or this area. That will be your answer. Just pick it. There is no stuff here. This is not stuff. This is just something quite, it's more of qualitative reasoning. We give you one image. We tell you that when you see this affected in this image, hey, this is what is happening. We now give you another image that we've explained to you earlier, or you identify where the lesion is here. You just come here and just pick it. Don't turn this thing to big stuff. That's all. And you check for severe hypotension in the question. Is there any other thing that can affect the watershed zone? Yes. This is the commonest location of brain metastasis. The question will just tell you this patient has a metastatic brain lesion. Which part of the brain do you think this thing is likely to go to? You just give you image of the brain and put A, B, C, D here. And just pick the watershed so you can see on the image. And that's all. You are okay with that. Any other stuff, you can ignore it. All right. So I won't really bother you much with this lesion here. The way I'll just tell you basically. If you are having the anterior cerebral artery, middle cerebral artery watershed infarct, so this place is infarcted, maybe from this severe hypotension, you may start thinking towards the way the patient will manifest. The patient will manifest with proximal upper and lower extremity weakness. Why? This thing is affecting the anterior cerebral artery. It's also affecting the middle cerebral artery. So you see something related to upper and lower extremity in the patient. So the arm is weak, the legs are weak. So this patient will present with what we call man in a barrel syndrome. This is not a big word. When we were younger, we used to put ourselves in a barrel. This is me. And this is the image, lower limb. And we now put ourselves in a barrel. And this is the barrel. We put ourselves then. We put ourselves like this. Just put ourselves in a barrel. We will now be running. We won't be able to run very well. It will look like the lower limbs are weak. You want to lift the hand, you can't lift the hand. It will look like the upper limbs are weak. They look for a name to call it. Man in a barrel syndrome. Shikena. No big issue here unless you just want to be making big deal out of them. And you leave that. You definitely know that once the posterior cerebral artery is involved, the patient will have cortical blindness, higher order visual dysfunction. Peg it on that and go. Then, okay, let me show you one or two questions. Just for you to have an idea of the way they give you the question there. Okay, let me see this. Because sometimes they will need to, let me see the one that, okay, let me first of all answer this second question. It will help you to analyze that. Before we go to the first question, a 66-year-old man undergoes a coronary artery bypass grafting. Upon regaining consciousness, coronary artery bypass. Why must you do a bypass for this patient? Heart is gone. MI. Okay, now you need to go and bypass the artery because of complete occlusion of the artery. If the artery is completely occluded, then the muscle of the heart supplied by that artery will be forever at that moment be hypokinetic until this bypass is done. Upon regaining consciousness, he reports that he cannot see from either side and cannot move his arms. Physical examination shows bilateral equal reactive pupils. The eyes are good. A fundoscopy shows no abnormality. An MRI of the brain shows wedge-shaped cortical infarct in both occipital lobe. Which of the following is the most likely cause of this patient's current symptoms? Definitely, this thing has affected that the MI the patient had. The patient suffered hypotension, severe one hypotension that now affects that watershed area that is related to the visceral pathway, visceral cortex, and that's all. They can also ask you in this question that where else do you think this patient can have symptoms or signs? Just go to the GI and bring another watershed area there. That will also be correct if that's how the question is given. And these are the modality by which they test the watershed area for you. You master it, you are good. If you don't master it, you are also good. Just master anything you like. Let us look at this first one. A 70-year-old right-handed man comes to the emergency department with a day-long history of vision disturbance and bumping into objects on the left side. She also has had a mild headache over the past several hours. Then you notice that this patient actually reports this. There is no way you will not see one or two patients that will be able to say that I'm having this, I'm having that statistic. The majority of the patients with cortical blindness, they will be arguing with you that they are fine. All right, so by the time you go into residency, you'll be able to see differences and start adding to your stuff, removing from your stuff. Medical history include hypertension, hyperlipidemia, type 2DF. Physical examination shows a left homonymous hemianopia with macular sparing. We are going to be doing all this one later. Non-contrast CT of the head demonstrates an area of focal parenchyma, hypoattenuation consistent with ischemic infarction as shown. Which of the following additional examination findings is most likely to be seen here? We are going to leave this question till we are likely going to solve it later when we do all those other pathways. All right, but definitely it's all about the watershed. So you bring this knowledge, you start integrating them as we continue to expand our knowledge. That's all. So we come down to what we call the circle of Willis, and I want you to pay attention
Dr.
here.
Dr. Festus, sorry, I don't know if it's dragging you back, but what of the watershed zones between the superficial and deep
Well,
vascular
it's
territories
also
of the med?
likely, I will come back to it later. But now that you raised it, let me just mention something about it. I put a diagram here for you. So let me enlarge the diagram so you can understand something here. So I just hope you can see the diagram better. So what happened here is this. There are 2 points I want to bring out from this diagram. This is let me first of all talk about the deep branches of majority of these vessels. Each of them actually has its own deep branches. Anterior cerebral artery has its deep branches. Middle cerebral artery has its deep branches. Posterior cerebral artery has its deep branches. So this, what do you call it? The deep branches of posterior cerebral artery will come and supply this thalamus. Can you see? It supply the thalamus. And that's what it does. The anterior cerebral artery deep branches will come and supply the all these caudate nucleus and the internal capsule here. This internal capsule again is also supplied by a particular vessel. We call it anterior choroidal artery. I will show you where the anterior choroidal artery is coming from later. So it's supplying the anterior choroidal artery. Let me show you. We'll soon get there now. All right, so that's where anterior choroidal artery is supplied. So we are going to eventually look at the arterial supply to this internal capsule. But for now, just look at, okay, this anterior cerebral artery, that's its own deep branch. It just supply the region directly beneath it. Posterior cerebral artery has its own deep branch, supply the region directly beneath it. The same thing for the middle cerebral artery deep branch. This one will supply the lentiform nucleus, Shikena. Then we now talk about the internal capsule between them. That one has branches from anterior cerebral artery, then the anterior choroidal artery. You also have some other phase, but these are the major ones that you talk about. And these are just the deep branches of them. So you now have that internal border zone is here. So the deep branch of the middle cerebral artery and the superficial branch of the middle cerebral artery, where they all meet, you have the internal border zone there, chicken. But they hardly test the internal. If I thought you see a question on that, you should be able to answer it. The same concept, the same stuff, no issue. All right.
So, Dr. Festus, so likely all those hippocampus and amygdala, all those ones will be posterior, right?
The hippocampus,
Yes.
they are actually located in the temporal lobe. That one will also still be supplied by the middle cerebral artery.
Okay.
Okay, let's
got it.
move to the circle of Willis. All the other questions we'll be answering them later. Circle of
Yeah,
Willis.
Dr. Barandi, can we get a short break? It's been
Oh,
almost.
really? In fact, I need to even leave now. Thank you so much. We meet later. I need to leave now. Thank you. Bye. We
How
meet in
many
the
minutes?
next 20 minutes.
Okay.
Yeah. So before we left, um, a question was asked about the arterial supply to the hippocampus. Though I don't think it's necessary, but or that knowledge is needed. But just to correct that, because I said it should be middle cerebral artery, I checked. So it's actually posterior. And this image will give clarity to that, because this is actually the region of the hippocampus. It's medially located. So posterior cerebral arteries, they supply all this region. So you have posterior cerebral artery there. This region here. Do you get it? So that's just that. Just for us to have an idea of, apart from that, anterior choroidal too is also part of it. Just for us to have an idea of that, but that knowledge is not needed, it's not necessary. Most especially for this, your USMLE, whether one or two. Okay, so that's that about the circle of Willis. So what happened in circle of Willis? I want us to pay attention to the point I'm making, and let us try to reduce interruptions as much as possible, because I will lose I don't have any material here. I only read whatsoever that is there, and I launch an explanation. So if you disrupt my line of reasoning, I won't be able to give you as many points as possible. Okay. So this is the circle of Willis. What you need to put at the back of your mind with respect to the circle of Willis, not only circle of Willis, but both this arterial supply to the brainstem and the arterial supply and the circle of Willis itself. So you need to have the two understanding. So you must be able to draw this. Your ability to draw it will help you a lot to recollect them easily without unnecessary headache. So let us draw it together. What you have is this. You have first of all, have two vessels coming together. You call them vertebral artery. So vertebral artery will come like this. First one. The second one will also come like this. They now fuse together and form what we call the basilar artery. That basilar artery is just coming from the name, the fact that it's supplying the base, like the base of the brainstem. So this is the basilar artery. Basilar artery is formed from the two vertebral arteries coming together. So we have what we call the medial branch. We have the lateral branch. So the medial branch you have a branch coming like this, another branch coming like this. They fuse together and form what you call the anterior spinal artery. So this is your anterior spinal artery. Then we also have the lateral branch. This is the lateral branch, first one, and this is the second one. There are two lateral branches. You call them posterior inferior cerebellar artery. So this is also posterior inferior cerebellar artery. Then we come to the basilar artery. You first of all have this branch coming off from the base of the basilar artery. You call that anterior inferior cerebellar artery. So then you come to the superior part of the basilar artery. You have another branch again. You call this superior cerebellar artery. All the branches you talk about from here to here, they are all cerebellar. Cerebellar. So this is superior cerebellar, anterior inferior cerebellar, posterior inferior cerebellar artery. All of them are cerebellar. So this is cerebellar, this is ICA, cerebellar artery, and this is superior cerebellar artery. All of them are cerebellar. So don't go and make that mistake of thinking otherwise. It will help you. So that when you are reading the question, it will help you, it will guide you, because we have a lot to do with this artery. You don't joke with them. All right. Then the basilar artery will now emerge and now divide itself into two. Posterior cerebral artery, and that's how you form your posterior. And this is everything about the brainstem. So you must be able to draw this. I want you to pick a sheet of paper and try to sketch this. Sketch it and let us see whether you can do that. Let us draw it again together. Let's draw it again so that you will get used to it. Let's draw it again. So this is what you have. These are vertebral arteries. They come together and form what? Basilar artery. Then you have the medial branch. Can you see these two medial branch? They come together and form anterior spinal artery. Then you have the lateral branch, which is called posterior inferior cerebellar artery. At the lower part of the basilar, you have another branch, anterior inferior cerebellar artery. This proximal part of the basilar, you have the superior cerebellar what? Artery. Then this one will now emerge and divide into two. Shaking now. Two posterior cerebral artery. And that's all. So that's just everything. So if you want to put your brain stem on this diagram now, let us put our brain stem, how the brain stem will look like. You have something like this. This is going to be your medulla. This is going to be your pons. So this is going to be your pons. Then this is going to be your midbrain. This is your midbrain. This is your medulla. This is your pons. And this is and that's all. So if you want to think about the medulla now, the question is all about medial part of the medulla. They say what's the arterial supply to the medial part. I just want to try to simplify it. You have more artery, but if you can think the way we are thinking here, you won't have any problem with any question in your neuro. When you start asking, is it only this, is it only that, you start complicating the matter for yourself. When you see questions, you now start having a lot of things to start thinking about. So you won't be able to think straight again. So when the question is all about the medial part of the medulla, think about the anterior spinal artery, shaking her. If the question is about the lateral part of the medulla, you can just start thinking towards this posterior inferior cerebellar artery. So these are the ones they usually love to talk about. It doesn't mean that the vertebral artery cannot supply the lateral. So it still has one or two things to do with the lateral. It may have one or two things to do with the medial. But just to separate them clearly, these are the two. This one is for the medial. This one is for the lateral. Medulla. We come to the pons. The lateral part of the pons, we peg it on this anterior inferior cerebellar artery. The medial part of the pons, we peg it on the basilar artery. Then we come to the midbrain. The way you look at the midbrain, you can only look at the midbrain like this. We hardly look at the midbrain as the medial or lateral. We just look at it as the upper part of the midbrain, lower part of the midbrain. So the upper part of the midbrain, posterior cerebral artery. The lower part of the midbrain, the superior cerebellar artery, chicana. And that's all. No stuff here. There is nothing stuffy here. And that's just all about the brainstem. All the brainstem we are going to be doing, we'll peg them on these arteries. Be doing that, be using that, and you will be okay. You will love all those questions very well. Any other detail you want to add, you can go and be adding them. All right. So let's now add this one to the circle of Willis. With respect to the circle of Willis now, this one must join the circle of Willis because we want to form a circle now. We need two arteries to form the circle. The first artery you need is this internal carotid artery. You also need this posterior cerebral artery. This internal carotid artery, please never forget it. They will give you this cycle and now put an arrow on one of these vessels. Which vessel is this? Internal carotid artery. Middle cerebral artery has nothing to do with circle of Willis. It has capital nothing to do with circle of Willis. If you've been thinking about it, don't bring it here. Internal carotid artery will give off the anterior cerebral artery. We also give off this posterior communicating artery. Posterior communicating artery is given off by this internal carotid artery. So these are the first two branches you want to talk about that are related to circle of Willis. So anterior cerebral, posterior communicating, because we already have posterior cerebral. You can be thinking towards posterior cerebral again. So this one is going to be posterior communicating. It's going to be the posterior communicating. So that's what we are going to have there. So now we already know where our branches are coming from. Internal carotid, we give off anterior cerebral, posterior communicating, anterior cerebral, posterior communicating. Then this anterior cerebral will be joined together through anterior communicating. They can put an arrow here and tell you which vessel is that. They can put an arrow on this internal carotid and ask you which vessel. That may just be your question on circle of Willis. They may put an arrow on this posterior one here and just ask you which vessel is this, shaking. So, and that is how you form your circle of Willis. Now, I narrated a question to you the other time. If you have a thrombus or an embolus that's proximal to this anterior communicating, how will the patient present? The patient will not have any symptoms. They don't usually have any symptoms as such because the other branch will take over the circulation. But if I thought the lesion is distal, the patient will now come down with symptoms. Oh, that's lovely. Thank you so much. This is all about the vessel. But are there other things you want to note here now? The first thing I want to tell you is about the region where you have aneurysm. Aneurysm, you can easily predict it. You don't need to have read it in a place before you master where you can have aneurysm. It can occur anywhere, most especially around the angles. So you can have an aneurysm around this angle, around this angle, around this angle, around this angle, all manner of places you can have them. We now have some peculiar aneurysm that you must note. The first one is this one, aneurysm of the anterior communicating. The reason why it's important is because it can compress on this structure around it. You call it optic chiasm, aneurysm of the anterior communicating artery. So if you read a question, by now, whether you want to agree with me or not, I know all of you have heard about bitemporal hemianopia. So if the question talks about bitemporal hemianopia, they just ask you that, where do you think the aneurysm is? It's just going to be on this anterior communicating chicana. That's all. Now, that is the first question with respect to aneurysm. The second one is another nerve. There is another nerve. They will give you an aneurysm that is related to it. Which one is that? It's actually the posterior communicating artery. They will tell you a patient is having an aneurysm around this region. And I ask you that which vessel is likely going to be compressed. The vessel that's going to be compressed is cranial nerve 3. So the third cranial nerve. The last one we are going to talk about is, if at all there is a lesion. Okay, let me just narrow it to those two about those aneurysm. So when you read question about around the circle of Willis, there is an aneurysm. You already have two regions you are thinking about. Around this posterior communicating artery and posterior cerebral, just between them. If you have an aneurysm there, it can compress on third cranial nerve. So why aneurysm of anterior communicating artery can compress on optic chiasm? So when they give you question on bitemporal hemianopia, you have an idea of where the aneurysm is. If they give you a question on aneurysmal compression of third cranial nerve, you know where the aneurysm is, chicana. That's just the 2 points you must never forget again. Okay, let's leave this area. Let us see some questions, if at all they make sense for now. Let me draw the circle of Willis for you. Let me show you this picture, circle of Willis. I just hope that we need to have done everything. We've done everything before we solve the question. So I will project the circle of Willis to you. You just pick your answer. So match it with the little we've done before. I will read the question now. Just tell me your answer. They tell you in this question that a 68-year-old man is evaluated for visual loss in the left eye that resolved spontaneously within several hours. The patient has a history of hypertension, type 2DM, coronary artery disease, and ischemic cardiomyopathy. He has smoked a pack of cigarettes daily for the past 40 years. Physical examination reveals a left carotid bruise, but no neurologic deficit. A carotid Doppler ultrasound showed 85% stenosis of the left internal carotid artery, and carotid angiography with stenting is performed. During the procedure, atherosclerotic debris embolized to the artery shown, that's with the white arrow on the cerebral magnetic resonance angiogram below. Which of the following action is most likely to be impaired? So which vessel do you think is affected in that diagram?
Anterior cerebral artery.
So anterior cerebral artery is affected here. So which activity do you think this patient is going to have difficulty performing?
Lower limb.
Vision.
Something related to lower limb, right? So
Yeah.
when we look at the question now, we are just checking for anything related to the lower limb. Chicana, we don't have any specific activity until question tells us one they are looking for. They tell you whistling. Is whistling related to the lower limb?
No.
Swallowing food, is it related to lower limb?
No.
Do we speak with our legs?
No.
Gripping, do we grip with our legs?
No.
Climbing of stairs. Do we climb stairs with our leg? Yes. The
Yes.
answer
Yeah.
will be the climbing of stairs. Let me show you another question, another diagram on circle of Willis. Simple, simple, simple question. Don't complicate them. So they show you this diagram in your question. It might be exact diagram. They just show you something like this. Now ask you that. They ask you this question. Sorry. A 55-year-old right-handed man comes to the emergency department due to recent onset of severe throbbing, right-sided headache, and double vision. Okay, his medical history includes poorly controlled hypertension, chronic tobacco use. Neurologic examination shows that he is awake, alert and oriented, and can follow command. Visual field and optic fundi are normal. The position of the right eye is down and out with ipsilateral ptosis. The right pupil is dilated and non-reactive to both light and accommodation. Left eye is normal based on this patient's what do you call it? Neurologic deficit. CT angiography of the head is most likely to reveal an aneurysm arising from which of the following location in the image you are looking at. So, although I've not mentioned, I don't think I think I mentioned it briefly, the muscle of the eye that are supplied by the third cranial nerve. So you can pick your pen and paper now and just write LR6 SO4 AO3. Just write it, play around them. Okay, let me just show you something briefly. This is the nose. This is the eye.
We're not seeing your screen.
You are not seeing my screen. Okay. Let me draw it here. This is the eye. This is the nose. So you show that this is the medial part of the eye. This is the lateral part of the eye. This is the eyeball. So this is the medial rectus. This is your inferior rectus. This is your superior rectus. This is your lateral rectus. Then I told you something about the oblique. I call this one, this is your superior rectus. This is your medial rectus. This is your lateral rectus. And this is your inferior rectus. So you have another distance here. This is going to be your inferior oblique. I just used to put this arrow just to tell you where it will move the eye to. The arrow tell you where they move the eye to. This is your superior oblique. So this is inferior oblique. This is superior oblique. All right. So if you write our LR6, SO4, AO, all others, 3. So what it stands for, your lateral rectus is supplied by cranial nerve 6, which is abducens. Your superior oblique is supplied by cranial nerve 4, which is trochlear. Then all others are supplied by the cranial nerve 3. So if the cranial nerve 3 is affected, this patient will have, we are going to have elimination of this. Let me show you so that you will understand. So this one will not be there again, will not be able to walk again. Inferior oblique will not be able to walk again. Medial rectus will not be able to walk again. Inferior rectus will not be able to walk again. The only one we are going to be left with will be The only thing we are left with here will be the superior oblique and the lateral rectus. Can you see where the arrow points to? And this is the nose. Mathematically, we used to draw arrow. If you want to look for what we call resultant arrow, if you combine these two arrows the way they are going, what kind of movement are they going to produce? Let me show you. We usually draw what we call the complementary forces. This is just more like the shadow of this superior. This is also the shadow of the lateral rectus. Just draw their shadow. This arrow is pointing in this direction. This is also pointing in this direction. This arrow is pointing in this direction. This arrow is also pointing in this direction. You can see two of them look alike. We call them mirror image. You are now going to look for two arrows that flow together. We move from tail. We say we move from tail to head. So this is the tail of this arrow. This is the head. You just pick them two. This is the head of this. So if you draw the arrow, this is the kind of resultant force you are going to it's going to go like this. And that is why when there is palsy of the third cranial nerve, they usually have the eye move down and outward, because the arrow you are seeing here, the resultant arrow, is actually down and outward, shaking up. It's coming down and it's also going outward, shaking up. So that's just for you to know that there is a reason for that eye going down and outward. Please let us mute all our mics. There is a reason for that eye going down and outward. There is a reason for it. Do you get it? And that's just the point I want you to pick with respect to that. So we've not done the third cranial nerve actually, but just for you to have an idea about the question. I don't want you to ask any question about the third cranial nerve because we've not done it, but just for you to have an idea about LRC cells for AO minus. So this patient definitely is having the third cranial nerve palsy. And I make reference to the third cranial nerve palsy with respect to what? Which artery did I say you are going to be thinking about with third cranial nerve palsy? Who remembers?
Posterior communication.
Posterior.
So when you see posterior communicating artery in the question, that should actually be your answer until proven otherwise. So the answer to that question, the answer to that question is going to be D. And that D, what is D in that question? What is D in that diagram?
Posterior communicating artery.
So let me show you another circle of Willy. So I'm going to show you another picture. So you will answer this question now. Just use the logic. Please don't complicate it.
Chief, so the answer is posterior communicating artery, right?
Posterior communicating. I told you before. So when you have aneurysm at the anterior communicating artery will give rise to what?
Bitemporal hemianopia.
So if the question is all about bitemporal hemianopia now, you'll be thinking towards anterior communicating. So if the question is about third cranial nerve palsy, you'll be thinking towards posterior communicating. All right. So this is another diagram.
So in the question, what side of the eye, is it the right or left, is affected? In that question.
We don't need to analyze that because I think the diagram they gave. I'm coming. Sorry. Okay. The diagram they gave. If the diagram they are giving is showing both right and left, so you just need to look at that too. So
it's showing right and left. That's fine.
I'm coming. So all the cranial nerves, they give ipsilateral lesion. So if it's the right that is affected, you think towards the right. If it's the left, you think towards the left. All cranial nerves, ipsilateral.
Okay.
So let me assume that they do not even give you any side. Just look at the diagram, you don't see any side. And it's not about side. Just pick the one that's related to the options they give. So immediately you ask that question, I needed to look at the diagram to check, is it related to side? Because you can see right and left there. If you go back to the question, you realize that it's actually the right eye that is also affected, because all cranial nerve issue, they give rise to, they are all ipsilateral in their manifestation. Ipsilateral. I'm still going to make that point later soon. So look at this diagram now. This is another circle of Willis they are giving you. You can easily label them. Which artery do you think this your J is? Anyone?
Posterior inferior cerebellar.
Are you sure?
Yeah.
Jay,
Yes.
Yes.
Posterior inferior
you are
cerebellum.
still saying yes. Who is saying yes again? J is what?
Posterior inferior cerebellum.
You are still saying it with
No,
confidence.
it's
All right.
anterior inferior.
It's
So you may
posterior
want
inferior.
to
I
be
thought you said
Anterior
okay.
inferior
Hello,
cerebellum.
Anterior
hello,
inferior cerebellar.
hello. Just wait. So you may want to
Oh,
be thinking. You may want to be you may be confused with which one is anterior, which one is posterior. Yeah, you definitely know that one of them is anterior, one of them is posterior. Let me help you out. If you remember SAPMA that is occurring in Nigeria, you know you need to first of all reach anterior before you go to posterior, and posterior is related to the vertebral artery. This is anterior spinal artery. Vertebral artery will now give a branch. Sorry, is this J coming from vertebral artery?
No.
no.
Definitely your J is anterior inferior cerebellar artery. Chikedola. Do you get it? So your S,
Yes.
this one, this other branch below the I and D, these are what? Superior what?
Superior cerebellum.
Superior
Superior
cerebellar.
cerebellar.
Okay, let me read the question to you so you pick your answer. The question says that a 66-year-old right-handed man is brought to the emergency. Even though they are talking about handedness here, if we are talking about the brainstem, don't really, unless the lesion is related to the cerebral hemisphere, do you get it? So this is right-handed man is brought to the emergency department due to left-sided numbness and weakness. Where is the weakness? On the left, and the numbness. The patient woke with left hand clumsiness that rapidly progressed to profound left-sided weakness. So definitely in this question we are having what? Left-sided weakness. You need to be making those points out like a sketch. Left-sided weakness affecting the left arm more than the left leg. So you are having arm and leg being involved. Definitely this is not homunculus. This is not homunculus because the leg is supplied by the anterior cerebral. The arm is supplied by the middle cerebral. Am I having occlusion of the two of them? So it's definitely, this is not homunculus issue. It's not cerebral. You start thinking towards something related to brainstem. He has a history of hypertension and has smoked a pack of cigarettes daily for 40 years. Blood pressure is 175/90 and pulse is 82. Neurology examination revealed impaired touch discrimination in the left arm with left facial weakness, sparing the forehead. So there is a left facial weakness. Which cranial nerve, based on your past experience in medicine, which cranial nerve is likely to be that left facial weakness?
Seven.
Facial nerve,
Facial
right?
nerve.
Yes,
Lovely.
facial.
So I know I've not done it, but just for you to have an idea about that circle of Willis. Do you get it? By the time we are done with them and you are solving this question in your past question, it will make a lot of sense to you. So there is facial nerve in this question. They now say that 2/5 muscle strength in the left upper limb and 4/5 muscle strength in the left lower limb. Well, there is weakness, definitely. Right-sided strength and visual field examination are normal. Which of the following label artery is most likely occluded in this patient? So where do you think the lesion in this patient is? Anyone?
J.
Hello?
Hi.
Where do you think the lesion? What are the points you
I
wrote
think it's
down
J.
in that question? What's the points you wrote down in that question?
Um,
Facial nerve, facial weakness.
Okay, no
facial
problem.
nerve weakness.
I just hope that this is not too early to solve this question now. That's my point.
It's
Because
okay.
no, it's not okay. It's not okay. The reason is that I need to show you how to be analyzing. Let us leave that question. We'll
I
come
think
back
it
to it soon.
affects the pons also.
So let me see another question. You are going to come back to that question and look at it. The reason is that I need to show you how to think with respect to brainstem. So
Okay.
if you don't understand how you analyze brainstem question, I will be the one giving myself a day, because you will just be looking at me, and some of you will be nodding, other will be shaking their head and be like, this guy is complicating this matter. Now, so look at this last question. I hope it's not, there is no image here anyway. Okay, but there is a point here. Ignore this question. You will solve them later. Just have an idea, because this question is integrated into where we are going to next. So have an idea about the circle of Willis and this brainstem. That's all I need you to do. Dura venous sinus. So very soon we are coming back to it. Don't forget what I told you. We are coming here. That's where we now start digging deep into all of them. Do you get it? So just relax. Dura venous sinus says they are all there. They have their own names and the likes. So the bottom line here is this. The bottom line here is this. You have this dura venous sinus. This is it. Then you have what we call arachnoid granulation. Arachnoid granulation. So this arachnoid granulation, just let us represent with this, is bringing the CSF in it. So when the CSF reach this arachnoid granulation area, this granulation or this finger-like stuff, CSF is supposed to be absorbed into the dura venous sinus. And dura venous sinus will now carry it away. You now imagine that there is a thrombus that is blocking the dura venous sinus. That dura venous sinus cannot drain again. Blood will start building up here. Even arachnoid granulation cannot empty CSF into it. CSF will now start backing up and start piling up. In all the ventricles, you start seeing dilation, 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 and dilation. So there will be symptoms and signs of raised ICP. But this does not still tell you that there is a dura venous sinus thrombosis or venous sinus thrombosis in this patient. I can see raised ICP in any condition that's related to that can raise the ICP. There is something, two things you will look for in question that will give it out for you. One, can I see something related to thrombus in this question? You read the question, you are seeing something like D dimer is high, that one is high, the other one is high. Thrombus is definitely formed in this patient. I'm also now seeing something related to raise ICP. Then I'm like, the CSF flow is blocked in this patient because of that thrombus. I'm seeing something related to thrombus is formed, like they are talking about fibrin degradation product. They are talking about D dimer. They are talking about, you already know there is a thrombus here. You now check the question again, you are seeing raised ICP, then the flow of CSF is affected. Or you say, what do you call it? Or you say the intracranial pressure is increased, which may be related to any other thing. How will I be able to narrow it to the flow of CSF? And now check the ventricles. All the ventricles are dilated. What? Ventricles are dilated. I'm seeing thrombus. I'm seeing fibrin degradation product signal. Thrombus being formed signal like FDP, D dimer in the question. Until proven otherwise, you start thinking towards venous sinus thrombosis. So this thrombus that is formed, this is the CSF that is flowing. When it reaches this region, arachnoid granulation should empty the CSF into the dura venous sinuses. But if there is a thrombus, even that sinus blood is not flowing there. You start having what you call arachnoid granulation scarring. This place will start becoming thickened. because of the high pressure within the vein, thickened, thickened, thickened. So CSF cannot flow through it into the sinus. Again, CSF will now be accumulating in the ventricles. Majority of the ventricles will now dilate out. Do you get it? So that will just be what we give it out for you. So there is no stuff here. It's all about you starting to merge together the knowledge you've accumulated over time in your hematology about the thrombus. Then you merge it with raise ICP. So let me just show you, give you, just for you to have an idea of the way the thing will come. They give you this question. A 38-year-old woman comes to the emergency department because of progressive headache, blurry of vision, nausea for 1 day. 4 days ago, she was diagnosed with right middle ear infection. She appears lethargic. Her temperature is high. Blood pressure is 148/95. Ophthalmologic examination shows bilateral swelling of the optic disc. That is one of the signals we see that tell us that this patient is having raised ICP. We call it papilledema, optic disc swelling. The corneal reflex in the eye is absent. Sensation to touch is reduced on the upper right side of the face. Now tell you again that serum study shows increased concentration of fibrin degradation product. There is no way they will set a question for you that will be going towards all these thrombosis in the venous sinuses, and they will not put fibrin degradation product or D-dimer in that question. If D-dimer is not there, don't think in that line of thrombosis in the dural venous sinus. Don't think in that line. That's one. All these D-dimer fibrin degradation product bring you closer to that kind of diagnosis. If they are not there, don't even think in that line. And that is just all you check for him. Immediately you are seeing fibrin degradation, just a thrombus is formed. If the thrombus is formed, I'm also seeing something related to raised ICP in this patient. Then definitely this is cerebral venous thrombosis, Shikena. You pick your answer and just go. So it's not as difficult as you think unless you are overthinking about it. So I will leave this area and go to the next one. The causes of the thrombus, they are just the one they put here. And I don't think they will put any of them in the option and you will not know that this is likely to be the cause. Because factor 5 leading, I don't think that one will be a big deal to you. You already know what's going on with that in the hematology. OCPUs, I've mentioned that. I've also mentioned this again when we are doing the reproduction. So just merge it to everything you've done in hematology. That will give it out. Ventricular system. There is no big deal here. Don't make any big deal out of this. You already know. All you need to have at the back of your mind is a picture they are putting here. Any of them anyways. So now pay attention to this. These are the lateral ventricles. This is your third ventricle and this is your fourth ventricle. CSF are produced by the specialized cells or structure of, you call them choroid plexus. They are the ones that produce all these CSF. So when these CSFs are produced, can you see? They fill the lateral ventricles. Then they come out of the lateral ventricle to the third ventricle through a foramen here, each of them. So you call that foramen interventricular foramen. So for both of them, you call them those foramina interventricular foramina of Monroe. So the Monroe is not a big deal for you. If Monroe is going to be rolling on your tongue, please, you can forget it. Just remember interventricular foramina. You can forget about Monroe. But if you like Mr. Monroe very well, you can still add it to it. CSF will come into the third ventricle. And from the third ventricle, it will pass through a dot. We call it a dot, small dot. That is cerebral aqueduct of Sylvius. Aqueduct of Sylvius is aqueduct of, cerebral aqueduct is cerebral aqueduct. If that Sylvius there is not going to be sieving out of you, just forget about it and just remember cerebral aqueduct. So and come through that cerebral aqueduct, it comes to the fourth ventricle. Now, get this. When it gets to the fourth ventricle, it can continue into the central canal, and some of them will be absorbed, will leave the central canal. Some of them will leave the fourth ventricle into their subarachnoid space. Through which channel or foramina are they going to live? We have two lateral ones and we have one medial one. The two lateral ones you see, they are the foramina of Luschka, lateral foramina. The medial one, through which the CSF will live into the subarachnoid space, is actually the foramen of Magendie. And these are just the two. Now think about it. This is now your question. These guys will now come and just tell you that the two lateral ventricles are dilated. Nothing happened to third though. Nothing happened to fourth. Nothing happened to any other region. These guys are just dilated and filled with CSF. What do you think is going on? Your diagnosis will be interventricular foramina are blocked. So CSF cannot leave them to come into the third ventricle. That is question one. The question two, the two lateral ventricles are dilated. The third ventricle is also dilated. Nothing happened to the fourth ventricle. Definitely, this patient is having aqueduct stenosis, or is a cerebral aqueduct stenosis. Shikena. So CSF cannot leave the fourth ventricle to come down to the fourth ventricle. So you can see that all the proximal ventricles are just dilating. If the question now tells you the two lateral ventricles dilated, third ventricle dilated, fourth ventricle dilated, likely the foramina of Luschka is blocked. Foramen of Magendie is also blocked. Another possibility is like likely you are having arachnoid granulation scarring, to the point that you don't have reabsorption into the venous sinus. All those dural venous sinuses. Reabsorption is not occurring. Or probably we are even dealing with dural venous sinuses. We are dealing with thrombosis here. And don't forget what you will see in question. I will give out the thrombosis. Do you get it? Dural venous thrombosis. Or you say venous sinus thrombosis. Anyhow you put it. Thrombosis is thrombosis. Don't forget. And that is all about this area. So it's just more of qualitative reasoning. This one is dilated, then likely the opening between this area and this third ventricle is blocked. Two of them are dilated, likely the opening between this third and the lower one is blocked. Everything is dilated, maybe the outflow tract is blocked, or foramina are blocked, or maybe it cannot be reabsorbed into the dural venous sinus or something like that. That's just how you just think about it. And that's all about the ventricle. Let me show you one or two questions just for you to have an idea. Look at this question. They tell you a 45-year-old woman comes to the emergency department due to sudden onset severe headache. On arrival, the patient is alert and oriented and has no facial neurologic deficit. CT scan of the head reveals subarachnoid hemorrhage. Now, I need to tell you something about subarachnoid hemorrhage. Don't forget that around that subarachnoid region, you have your arachnoid granulation. What we discover is that a patient with subarachnoid hemorrhage, those blood will now go and stay on those arachnoid granulation and now block it. It's like someone having a blood covering up a sieve that you are using to sieve your yam powder. Something just cover it and just block it. It won't be able to sieve anything. That's what happened in subarachnoid hemorrhage. It just go to that arachnoid granulation and cover it up, so it can't sieve CSF from that subarachnoid space into the dural venous sinus. It can't sieve it. All right. So that one already give us an idea that, okay, there will be a problem with absorption of CSF from the subarachnoid space into the dural venous sinus. And she is admitted to the critical care unit. Over the next several days, the patient gradually becomes somnolent and less responsive. She opens her eyes to painful stimuli only and does not follow command. Repeat imaging of the brain shows no new hemorrhage, but there is enlargement of the entire ventricular system. Compared to the previous CT scan. Immediately you see entire, you know that definitely this is either I'm dealing with foramen Luschka block, or I'm dealing with arachnoid scarring, or I'm dealing with venous thrombosis. But if the answer will be venous thrombosis, you will see fibrin degradation in the question. Can I see that? You say no, then it's not that. If this is this, what condition is this patient is that I say this patient has subarachnoid hemorrhage, definitely the blood has covered up the arachnoid granulation, and blood, the CSF cannot leave the subarachnoid space into the dura venous sinus. Shaking, the answer will just be impaired absorption of CSF. Shaking. All what they put here, they can have one or two things to do with either subarachnoid hemorrhage or the dilatation that you can have with respect to the ventricular system. So the answer is he. So let me show you one more question just for you to have an idea. Sorry, this is a 9-year-old girl. He's brought to the emergency department by her parent due to severe headache. Let them give you all manner of symptoms. Just a lethargy for meeting. Her symptom began a few weeks ago as mild intermittent headache with fatigue and have progressively worsened. CT scan of the hair reveal a mass lesion, enlarged lateral and third ventricle, and a normal size fourth ventricle. That just tell you that whatsoever I'm thinking about here has something to do with the connection between the third and the fourth. Fourth is appearing normal, lateral and third are dilated. Then this is just all about aqueducts of Sirius or cerebral aqueduct. Shikena. They now say which of the following is most likely site of obstruction in this patient? The answer is cerebral aqueduct. And that's how you pick your answer and go. Just look, which ventricle did you say are dilated? This one. So just do your 1 + 1 and you pick your answer. There is no stuff in neuro. We are just the one creating a headache for ourselves. Let us be going gradually till we finish. Even all the brain tumors, we will look at them, you see the simplicity in them. You are just the one putting a lot of stuffs in your head, all because we are doctors and they say medicine is hard. We just want to complicate it and complicate it for everyone as we see. You don't need to be right. You don't need to be 100% correct. You just need to have a foundation with which you think. Do you get it? It will give you a deckless reason. When you see neuro question, you won't be jittering. All right, look at the brainstem now. These are the brainstem. Probably you might have looked at it and think maybe they need you to know all the labeling. Please just relax yourself. Anytime you hear the word cranial nerves, there is a way you must always be looking at it from now on. The way you look at it, you have all these cranial nerves, they are arranged, most especially the cranial nerve 3 to 12, they are arranged on the brain stems. So there must be a way we look at them. And I want you to pick, first of all, understand this table. I will remove this table for you. You will now draw your own. So you must understand it. And you will put the arterial supply on them all. Now, this is what we have. The cranial nerves, they arrange themselves in two ways. Some of them arrange themselves medially. You will see them around the media, while the others arrange themselves laterally. So the ones, how are we going to know the ones that arrange themselves medially in question? This, and how are we going to know the ones that arrange themselves laterally? We are going to be using two rules. Rule number 1, we have 3 brain stems: the midbrain, the pons, and the medulla. We divide those cranial nerves 4-4. We just look at cranial nerve 1, 2, 3, and 4 and say they are above the pons. They say they are above the pons and not just categorically saying that they are located in the midbrain, because cranial nerve 1 and 2 has nothing to do with midbrain. But 3 and 4 has something to do with midbrain. However, both those ones that have something to do with midbrain and those that have nothing to do with midbrain, they are both above the pons. So we are just going to say cranial nerve 1, 2, 3, and 4, they are found above the pons. While cranial nerve 5, 6, 7, and 8, you find them within the pons. Then 9, 10, 11, and 12, you find them within the medulla. Shaking. That's the rule number one. You just divide them 4. Okay. The second rule is that those that are of the factor of 12, the factors of 12, you see them in the midline. Any other number that has nothing to do with 12, that is not divisible by 12, you see it in the lateral. Now let us draw our table. You are now going to draw your table like this and put lateral, medial, medial, lateral. So this is just the midline. This is the right. Let us put this one as right. This is the left. So you will see medial, left medial. You will see left lateral. You will see right medial, right lateral. It's still the same thing we want to do. This is just to show the midline. Do you get it? Midbrain. We are going to remove cranial nerve 1 and 2. They have nothing to do with brainstem, so we remove them. So we are only left with cranial nerve 3 and 4. So midbrain will be dealing with cranial nerve 3 and cranial nerve 4. While the pons will be dealing with cranial nerve 5, we'll deal with cranial nerve 6, we deal with cranial nerve 7, we deal with cranial nerve 8. While medulla will be dealing with 9, we'll be dealing with 10, we'll be dealing with 11, and we'll be dealing with 12. You now ask yourself, is 3 divisible by 12? And is 12 divisible by 3? You say yes, then it's going to be in the midline, medial. Is 12 divisible by 4? You say yes, then it's going to be in the midline. It shows that we do not really have any cranial nerve in the lateral for the midbrain. Then you come to the pons. Out of all these numbers, 5, 6, 7, and 8, which one can divide 12? You see, out of all of them, it's only 6 that can divide 12. Then 6 is going to be the one on the medial. Others, they can't divide 12. You put them on the lateral. You come to the last one here. You look at these numbers. Out of all these 9, 10, 11, 12, which of them can divide 12? Say 12 itself can divide 12. Then that 12, you put it on the medial. All the others, they can't. You put them on the lateral. So if we now talk about a lesion affecting the medial part of the midbrain, I already know the cranial nerve that will be in the question. If the question talks about a lesion that affects the medial part of the pons, I already know the cranial nerve that will be in the. In fact, I can predict the way the patient will present. I will just say the patient will present with inability to abduct the eye. Lateral rectus will be affected. All because I know this is cranial nerve 6, and cranial nerve 6 supply the lateral rectus of the eye. If the question talks about the cranial nerve 12, medial part of the medulla, I already have an idea of the cranial nerve that will be affected. Which cranial nerve is that? Cranial nerve 12. The same cranial nerve that supplies the hyoglossus, the genioglossus, and styloglossus. The patient may be having problem protruding the tongue, retracting the tongue, or making a trough out of the tongue. Cranial nerve 12. So if it is the lateral, I already have an idea of the cranial nerve that will be affected in the pons and that of the medulla. Shikena, you are the one giving yourself headache. Now, what about the vessel? We were jokingly drawing a diagram the other time, and I was telling you try to draw it. For those that drew it there, I know they won't ask me any question. Okay, you now just imagine if you close your eyes, you must be able to picture the diagram you drew. And know that, okay, we first of all say that the vertebral artery come together, form the basilar artery. This one now first of all has this superior cerebellar, then now have the posterior cerebral. We also have another branch at the lower part of the basilar. You call that anterior inferior cerebellar. We have another branch here, posterior inferior cerebellar. Then we have the central part, anterior spinal artery. So this area is for the pons. This area is for the pons. This is for the midbrain, and this is for the medulla. So if the question talks about the lateral, which artery will supply the lateral part of the medulla, I already know that this is going to be related to something like this spica. But if you draw this your diagram very well, this is how the vertebral artery are too. They will also supply the what? The lateral part, shaking. That's why you see pica and vertebral. I mean, the vertebral artery, pica and vertebral artery here. What about the media part of the medulla? Anterior spinal artery, anterior spinal artery. So what about the pons, lateral pons, anterior inferior cerebellar artery, ICA? What about the medial part of the pons, basilar artery, basilar artery? What about the medial part? In fact, you see, with respect, I don't want you to complicate it for yourself. You have two vessels here, and I told you before, look at it lower upper. The major vessel supplying the midbrain is the posterior cerebral artery, whether lateral or medial, shaken up. And that's how you deal with the brainstem view here, anytime you are given. Do you want to try it on your paper? People that are with me, do you want to try something on your paper? Do you want to try it? Do you understand me?
Do you understand? Yes, yes. Yes, thank you.
All right. Okay, let me give you 2 minutes. I will remove this stuff. Now, draw the table by yourself. Do the thinking, because in the exam, you will be left alone with God and your hard work. So you can try to draw that. You should be done by now, right?
Yes.
Okay.
Yes.
Yes.
Definitely. So that's what. So don't forget that diagram you drew by yourself. You will see what the diagram will do for you in the exam. Because when they give you the question, you will not never forget. You will never miss it. Okay, that's just about this. What about, is there any? That's just all you want to note here. Very well. I put a diagram here. I am going to, let me just try to, let me see the kind of question I even put here.
Dr. Festus, when you look at that for the medial parts, for the midbrain,
Mm,
which is cranial nerve 3 and 4,
mm.
you know, in the process of drawing it, I was just thinking of that is, it looks more like being served by the posterior communicating artery, because that looks more medial than the posterior cerebral artery.
I don't
You,
get your point very well.
I said, 3 and 4, cranial nerve 3 and 4 that we find in the midbrain.
Yes.
You know, as I was trying to place it in the circle of Willis, it looks more like it's something that is fitting into the posterior communicating artery than the posterior cerebral artery.
Okay.
So,
I,
yeah.
I get your point, but it's actually the posterior cerebral artery that
Okay.
supply the all those regions, the midbrain. This is still about the brainstem.
Yes.
Yes. Okay. Okay, it's all right. So we are going to see later some other vessels that they are going to put there. I will be showing you those ones here, or this area. Do you get it? So you will be able to understand why they present the way they present. Where is it? So why they present the way they present. So all these stuff, you will be the one to write all of them by yourself. Do you get it? So just relax and let's go through what they put here. I think, is there anything I'm leaving out here? All right. So don't forget, please. I want to merge this, your knowledge now, with something else so that it will make sense to you. We just talked about the arrangement of those cranial nerves. What about the tracts? What about the tract? Okay, the midbrain, those cranial nerve 3, oculomotor, that's the name. Cranial nerve 4 is trochlear, 5 is trigeminal, 6. I want you to pay attention. I want to explain this one twice. 6 is abducens, fascia is just, 7 is fascia, 8 is auditory, 9 is glossopharyngeal, 10 is vagus, 11 is spinal accessory, 12 is hypoglossal. So this is just to give you a glimpse. We are not looking at each of them the way we are supposed to, but just for you to have a glimpse of what is cranial nerve we do. Oculomotor, eye will turn out and downward. We've done that one before. I showed you how they came across that. Trachea, LR6, SO4, that's superior oblique. So the patient will not be able to look down when looking towards the nose. If you remember the diagram, you see that I put my superior oblique towards the nose. So if that superior oblique is damaged, the patient will not be able to look down and towards the nose, like you reading. You will just see them say that when the patient is reading, the patient used to have diplopia. Something is wrong. But when the patient is looking at other direction, no issue. They show that it shows that superior oblique is actually having issue. So you start thinking towards something like trochlear nerve, cranial nerve 4. What about the trigeminal nerve? All the cranial nerves that you are going to be seeing, they are all ipsilateral in their lesion manifestation. So ipsilateral. So what I used to do, and what I will advise you to be doing, is that when you read the question, you don't know whether right, left, you are even confused. Yeah, is corticospinal this? Is that one? Just locate the cranial nerve there. Once you start seeing that the patient is having left facial nerve, less facial, maybe drooping or something, you just know that the lesion here is on the left. Shikena. You can use the cranial nerve lesion as a window to know, is the lesion on the left part of the brainstem or the right. Because when they mix up all those tracks, you may be confused. Your escape route is the cranial nerve, because they are always ipsilateral in their manifestation of the lesion. The abducens, you know that one. Ipsilateral high abduction weakness. When they say, you abduct, they cannot abduct. What of fascia? Ipsilateral facial weakness and drop. What about auditory? Ipsilateral deafness. Glossopharyngeal. Ipsilateral pharyngeal sensory loss. Something related to the pharynx. That's why they call it glossopharyngeal. Unless you want to change the name. What of vagus? Just ipsilateral palatine weakness. Something related to the palate. What of spinal accessory? Ipsilateral shoulder weakness. They cannot stroke the shoulder. So hypoglossal, ipsilateral weakness of the tongue. Shikena, all of them ipsilateral. So you can easily imagine this. So that's just about their manifestation. Let us merge it to the tract. Now, all the tract you will be using, this is not exclusive. So no one should ask me about spinocerebellar something tract. So don't, or just this basic tract, just how you are going to be These are the ones you want to bring out of the questions. We have some tracts that are only seen in the midline. We have some tracts that are seen on the lateral. The ones that are seen in the midline, they usually start with M. The ones that are seen on the lateral, they usually start with S on the side. S. So when you read the question and you can categorically say that this patient is having a motor tract affected, then that is midline. That is media. You can categorically say that this patient is having motor nuclei affected. That is media. So what are these motor tracts? There are two major motor tracts you don't want to forget in your life. Corticospinal, corticobulbar. Corticospinal deals with the motor of like the whole body. Bulbar deals with when you talk. When the patient talks, it deals with like ability to talk, to make all those sound and different kind of things. That's bulbar. All right. What of the media lemniscus? That one is also starting with M. Media lemniscus. That is contralateral, loss of proprioception and vibration. These two tracts, they cross. They cross. So you will see contralateral, loss of proprioception and vibration. Then motor, contralateral weakness. You can see these two are contralateral, but will you be able to remember in the exam? That's why you need your cranial nerve. But corticospinal, contralateral, medial lemniscus, contralateral. Maybe you can look at the scus and core in their name. You can use it as, okay, contralateral. Corticospinal, corticobulbar, contralateral. Medial lemniscus, contralateral. At least cos is coming out of the name. Contralateral. Loss of proprioception and vibration. Proprioception is just telling you, I move your thumb up. Can you know that your toe up? Can you tell me that your big toe is pointing up? You say yes, proprioception. I am moving it down. Can you tell me that your big toe is pointing in downward direction? You say yes, proprioception is correct. So they are all by medial lemniscus. Where is the name coming from? Please don't ask me where and don't bother me now. I can show you that later. Just for you to note this. What about the medial longitudinal fasciculus? We can't see any core in this name. Medial longitudinal fasciculus. There is no core there. So fasciculus is different from medial lemniscus. So fasciculus, ipsilateral, internuclear ophthalmoplegia. Motor nucleus and nerves, ipsilateral motor cranial nerve loss. So what are these motor nuclei? They are just the same ones you see at the center. Cranial nerve 3, cranial nerve 4, cranial nerve 6, cranial nerve 12. They are all motor. These ones, they are sensory. So I already have an idea of those ones that are motor. We also have some of them that are both motor and sensory. Don't bother yourself about them now. So, but at least if you draw this table, you'll be able to say cranial F3 is motor. It has some motor function. 4 has motor function. 6 has motor function. 12 has motor function. So that's another important point you want to note. Where is the diagram I was using to? Sorry. Okay, so that's that about the media. So you can pick your pen and just write the media structure you are looking for in question. Motor pathway, corticospinal, corticobulbar. Media lemniscus. Media longitudinal fasciculus. Motor nuclei. So you must write this 4 out over and over. That's when it will stay. Those ones that you can see core in their name, corticospinal, corticobulbar, they are contralateral. What of the lateral one? They all start with S. spinocerebellar, spinothalamic, sympathetic, sensory nucleus of cranial 5. Spinocerebellar, spinothalamic, sympathetic. Sympathetic will give ipsilateral ulnar syndrome. Spinothalamic will give contralateral pain and temperature loss. Spinocerebellar, you know, I told you cerebellar lesion, they always give ipsilateral. This one will give ipsilateral ataxia. Cranial nerve 5 is only used most of the time in question to lateralize the lesion. When you see cranial nerve 5 in a patient that is having cranial nerve 3 and 4, no, cranial nerve 5 in the question that is also having cranial nerve, something related to cranial nerve 5, I mean something related to cranial nerve 9, 10 and 11. Cranial nerve 5 is also there. You are like, is this in the pons or the medulla? 5 is related to the pons. Majority of the other cranial nerve, they are in the medulla. Is this lesion in the pons or medulla? Never forget, cranial nerve 5 most of the time is used to lateralize the lesion, just to tell you that this lesion is on the lateral. So you can see it in any of the brainstem affectation. If they like, you may see it there. It's only used most of the time to lateralize. So if they are telling you it's a lateral pain and temperature loss in the face, because that's what cranial 5 supply the face, so you start thinking towards there is a lateral lesion, shikena. So you want to, let me give you 1 minute to draw this table. Just try to draw it by yourself. If at all you want to try, you can look at the table, you can draw it just to play around them. But make sure as you are drawing, you are also thinking along the line. I give you 2 minutes to do so.
I'm sorry, Dr. Professor, what's HNO again?
Internuclear ophthalmoplegia. What are the components of ulnar syndrome?
And we'll have ptosis, meiosis, and anhidrosis.
So when you see them in question, you already know what they all stand for. Please don't forget. By now, it should be done.
Then the that medial longitudinal fasciculus, how would it now present? The one that causes the intranuclear ophthalmoplegia.
So they just have problem with conjugate eye movement. Don't worry, we are going to solve some questions. I will show you. Conjugate eye movement. Problem with conjugate eye movement. Do you know the meaning of conjugate eye movement?
Yes, like the one we find in what's it called? Is it the cortical region?
You wanted
Where,
to say frontal eye field.
sir?
You wanted to say frontal eye field
Frontal eye field, yes. Front, is it front?
before you gave it another name. It's frontal eye field lesion.
Okay.
Okay, so don't worry, I will show you how you apply all these things in question. But have you all gotten it? So you now need to bring out your pen and paper. So let me take you through a journey. Sorry, this is neuro for you. So I just need to be a bit slower so that you'll be able to master it. At least you won't miss it up. But have you been getting it for those that have been with us?
Yes.
Others don't know whether they are getting. Dr. Paulette is not sure
Yes.
of the category she belongs to.
I'm getting it.
Okay, let us put all of them together in the question. So I don't need to be correct. So I just want you to get it. You may even get it better than the way I understand it, but you should be able to get it better. Solve more questions. I actually hardly solve more questions nowadays as such, but you are practicing actively. Please solve as many questions as you can. It will help you out. So let me take you through these questions. Let us try to solve just like maybe 10 questions here or less than that. So I will project the image for you. You bring out your answer. I will read the question to you. Brainstem 2, brainstem 1. So be ready. So what you are going to be doing is that when I am reading the question to your hearing, you will be analyzing, bringing out the symptoms. Do you get it? And I'll say that this is the cranial nerve that is affected. This is this, this is that. Do you get my point? I know you get it, even when
Yeah.
you talk.
Yes.
Oh, yes.
So I'm also going to be doing my own here so that we are all on the same page. So a 34-year-old man is evaluated in the clinic due to persistent buzzing in his right ear for the past 6 months. So this patient is having persistent buzzing in the right ear. Just be writing it down like that. Use something like point, point, point. The patient also has decreased hearing on the right side. Decreased hearing on right side. Nothing. He has had no fever, ear pain, running nose, sore throat, or cough. The patient does not use cotton swab and has not been exposed to loud noise. He tried using over-the-counter pseudoephedrine with no improvement in his symptoms. On physical examination, there is no sinus tenderness, and mucous membrane are moist without erythema or exudate. Otoscopic examination revealed normal appearing external auditory canal bilaterally with pinkish gray tympanic membrane. MRI of the brain revealed an intracranial tumor. The patient's lesion has most likely arisen from which of the following structure? So even though we've not really done much about going deep into each of the cranial nerve, which cranial nerve do you think is likely that they are talking about here? Anyone?
Crown of
Vestibular.
head. Vestibulocochlear.
Vestibulocochlear. So which of these cranial nerve is vestibulocochlear here? Which cranial nerve is this? Option B.
Six.
This is cranial nerve 6.
6.
It's medially located. Which one is option C?
Facial nerve.
Seven.
Maybe 7.
Which one is this? Is not maybe 7, because after 6, which number do you want to go to?
7.
7.
So which one is cranial nerve D?
8.
8.
8.
So this is cranial nerve. So cranial nerve 7 can also give something related to the hair. That one usually cause what we call hyperacusis. They will just be having a lot of, as I talk now, I just say Shola, they will hear Shola. It will be loud inside their hair. They will not be like, hey, you are shouting. You can just talk. You are shouting. That is cranial nerve 7 issue. But you will also see something related to other areas supplied by the cranial nerve 7 in the question. Where is your cranial nerve 5? It is the biggest cranial nerve you will see there. So this is your cranial nerve 5. This is your cranial nerve 5. This is your cranial nerve 3. This is your cranial nerve 4. Do you get it? Don't tell me that this 4 is looking lateral. This is still medial because it moves like this. Do you get me? So please note all those stuff. So that's that about. The question is, the answer is D. Let me project another image for you. You now pick your answer in it. Sorry. Okay. They give you this kind of image in your exam. When you see it, don't be scared. So let me read the question. You just want to make a guess where the lesion is. That's all you need. Then it is that you're guessing you will now use to narrow the answer to a particular place there. Do you get it? What is this F talking about? Which brainstem is this F likely to be?
The pond.
Medulla.
Your medulla. Pons is usually this big, and look, you see this bump. Do you get it? That's your pons. It pump out. Do you get it? Above it is your midbrain. Below it is your medulla. Which structure is this leaf-like structure?
Cerebellum.
Which structure is this area? They put as option C. Don't worry.
Pineal.
That's your pineal
The
gland.
pineal gland.
Pineal gland. You can see this black space that is running behind the brainstem. That is your central canal. Do you get me? Your central canal. This is it.
Is that B?
This is your, no, that's not B. So this space behind your brainstem, this black line that you are seeing here, that's your central. CSF is what is flowing there. Do you get me, everybody?
Can you use the cursor to show us?
See my cursor. If I should draw on it, you will not see it again. It's just this black line you are seeing.
Okay.
Behind the, so this is your central canal. It's now bound like this. Can you see? It's continuing like this. So this is it. This is your central canal. So this structure you are seeing here is likely to be your choroid plexus. Choroid plexus. Do you get me, everybody? Producing what? What does choroid plexus produce?
CSF.
CSF. Okay. This structure you are seeing in this head is likely to be your pituitary gland. Do you get me, everybody?
Yes.
Pituitary. So that's that. Now, let me read the question to you. You just tell me the answer you feel. Don't think the question is difficult. There is nothing difficult there. It will continue to be difficult if you are looking at them difficult. And you don't need to analyze them fully. A 4-year-old boy is brought to the office due to headaches that have worsened progressively over the past month and are most severe when lying down. Headache. He also has had non-bloody, non-bilious MSs for 2 weeks that typically occur early in the morning. This patient is vomiting early in the morning, is also having a headache. You start suspecting, what is going on? Are you pregnant? Are you this? But this is a boy. This is a 4-year-old boy. Maybe I'm dealing with a tumor in the brain. You don't know. You don't need to be correct. You are just guessing. In addition, the child has intermittent blurry vision, particularly when looking up at the mirror while brushing his teeth. Anytime the child looks up, the child will have blurry vision. When the child looks down, no blurry vision. When the child looks to the right, not really having blurry vision, but looking up, there is blurry vision. Physical examination shows bilateral papilledema. When you read question and you see bilateral papilledema, what does that one tell you?
ICP.
Raised ICP. So definitely this patient is having raised ICP. And they are now telling us that the patient is having headache. Then likely we are dealing with a space occupying lesion in this patient. Likely, don't need to be correct. All right, inability to gaze upward and bilateral eyelid retraction. I've not told you more. I've not told you a lot of things about the cranial nerve, but definitely you are seeing this eyelid retraction. That one is as a result of lesion to the cranial nerve. Which cranial nerve? 3. Okay,
3.
cranial nerve 3. So we are still going to do it later, but just for you to have an idea. Laboratory testing of sodium, growth hormone, luteinizing hormone, follicular stimulating hormone is normal. So there is nothing wrong with your pituitary here. Given the early morning emesis and papilledema, a brain mass is suspected and a brain MRI is ordered. Which of the following is the most likely location of the brain lesion in this patient? This patient has something to do with cranial nerve 3. So which part of that diagram you are looking at do you think is the answer?
The midbrain.
So which of the options?
B.
C.
B.
C.
A.
C is pons. I mean, D is
It's C.
pons. Is B.
Sorry,
It's
who said
C.
B? Is B midbrain?
No,
No.
Is A midbrain?
no.
I don't understand though.
C is not
But I
midbrain,
thought
actually.
D is the pons.
This is
This is
pineal
a
gland.
region around the midbrain. If there is a mass here, it can compress on the midbrain.
Ah, okay.
Okay.
Even if you say it's not okay, I know it's definitely okay.
I like
So that's just how you see that you don't even need to know the diagnosis. You don't even need to know the name of the mass, even though you want to know it. Piniloma. You don't even need that diagnosis. You just need that your role and just be applying it. You will solve a lot of questions that you don't even know what the patient is having. You just tell them and be like, this is where the lesion is. This is where the lesion is. All for you understanding the role. Shikena. Okay. So let me show you another diagram. Do you get this picture, everyone, now?
Yes, Dr.
Yes.
Festus.
Dr. Precious.
Yes, I get the explanation for this, but the only thing I remember I have is the patient cannot look up. I was thinking of cranial fall. I was thinking of superior rectus.
Okay. Inferior oblique is supplied by what?
LR6, SO4, AO3. 3.
Prayer nerve
Okay.
3.
Superior
Cranial 3.
rectus. So superior rectus is supplied by which cranial nerve?
The sixth
4.
one.
Ah,
Is it LR6?
Prayer
It's
nerve.
Four.
still 3.
Four.
It's
Four.
still
That's
3 now.
four. It's
It's
Superior
not
still
oblique
clear
3.
4.
nerve.
Others, it's still 3.
3. It's still
everyone that
3.
fought for me, God will fight for you too.
It's still
Dr.
3.
Lunati, Dr. Paulette, Dr. Antonia, you that fought for me, God will fight for
Is
you.
is it not SO4?
Amen.
And
Dr. Precious, have you gotten it?
SO4, okay, SO4 is superior oblique. Okay, sorry, it's 3. Sorry. It's 3. Look.
All right. So that's that about that. Let me show you another question. Let me see if I put that question as a diagram. No diagram. Let me project my page back so you can follow back. So you don't need to know the diagnosis of some of your questions. So when you are doing your step 2, you start looking at this is all about basic. This is all about basic. All right. So look at this question. Are you seeing my okay? You are seeing. A 3-year-old boy is rushed to you after he is found underwater in the bathtub. His parents say the patient was left alone for 5 minutes. On physical examination, he does not respond to painful stimuli and is pulseless and not breathing. Okay, he's pulseless and not breathing. Cardiac rhythm is asystole and spontaneously return after several minutes of resuscitation. While performing endotracheal intubation, stimulation of the posterior pharyngeal wall with laryngoscope elicit no soft palate or gagging. Which cranial nerve do you need for that soft palate movement?
Marcus.
is
Cranial nerve
10.
what? Third.
10.
10.
Third. Then gagging. Which cranial nerve do you need for gagging?
9.
Is 9.
We
9.
9.
can't see any gag. We can't see any third. Where do you think the lesion is likely to be? Anyone?
In the
10.
medulla.
In
Going to
the
be
What do you
medulla.
mean by
medulla.
medulla? What is
Medulla.
medulla?
Medulla.
What's
Lateral
Lateral
medulla.
medulla.
lateral medulla? And that's all. So if they are specific about this question for you, they just ask, where do you think is the lesion? Just say lateral medulla. You pick your answer and you go. Can you see that it's actually simpler than you think? So, and they are not even asking you about whether medial or lateral. Just pick your medulla oblongata and go. Okay, see this question. A 56-year-old man is brought to the emergency department due to weakness and difficulty speaking. Okay, This patient is having weakness. He's also having difficulty speaking. Wow, I've not explained this one to you. Okay, this is another area entirely. Are we okay, let's finish it. Let's do it. I will use the opportunity to just explain to you. So which tract do you think is affected in this patient? Difficulty speaking, there is also weakness. Oh yeah, please talk.
Corticobulbar, corticospinal.
Corticobulbar speaking, corticospinal weakness. Do you get it? Everyone?
Yes.
Lovely.
Yes.
He has a
Yes.
history of hypertension, cigarette smoking, and holy substance use. The patient experienced a headache while smoking crack cocaine the previous night. This morning, he was found on the bed, unable to move or speak. On physical examination, the patient is awake with normal pupillary response. Vertical eye movement are intact, but horizontal eye movement are impaired. What do you need for the horizontal eye movement? Lateral rectus and
Yes.
medial rectus. So
Just.
we are seeing something related to cranial nerve 6 is involved. Are you with me, everybody? The medial rectus
Yes.
is cranial nerve what?
Yes.
3, but we don't know
So,
where the patient is moving the eye to. Do you get it? You don't know where the patient, but definitely the what do you call it? Definitely something is wrong. Is wrong with either cranial nerve 6 or 3, but you don't know which of them is affected. Do you get my point? Love, because these are the ones that deals with horizontal, but they are telling you that vertical eye movement are intact. It shows that it can be cranial nerve 3. It's only cranial nerve 6. Do you get the analysis I did there, everybody?
yes.
Yes.
That yes is not concentrated enough. Do you get
Sorry,
the
can
Yeah.
you
analysis?
explain that last statement
All
again?
right. Vertical eye movement. You know that you, with respect to the vertical eye movement, you have your LR6,
Yes.
SO4. I'm coming. AO3. I just put A3. Okay. So lateral rectus is horizontal. Superior oblique is like related to vertical, and all other supplied by the cranial F3 are also horizontal and vertical. But they tell you vertical is okay. Definitely nothing is wrong with cranial F3, nothing is wrong with cranial F4. But horizontal is affected. Definitely the cranial F affected in this patient is 6.
Yes.
Do you get it? Because
Yes.
Oh, yes.
Yes.
horizontal is
Yes.
both 6 and 3. So I don't know which of them, but I now look at, is there any other loss of function of cranial F3? They say it's not there, then it's not 3. Do you get it? If it's 3, you also be seeing some abnormality with vertical eye movement. Do you get it?
Yes.
Okay. There is loss of motor strength in the upper and lower extremity bilaterally. Ischemic infarction from cocaine-induced vasospasm is suspected. A lesion involving which of the brain region is the most likely cause of this patient's current condition. So which cranial nerve are we dealing with here? Cranial nerve what?
6.
6.
Which
Six
tract are we dealing with here?
is media,
Corticospinal and
So
middle.
Corticospinal.
so the answer should be
medial.
something like media pointine lesion. Do you agree with me?
Yes.
Yes.
Lovely.
Yes.
So another way they write your media pointine lesion is like this, and there is a way that you characterize it. That's what brought out this diagram here. Corticospinal. This is your corticospinal tract. This is your pons. Corticospinal tract. This is your cranial nerve 6, and you have another cranial nerve 7. So most of the time, you see the corticospinal tract will be affected, cranial nerve 6 will be affected, and you may see corticospinal tract on one side, cranial nerve 6 on the other side. All of them, you can have one manner of manifestation, just involving cranial nerve 6, whether on the same side or another side. They are sharp being affected. You call that ventral pointine lesion. So that ventral pointine lesion or ventral pointine syndrome, they give it another name that you don't need to know it. Millard Gobler syndrome. So one of the classical crossed brainstem syndrome. You just see corticospinal on one side, cranial nerve on the other side. You just be like, okay, how come it's not the cranial nerve on the same side? How come it's the cranial nerve on the other side? That is ventral pointine syndrome. Do you get it? Ventral pointine syndrome. That's just one thing you will notice. So whether the question specifically tell you that the corticospinal on the same side or cranial nerve 6 or 7 on the other side, or they shall switch themselves, or they are not switching, just know that it's either you are dealing with media or they just go and put that ventral pointine syndrome there for you. And that's all. And there are two cranial nerves you may see there. Cranial nerve 6 in question and sometimes cranial nerve 7. So that when you see the question, you are not lost. You still have an idea that, okay, even though cranial nerve 7 is there, but I'm saying corticospinal cranial nerve 6, even though they are still putting 7 there, this is looking more like ventral pointine syndrome. Shikena. That's all what I want you to pick. Even though 7 is there, don't forget that 6 is supposed to be media, but even though 7 is also there, you just put it on ventral. Do you get my point? But if they want you to say that this is media, cranial nerve 7 will not be in that question. It will still flow with the way you have understood it. So that's just that. Let us put it like that. I pray that you've listened to me concerning my explanation there. All right, that's why the answer to this question is going to be the ventral pointine, because you can see corticospinal, corticobulbar, then you can also see cranial nerve 6 being affected. The answer will be ventral. So they just choose not to put media there, but it's ventral. Look at this question. Brainstem 3. So this is the brainstem they are giving you, the brain structure image they are giving
Oh,
you.
sorry, Dr. Festus. So it is ventral or medial because the motor functions are involved, the motor tract, the corticospinal and bulbar are involved, right?
Okay,
And
the
then
explanation I just explained now
it
is
is
that
false because
I give
okay.
you an explanation about the term called ventral pointine. That's another concept. I wanted to ignore the question, but I say let me just use this question to explain to you. Ventral pointine, it has its own characteristic. And what is the attributes you see in question? I will tell you that this is ventral pointine. Corticospinal will be affected. You also see something related to cranial nerve 6. You can also see something related to cranial nerve 7. The corticospinal and cranial nerve 6, it may be on the same side, it may be on the other opposite side. That's what you call cross lesion syndrome. Because how come corticospinal is on the right that is affected, cranial nerve 6 is on the left that is affected? So I just want you to have an idea of the all manner of ways by which question of ventral can come. If it's only corticospinal and the cranial nerve 6 you are seeing, and you can see any cross lesion there, that is, one is affected on one side, the other one is affected on the other side, they will not be putting ventral in question. It's media they will be putting there. Do you get it? You will be seeing something like media. So just for you to have an idea about the ventral, and thank God you are thinking towards the media, but you can't see any media in that option of the question we saw. The only thing you could see there was what do you call it, ventral. You now say that, okay, this is likely to be the ventral, and that's all. There is no any other answer that is conflicting that. So this is the image they are giving you in this question. I'll just read the question to you and you pick your answer. So the image here is telling you that a 64-year-old man with a history of uncontrolled hypertension come to the emergency department due to sudden onset right-sided weakness. Blood pressure is 170/106. Examination shows left facial weakness affecting the forehead and lower face. So left facial weakness, which cranial nerve is that?
Right facial nerve.
I don't understand. Who said that? Dr.
Five.
Akinwumi?
7.
Cranial nerve
7.
5.
Cranial nerve
Ipsilateral cranial nerve 7.
Which one is ipsilateral cranial? Which cranial nerve is affected in a patient?
7.
7.
7.
A patient manifests left facial weakness. Which cranial nerve?
5.
5.
Don't talk again. No one should talk again. This patient is having left This patient is having left cranial nerve 7 affected. They already told you left. You need to bring out, because that is actually what you are looking for.
Okay.
Forget about the diagram you are looking at. You need to think in line with the way they are setting the question. I already told you that all the cranial nerve will give you ipsilateral manifestation. Someone say ipsilateral. Is there anything like ipsilateral nerve? So you just, you have already seen left facial weakness here. Then you just say that left cranial nerve 7 is affected. Just put it there. I already know where my cranial nerve is. Then affecting the forehead and the lower face. They now say we are not doing all this. Is it affecting the forehead? Is it sparing the forehead? We have nothing to do with that, because we are not dealing with. We are just using it to narrow our lesion towards a particular part of the brainstem. So forget about the upper motor neuron or lower motor neuron here. Muscle strength is 3/5 in the right upper and lower. So this is right upper and lower. So where do you think the lesion is? Left what? Corticospinal. Because this is weakness in upper and lower. So left corticospinal. Deep tendon reflexes are brisk and Babinski sign is present on the right. A midline sagittal section of a normal brain is shown to you. This patient lesion is most likely located at which of the following anatomical? So despite them giving us cranial nerve 7, corticospinal, they are giving you and left and left and left. They just give you that simple diagram. So which part of the brainstem do you think this lesion is? You start thinking towards something like what? Pons.
Pons. It's going to be D.
Which D? The answer will not be D. Okay, let me read this question to your hearing, and I want you to analyze it and tell me your answer from there. A 70-year-old man is brought to the emergency department due to sudden onset weakness in his right arm and leg. Although he can speak, he cannot produce words clearly. Blood pressure is once. So this patient can speak, cannot produce words clearly. And this patient is also having sudden onset weakness in his right arm and leg. Weakness. Right arm and leg. I need to be writing in that, because before you tell me wrong answer, so I will also be able to think along. Okay. Blood pressure is 170/96, pulse is 80. The patient is alert and oriented. Neurologic examination shows 3/5 strength in both right upper and lower extremity. When the patient is asked to stick out his tongue, it deviates to the left. What? It deviates to the left. So tongue deviates to the left. Okay. Sensory examination shows no abnormalities. Which of the following is the most likely location of this patient's brain injury? So, before you tell me your answer, let me write my own down so that I'll be able to. So, let me tell me all the tracts that are affected in that patient.
The corticospinal.
Not yet. And that answer is even wrong. So think about the answer again before you say it.
Oh, okay. It's motonuclear, sorry.
So which tract is affected there?
The motonuclear.
So what are the tracts that are affected in the question I just read to you? This patient cannot speak. Speak, cannot produce words clearly.
Corticobulbar.
Okay. And this patient is having weakness on the right part of the body.
Corticospinal.
Don't say that. Don't say that. When you hear right side of the body, it's not just about. If we just say he's having weakness, that's another ball game. But for them to put right or left, yeah, you must qualify.
Left corticospinal.
Left corticospinal.
Exactly. Left corticospinal. Because if you don't start doing it that way, you will not be So left corticospinal. This patient cannot stick out the tongue. I mean, when the patient stick out the tongue was deflating to the left.
Left
Cranial
side
nerve 12.
was
Is that not motonucleus?
Okay.
is
Let me
motor
just be saying them so you can just be noting the point down. This patient cannot, when the patient stuck out the tongue was deflating to the left, and all the cranial nerves they give ipsilateral lesion. Then definitely this is left cranial nerve 12. I already have an idea of what is going on.
pulse.
So left cranial nerve 12 is affected, left corticospinal is affected, definitely. If I'm also making reference to the corticobulbar, it's also going to be left corticobulbar. So that's all. I'm already done with all the tracks. So I already know where this lesion is. Cranial nerve 12 is related to medulla, medial
Medulla.
to medulla. Then that's why this patient is having left medial medullary syndrome. The answer will be left medial medullary syndrome. Okay.
Oh,
So I just want you to please look at things the way I asked you to be looking at them. So that I will know that you are actually learning. So I know you've read, but all those things you've read, you can first of all just put them one side so that we'll be able to be on the same page. So all those simple things I'm asking now, that you should not forget to put this one there. Don't forget to put that. If you are not still getting them, I feel like you are just there, you are not listening to me. All right. Let me project let me see. Is that
So, Chief, the answer is E, right?
which
In this
E?
diagram.
Yes, it should be E.
It's not related to
Okay.
that diagram.
Diagram.
I
Oh,
read the
okay.
question to your hearing. So I'm going to
Oh,
read another one to your hearing. You tell me what the diagnosis is. You pick your pen and paper
okay.
and you bring out the clincher. I just use that diagram to be distracting you so that you will not just be
Okay.
telling me the options.
Dr. Festus, please, I need clarity on something. You know, you gave us a table, and based on that table, that is what some of us are using. And that patient couldn't talk, and then because of the motor weakness. But I'm still a bit confused about that cranial nerve 12. So are you saying we shouldn't add motor nucleus to it?
The cranial nerve 12 is there. Left cranial nerve 12. We mentioned it. You get it. It's everything. We have already analyzed all the whole table in the question. That's the cranial nerve 12. Is there. We just say left cranial nerve 12 is part of it. And that one just tells us that this is media. Because 12 is actually divisible by 12. So you
Yes,
get
I
it. So it's
understand
media.
that.
Yeah,
Yeah.
that's what the whole analysis is all about.
Okay.
So pick your pen and paper and analyze this question, everyone. A 76-year-old woman is brought to the emergency department due to sudden onset vertigo and difficulty swallowing for an hour. So you just say vertigo, difficulty swallowing for 1 hour. All right. They now say again, our only other medical condition is hypertension. Blood pressure is 160/90, pulse is 80 and regular. The patient is alert, awake, and oriented. Examination shows decreased pain and temperature sensation on the left side. Which pathway is that?
Spinal thalamic.
Spinal
Hypothalamic.
That's the left spinal thalamic.
So this patient is having decreased pain and temperature sensation on the left side.
left
Right.
spinal
That's it,
thalamic.
right.
Right.
Going to be right.
Well, just be writing your whatsoever you think. Just be writing it down. So, and this patient is also having loss of pain and temperature on the left side of the face and right side of the body. So this is left side of the face. So which nerve supply the left side of the face?
Sensory
Cranial nerve
use of cranial nerve 5.
Left side of the face. Which cranial nerve supply it?
Left
The left
cranial nerve.
sensory use of cranial nerve
Which
5, right?
which pathway are we going to be
5.
talking about with respect?
5.
Yeah, I know that. Which pathway are we going to be talking about with respect to loss of pain and temperature on the right side of the body?
Left
Left
spinal
spinal
Right
thalamic.
track.
left spinal thalamic.
The gag reflex is absent. Which cranial nerve is that?
9.
9.
That's 9.
Okay. Inability to swallow. Which cranial nerve is that?
That's
It's still
9.
9.
Bomba.
9.
You start thinking towards 10, yes. Okay, then we talk about cranial nerve 9. So we can see cranial nerve 9, cranial nerve 10 in this question, and we're also seeing cranial nerve 5. The gag reflex is asking, okay, muscle strength is 5/5 in all extremity. The patient lesion is most likely located in which region? Cranial nerve 9 is affected, 10 is affected, cranial nerve 5 is also affected. You're also seeing spinal thalamic tract. So what's your diagnosis?
That would be lateral
Lateral medullary.
medulla.
Lateral medullary syndrome.
Okay.
What happened to trigeminal nerve that they gave you there? Is it in the medulla?
It's just lateralizing the lesion.
Lateralizing.
Okay, so you remember that point. So
Yeah.
what's the answer? What's your full answer? We are talking about left, right. What's your full answer?
Left
That's
lateral.
left lateral
Left lateral
medullary
medullary syndrome.
syndrome.
That's very correct. So that's how you, let me look for another one for you. Give me the answer. Because if you can bring it out by yourself, you are you're already fired with respect to that.
Chief, please, I thought cranial nerve 8 was involved when they said the patient had vertigo.
Okay. The vertigo, there are so many things that can cause vertigo. So you can use that one to just say whether
Okay.
it's 8 or not. And even if you want to bring in 8 there, you just look at the other cranial nerve. Do they justify what you are thinking about? Do you get my point?
Yeah.
Yeah. So many things can cause vertigo. So many things. All right. So here this question. Okay, let me project something for you. Step 4. I just pray that you are getting it. Okay. A 65-year-old man comes to the emergency department due to acute onset slurred speech. Acute onset slurred speech. He also has right-sided weakness. Right-sided weakness. Right-sided weakness. Right-sided weakness. But denies any trauma, headache, or loss of consciousness. His medical problem include hypertension and type 2 DL. The patient has smoked 1 pack of cigarette daily for 20 years. Neurologic examination shows right-sided lower facial droop with sparing of the forehead muscle. Right-sided facial droop. Motor strength is 3/5 on the right, 5/5 on the left. There is also dysmetria and dysdiadochokinesia involving his right upper and lower extremities. MRI of the brain reveal an acute lacunar infarct in the brainstem, as shown in the image you are looking at. Which of the following cranial nerve sits the brainstem closest to the level affected by this patient's stroke? Please, can you first of all make a guess of the make a guess or diagnosis in this patient?
With the way it's affecting facial nerve 7, it's something that have to do with lateral
Okay,
structure.
okay, okay. This patient is coming with slurred speech, something related to the speech. Then this patient is also having right-sided weakness, but denies any trauma. So there is right-sided weakness. Okay,
Joke.
all's up. Then they now say in the question again that the patient is having there is something else there, right-sided lower facial droop. I hope you wrote all those stuff down. So right-sided weakness will be on what? Will be related to what?
Nerve 7.
Right-sided weakness will be related to what?
Corticospinal.
Left corticospinal.
Thank you for the person that said left corticospinal. God will never disappoint you.
Amen.
Then the right facial disc is related to what?
Facial nerve. Right facial nerve.
That's
Right facial
Right
nerve.
facial nerve.
Right
it's
facial nerve in this patient. Okay. Then they now go ahead. They are telling us about something. What else? There is also dysmetria and dysdiadochokinesia involving the right upper and lower extremity. Sorry, which pathway do you think that one is likely related to?
Right spinal cerebellar.
Good. Very, very good. Right. Spinocerebellar. So it's actually related to the cerebella. So we are seeing something related to the cerebella. Just let us say cerebellum. We are seeing something related to the cerebellum. We are also seeing something related to facial nerve. We are seeing something related to uh, uh,
Left
corticospinal. So when you
corticospinal.
see all these stuff together, something related to the cerebellum in the question, something related to the facial nerve, something related to all of them, it's just like you are having both what do you call it? It looks like you are having both medial and lateral lesions together. You start thinking towards what you call cerebellopointine angle. Do you get it? You start thinking
Yes.
towards cerebellopointine angle. Dr. Miriam, you can bring cerebellopointine angle out for them to see. So cerebellopointine angle. The question is now asking you that which cranial nerve, which of the following cranial nerve exceeds the brainstem closest to the level affected by this patient's stroke? So the stroke this patient is having is actually around that cerebellopointine angle. That's why you are seeing so many cranial nerves around that region being affected. Do you get it? So there is a cranial nerve we mentioned that is very big, that span so many regions. So which cranial nerve is that? The biggest
Five.
cranial nerve.
Five.
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 So that's the cranial nerve you go for, that is closest to wherever the lesion is there. Shikena. Do you get my point? That's very, very, very big. So if I thought the lesion, and it's also lateral, and you can see that, you can see something related to cerebellopointine facial nerve is affected already. This is lateral, even though corticospinal is affected too. So this is more likely to be affecting your trigeminal nerve. Shikena. It's a very big nerve. That's a very big nucleus. Do you get it? So that's one thing about the trigeminal. It's so big that you even need to divide into 3 branches. I'm going to show you another image. Okay, you guys want to tell me the location of this lesion. I will just mention it. Then tell me the location. A 70-year-old man is brought to you with right-sided weakness and double vision. Right-sided weakness and double vision. Medical history is significant for type 2 DM. Hypertension, hyperlipidemia. Blood pressure is 160/102. Pulse is 82. The patient is alert, oriented, and able to follow command. Speech is normal. On examination, left eye has ptosis and is fixed in the outer position, and the pupil is dilated. So what do you call dilated pupil? Pupil is dilated.
Mydriasis.
Mydriasis, you can see mydriasis. Then you can also see ptosis. Awesome. So the right eye, the right pupil, and the right eye movement are normal. Most so this is all about the left now. Left eye. Okay. Muscle strength is normal in the left upper and lower extremity and 3/5 in the right. So this patient is having right muscle weakness. They now tell you that deep tendon reflexes are 3+ on the right, 2+ on the left. Babinski sign is present on the right and absent on the left. That's by the way. There is no ataxia. Sensation is intact. Which of the following is the most likely location? So which cranial nerve do you think is affected in this patient? Left mydriasis and ptosis.
Left
Third nerve.
oculomotor.
3.
I
Left
think
cranial nerve is correct.
yeah.
This patient is having
Third
right
nerve.
muscle weakness. Which tract are you thinking about?
Cortical spinal.
Left
Left
cortical
spinal.
spine.
Spinal is correct. So which part of the brainstem do you think this lesion is?
Midbrain.
Midbrain. Should be in the midbrain.
That's correct, Chikena. This one tells me that you have actually understood it. So that's midbrain. Let me show you one more diagram. Then I stop the midbrain. All those cranial nerve lesion there. You tell me how this patient will present to you. This is what they are giving you in your exam. Which artery do you think that arrow is pointing at?
Posterior, inferior.
Who said
No,
that?
anterior, inferior.
That is
Eka.
Who first of all talk?
Nobody.
No, someone talks first. Someone say in a very low voice, posterior, inferior, cerebellar. Who said that? Who said that?
Yeah,
I
correct.
said it.
Okay, Dr. Thames, right? You got it. I just want to praise you that your ability to pick it very well, immediately you are saying it. You show that you've mastered it before Dr. Antonia wanted to confuse you. So,
Oh boy.
so that's very,
Terrible.
very correct. I'm actually very happy that you could pick it immediately. Posterior inferior, because you can see it emerging from the vertebral artery. What's the name of this artery at the middle, this small one?
Asa.
Anterior
Who is saying Asha? Who say Asha?
anterior spinal
the
artery.
No, we are not dealing with musician here. Please, we are dealing with artery. This is anterior spinal artery. So don't let us forget. Which vessel is this one? The one I start.
Vestibular.
Anterior
Before you talk,
cerebellum.
Ica.
Anterior
Oh, that's
inferior
anterior inferior
cerebellum.
cerebral artery.
So which artery is this one?
Superior cerebellar.
So which one do you think this is?
Posterior cerebral.
Posterior
Which artery is
cerebral.
this?
Cerebral.
Which artery is this?
Where are you marking?
That one is the internal, right? Carotid.
So please look at what we are saying.
What are you marking?
Posterior communicating.
Okay, is it posterior communicating?
Communicating artery.
So this is the artery I'm marking here.
Anterior,
So you don't even know which one.
Anterior
It's likely to be-
communicating.
it's likely to be-
Anterior
Oh,
communicating.
anterior.
It might be anterior cerebral. So where is your okay. This one, which vessel is this?
What are you marking?
shouldn't that one be internal carotid?
That's very correct. So that's your internal carotid artery. So which vessel is this?
Middle cerebral.
Middle cerebral artery is very correct. So which vessel is this? The one I marked before on top here.
Oh, that would be anterior
So
cerebral.
which one is this?
I'm not seeing your arrow. Posterior communicating.
Posterior
So you can
communicating.
easily name also when they give you the diagram, I know you will get it right. So rehearse around this question. Now let me read the question to you so you now pick your answer. They tell you in this question that a 64-year-old woman is brought to you due to stroke-like symptoms. The patient has a history of transient ischemic attack as well as other risk factors for cerebrovascular disease, including hypertension type 2 and hyperlipidemia. Urgent brain imaging reveals occlusion of a vessel indicated by the arrow. Which of the following finding is most likely to be observed in this patient? Wow, oh yeah, move the stuff. Who want to talk? So this arrow, this one, which vessel did you call that vessel again?
Posterior inferior
Posterior inferior cerebellar artery.
No, let me write. Okay, so posterior inferior cerebellar artery. So which part of the brainstem is it supplying?
Lateral medulla.
Lateral medulla. So how do you think this patient will present? Just tell me, just mention them. How do you think this patient will present?
Affectations of cranial nerve
Lots of
9, 10, and
There will
11.
lots of
be
dark reflex, lots of
about
dark
Please,
reflex.
hello, hello, hello. So let us first of all name the cranial nerve. Who want to name the cranial nerve that will be affected here?
9,
9,
10,
10, and
11,
11.
9,
10.
10, and 11. We can also say cranial nerve 5 there in case. Okay, because this is lateral lesion. Abi?
Mm-hmm.
Yes.
Okay. Which tract do you think will be affected in this patient?
Spinal,
Spinocerebellar,
Spinal, cerebellar, spinal,
thalamic,
thalamic,
sympa,
sympathetic,
sympathetic,
sympathetic.
and
innervation
And
too.
we've already talked about cranial nerve 5 already.
sensory nucleus.
Okay, now. So when you are now reading the options, let me now show you the options. Okay, let me read the option to you. Have you listed all those things? Because I have listed them out as I was saying them. So I will be mentioning the option. You just say that, oh, it's related to it. Down and out right eye with impaired extraocular movement, that you are going to see it in the patient. True or
No.
false?
No.
No.
False.
False.
Left-sided motor weakness. Will you see something related to motor weakness in this patient?
No.
False.
False.
No.
Loss of conjugate lateral gaze on both sides.
False.
No.
False.
That's related to the medial lemniscus.
Close.
I mean,
Yeah.
medial
Close.
longitudinal
The
fasciculus.
longitudinal fasciculum.
Fasciculus.
So that is
Affected.
medial. That's nothing to do with that. Okay. They tell you that vision loss over the left half of the visual field. That's something to do with visual field.
That have to do with
False.
brain.
False.
No.
That's nothing. This has nothing to
False.
do with visual field. Okay, that's
No.
so. The last option I'm having here is sensory loss over the right side of the face and left side of the body. True or false?
True.
True.
So which cranial nerve is supplying the right side of that face?
The face.
Cranial nerve 5.
Is
Right.
cranial nerve 5 part of the cranial nerve we listed?
Yes.
Yes.
Yes. Then left side of the body. Which tract are they talking about there?
Spinal thalamic.
Okay, now. Do you get it now, everybody?
Yes.
Hey. Others are not talking. I don't now know
Yes.
whether I was talking to myself or
Yes, yeah, we understand you.
Dr.
Left
Anthony
side
Adewu
of body,
understood.
spinal
Dr.
thalamic.
Precious got it. Dr.
Left
Miriam is
face,
not sure.
cranial
Dr. Esther is
nerve.
not even sure of where category she belongs to.
I said yes now.
You say yes.
I was the first person that said yes.
Dr. Kene, I don't know
Yeah.
where Dr. Okay, Dr. Kene got it too.
Prof, I got it.
Dr.
Yeah.
Adu, Dr. Ganiga, Dr. Chidima, Dr. Drea, Dr. Eve, do you get it? Dr. Eve? Dr. Eve.
Yes, sir, I got it.
Dr. Ganiga.
Somehow I'm kind of
Thank you.
distracted. I'll go through it later.
All right. Dr. Franciwa, you got it, right? I'm happy that all of you have gotten it. Okay. So let me show you one more question before you leave, because that's just the neuro for you. And these questions we are solving now, that's just the subsequent pages we'll be going through. So it will make you have a deckless revision. You will just be doing revision, the subsequent pages we'll be going through. So, because we've merged everything together here. Oh, let me show you. Don't bother yourself. See this question. A 3-year-old boy is rushed to the emergency department after he found underwater in the bathtub. We've done this one. We've done this. I think we've done majority of the question. We've done all of them. All right. Shikena, that's brain stem for you. So go back, rehearse this thing over and over again. Cranial nerve nuclei. We've already talked about this one. You already know those ones that are medial, those ones that are lateral. You know the ones you see in the midbrain, in the pons, in the medulla. Do you get it? And the one that you see that is spanning into the spinal cord, that's your cranial nerve 11. And that's why you have cranial accessory nerve. We also have spinal accessory nerve. Do you get it? So that's your accessory nerve for you. So that's all about that. Let us look at the vagal nuclei. Vagal nuclei. These are the vagal. So vagal nuclei. We have the nucleus tractus solitarius. Who remember where we mentioned this nucleus tractus solitarius in relation to what?
The vomiting center.
Vomiting. So in case they ask you, don't forget it. So nucleus ambiguous. Ambiguous. Do you get it? Then dorsal motor nucleus. I'm not going to spend time on them. So ambiguous, nuclear ambiguous, you have just cranial nerve 9 and 10. They always go together. There's 7, 9, and 10 for the nucleus tractus solitarius. Then dorsal nucleus, motor nucleus cranial nerve 10. Don't bother yourself. No, and these are the image that you've already put in your brain. They are now showing you that, okay, this is a cranial nerve 3, this is a cranial nerve 3 fiber moving like this. Can you see it? So, and that's just what you have already mastered. So there is nothing here again for you to learn. These also things you've already, if they give you this image and they give you the question, you already know what is in the media, what will be on the lateral. So there is nothing here for you to learn. The next thing you want to pay attention to is this cranial nerve and facial pathway. And it's very easy for you to, what do we call it? I want you to put 3 words at the back of your mind. The first one is ethmoid. I didn't say ethmoid though. Please, ethmoid. So before some people start bringing ethmoid into the question, ethmoid. The next word is sphenoid. Sphenoid. Please listen to me. You will not regret it. The third one is the tempora. So let us arrange these words in order of their, from letter E and S and T. So the same way they are arranged like this, that's the same way alphabetically. That's how they are arranged. We first of all get to letter E before you go to letter S, before you go to letter T. What does that one tell you? What it tells you is this: the ethmoid bone is related to anterior cranial fossa. Sphenoid bone is related to the middle cranial fossa. Temporal bone is related to posterior cranial fossa. So when the question is all about this nerve passes through the ethmoid, a foramen in the ethmoid bone, a foramen in the sphenoid bone, a foramen in the temporal bone, you already have an idea just by just looking at the letter. Ethmoid, sphenoid, temporal. Now, anterior cranial fossa, thank God, is just only one nerve that passes through it. Cranial nerve 1, only one. Cranial nerve 1 passes through the anterior. And where is it passing through in the anterior? Cribriform plate. Cribriform plate. So some people that go and swim, they may have some organism that passes through the cribriform plate, go into their CNS and start damaging their brain, just passing through the cribriform plate. So that's one for you. What about the middle cranial fossa? This is where you have work to do, and I've been able to simplify it for you. Just remember your osrus. Osrus. You just need to write it out one or twice. You will be okay. Osrus. This O is the, what is second cranial nerve related? You say optic. So this O is optic canal. S here is superior orbiter. It's also related to something like, okay, are we dealing with eye? You say yes. Superior orbiter fissure. There are now 3 foramina. You will see them playing around. Rotundum, ovale, spinosum. If you are not very careful, you may start missing them off. That is what this ROS will help you with. This is rotundum, ovale, spinosum. So let us bring all of them together. The foramina or the canal that we have in the middle cranial fossa. Optic canal, superior orbital fissure, foramen rotundum, foramen ovale, then foramen spinosum. Now let us put all the cranial nerve there. For the optic canal, cranial nerve 2, definitely. Superior orbital fissure, you say orbital. Did I hear you right? I say yes. You heard me right. We talk about 3 powerful cranial nerves that are related to ocular movements. And that is what? Cranial nerve 3, cranial nerve 4, cranial nerve 6. I can imagine Dr. Antonia asking me that. But what about the sensation to around that region of the eye and blah, blah, blah? I say, okay. First branch of the trigeminal nerve. So we bring everything onto the superior orbital fissure. So if they give you the cranial nerve that passes through the superior orbital fissure, you shouldn't miss it. It's just that simple. And I will ask you a question on this thing soon. If you are sleeping, sleep well. If you are awake, be awake. Now, rotundum, I can bring out a particular sound in that rotundum. Number 2, rotundum, cranial nerve 5, second branch. Ovale, cranial nerve, cranial nerve 5, second branch. Cranial, for the ovale, cranial nerve 5, third branch. Spinosum, no cranial nerve passes through this. It is a vessel. Middle meningeal artery. Which hematoma did we mention that comes as a result of damage to middle meningeal artery?
Subdural hematoma.
Okay, you wanted to say epidural.
Epidural.
Epidural
Yeah.
Epidural hematoma. So that is foramen spinosum. And that's all about the middle cranial fossa. Okay, we've seen 2, 3, 4, and 5 here. And then 3, 4, 6, and 5. So we now start with 7. Cranial nerve 7 is related to that's facial nerve, right? I mentioned a point the other time that facial nerve has something to also do with hair. There is also a particular cranial nerve that you peg on hair, and that is cranial nerve 8. That is vestibulocochlear nerve. So we now bring cranial nerve 7 and 8 together and be like, 2 of you have something in common. At least you also supply the stapedius muscle. Yeah. 2 of you, the vestibulocochlear nerve. Oh yeah, move together. Internal auditory meatus. So when they mention internal auditory meatus, 2 cranial nerve must come to your mind. Cranial nerve 7, cranial nerve 8. Now we come to the jugular. Jugular foramen. You can hold your neck. You can rub that your jugular area. What are the structures you make reference to? That's when you start, if you open your mouth, the same jugular area go in and like start talking about your pharynx, your tonsil, your palate, your disc. Which cranial nerve are you going to make reference with? Cranial nerve 9, cranial nerve 10. But don't forget, we still talk about you rubbing your jugular area. You are still at the same time rubbing the muscles and the likes that are around that region. Cranial nerve 11, then jugular vein. So that's jugular foramen. So you shouldn't miss it up because everything is all about all those internal structures that are related to that inner part of the mouth and the pharynx and the likes. What of hypoglossa? You don't need anyone to tell you what is passing through this one. Definitely cranial nerve 12. What of foramen magnum? Foramen magnum, brainstem definitely, vertebral artery definitely, then the spinal root of the cranial nerve 11. And that is all about the cranial nerves and vessel pathway. So let us
Did you say spinal branch of cranial nerve 11?
spinal root. If you want to call it branch, yeah, spinal root. Yeah. So please don't forget. So let us try to do a small exercise. so that when I am looking at question, you won't be saying that it's a lie. Which cranial nerve passes through the cribriform plate?
One.
Cranial nerve 1.
Which cranial nerve passes through the optic canal?
2.
2.
Two.
Which cranial
And
nerve
ophthalmic artery.
and of that cranial nerve are actually heart? Why did you add? Well, it's good that you are adding the
Just sorry.
ophthalmic artery to it. No, it's actually good. So that we don't forget ophthalmic artery too. Let me just be telling you structures there. So which structures pass through the superior orbital fissure?
Cranial nerve
Cranial nerve
3,
3,
4,
4,
6,
6,
5,
and
1.
V1.
5, 1.
Okay. Which cranial nerve passes through the foramen rotundum?
The
The
second
second branch of
branch.
trigeminal.
V2.
Okay. Which cranial nerve passes through the foramen ovale?
V3.
Which cranial nerve passes through the foramen spinosum?
No cranial nerve, middle meningeal artery.
Okay, we fall for the trap. Okay,
No.
you are guided. So middle meningeal artery. So what are the cranial nerves that pass through the auditory canal? Internal auditory meatus.
7 and 8
8
and
and
7 and 8. 7 and 8.
7 and 8.
Which cranial nerve pass through the jugular foramen?
9 and
9,
10. 9,
10,
10,
and
11.
11.
And
Which
11.
vessel pass through
The
the
jugular
jugular vein?
vein.
Jugular vein.
Jugular vein.
Which cranial nerve pass through the hypoglossal canal?
Hypoglossal.
12.
12.
12.
I
Cranial
had
of
4.
12.
I had 4.
12.
12.
12.
12.
Okay. Which cranial nerve pass through the foramen magnum?
The
Accessory
No
nerve.
cranial nerve.
vertebral
No
Spinal,
cranial nerve. It's the
Spinal root
vertebral
of
spinal root
11.
of
spinal roots
11.
of accessory nerve to passes it.
So let us check
Spinal
these
root
questions.
and vertebral artery.
So come and attempt this question now, everyone. So just look at it and just answer the question. So you will understand how that knowledge will play out. A 26-year-old previously healthy man is brought to the emergency department following a motorbike accident. He is found to have a maxillofacial injury. His condition is stabilized and surgical repair is performed. While recovering, the patient developed difficulty chewing. Which cranial nerve? I've not told you, but I will tell you now. There are 3
V3.
branches of trigeminal nerve: Phi1, Phi2, Phi3. Out of these 3, the one I don't want you to forget at all is that last one, vertebral branch. It is related to so many things. So many things. So one of them is that it supply the muscle of mastication. So if this patient cannot chew, so which cranial nerve will you be thinking about? Phi what?
The
3.
V3.
Where does the Phi3 pass through?
Oval.
Spinous.
No, in
Oval.
ovale.
Oval.
Ovale.
Okay, don't
Spinous is
forget. You
nothing.
can quickly just write down your ostrus. You already know that
Mm.
rotundum is for Phi2,
This
then
was
the next one that will follow it will be for Phi3. So the answer is
oval.
foramen ovale. Does it make sense to you, everybody?
Yes.
Yes.
Okay. On examination, the jaw deviates to the right side and right. So those are the other things that we just follow it. Look at this question. A 67-year-old woman with a known history of lung cancer comes to the office due to hoarseness and difficulty swallow. Which cranial nerve are you thinking about?
Next.
10.
That's 10, right?
10.
9,
10.
10, right? 10.
Mm.
So at least I just bring all of them together, definitely. So she has no disturbance in vision or hearing. On examination, there is loss of gag reflex on the left side. When the patient is prompted to say, the uvula deviates to the right, left shoulder is drooping. Which cranial nerve is that?
Spine.
Cranial nerve 10.
11.
11. Accessory nerve, yeah.
Accessory nerve. So drooping of the shoulder. And strength is reduced during the left shoulder stroke testing. Chest X-ray shows a right lower lobe lung mass and several osteolytic rib lesions. MRI of the head also demonstrate multiple lesion consistent with metastasis. A lesion involving which of the following anatomical structure is most likely responsible? Where do you think the lesion is affecting, everyone? Jugular what?
Foramen.
Jugular
Foramen.
Okay, now can you see how you are applying it? So no.
9, 10, 11.
So see this last question. A 28-year-old man is brought to the emergency department by ambulance after being hit in the head with a baseball bat. Physical examination shows swelling and bruising around the left temple, and a CT scan of the head shows a transverse fracture through the sphenoid bone. So we wrote 3 letters out the other time. Can someone remind me the 3 letters or 3 words?
It's more
Ethmoid, temporal
Who say
occipital.
Ikimo? Who say Ikimo?
Ethmoid, sphenoid, Professor Festus.
I'm hearing Ikimo. I'm like, Ikimo, what's Ikimo doing here?
You're having staphydia something in your ear.
Ethmoid, sphenoid, and temporal. So ethmoid is related to which fossa? Anterior what?
Anterior fossa.
Sphenoid is related to which fossa?
Middle cranial fossa.
So temporal is related to what?
Posterior
Posterior
cranial.
cranial
So this
fossa.
patient is having fracture through the sphenoid bone. So which cranial fossa will we be thinking about?
Middle cranial
To the middle cranial fossa.
You know, say neurology examination is most likely to show which of the following findings. So you just, so which finding do you think is likely to be? Or I meant just mention them. Something related to Osros.
It's going to affect the
and
optic.
Ostros.
Ostros.
It's
So
going to
something
affect the
related to
superior orbital.
Second cranial nerve, third cranial nerve, fourth, fifth, and sixth cranial nerve.
Okay, now let me talk now. So we are going to be thinking towards something related to optic nerve, something related to extraocular eye movement, because that is for cranial nerve 3, 4, and 6. We may also be thinking towards something related to what the ophthalmic branch. Ophthalmic branch.
Trigeminal nerve.
In fact, just let us say trigeminal nerves. Trigeminal nerves in question. And we may also be seeing something related to what? Middle
meningeal artery.
Meningeal artery.
So when you are now reading the question, that's all what you are going to be looking at. They tell you about left homonymous hemianopia. It has nothing to do with this. Do you get it? We are going to be looking at all those ones later. Then deviation of the uvula is related to which cranial nerve?
Cranial nerve 12.
That's going to be 9.
9.
10, 9, 10, 9. 2 of them go together. Don't bother yourself unnecessarily. So you don't need to be too specific. So decreased hearing in the left ear. Which cranial nerve is that?
8.
Whether 8 or 7. That's how you are going to just put it 7, 8, 7, 8. They also go together. Do you get me? Because this is all about fossa. They go together. Do you get it? So if there is something affecting cranial nerve 8, it's also likely to affect cranial nerve 7. That's just what you are doing. This is not about a specific thing. Now, left facial paralysis is also talking about cranial nerve 7, just a 7 at least. Even if 7 is affected, 8 also definitely, but this is about the fossa. They now put something here, inward deviation of the left eye. This is talking about what? Extraocular eye what?
Movement.
Then this is the answer. Answer is B. Do you get the point? Do you get the way you'll be analyzing it?
Yes.
Lovely.
Yes.
That's what you are going to be doing with respect to this area when they set question on it. So any question they like, let them set. Once you master these few things, ethmoid, sphenoid, and temporal, then what is passing through, if you can remember your ostros, it will help you a lot to answer questions that naturally you don't even think you will remember. It just help you out easily. No problem. And that's how you are done with this area. Let me give you break of 20 minutes. We meet when you come back. From there, we just spend a few minutes, then you go. I'm already having a lot of headache. So
Finally.
Thank you so much.
Thank you.
So we meet by 6:10. We meet 6:10. Let us plan towards 6:10, everyone. Thank you. So that is how we are going to be picturing this area, the cranial nerves and the facial. So when you are giving questions on the dome, So this area, this diagram, you don't expect you. This one will never give you a headache again in your life. Never, never, never. You just want to master these two cranial nerve, cranial nerve 3, cranial nerve 6. Then you want to master the posterior communicating, anterior communicating. Then you want to master something related to this anterior inferior cerebellar artery, Shikina. So if there is aneurysm on the posterior communicating, it will compress on cranial nerve 3. If there is an aneurysm of the anterior communicating, it will compress on the optic axis. Then if you have aneurysm on the maybe something like or a lesion affecting maybe this vertebral artery or the anterior inferior cerebellar artery, it may also affect the cranial nerve 6. So just here, just based on this location where how it's emerging, that's what we want to show. And if you can remind yourself this over and over again, we can give you this diagram and you miss question on it. These are the cranial nerve we've been talking about. All we just want to do is just to be like, let us note one or two things with respect to this so that when they give us in question, we are not lost. Olfactory, is for smell. Optic is for sight. Oculomotor. Now, oculomotor nerve is the third cranial nerve. So don't forget the muscle is supplied. Once you draw your diagram, all you want to do is to draw the diagram like this. This is the nose, and this is the eye. This is the eye. So what the third cranial nerve does is just to come here. All the extraocular eye muscle, medial rectus, lateral rectus, superior rectus, inferior rectus, inferior oblique, superior oblique. Shikina. So if you can rehearse this over and over again, let us put this medial rectus, inferior oblique, superior oblique, superior rectus, lateral rectus, inferior rectus, and that's all the muscle. So this one, lateral rectus is supplied by cranial nerve 6. Superior oblique is supplied by cranial nerve 4. All the others, they are supplied by cranial nerve 3. Shikena. So you just draw it, you will be able to list them out. So apart from those extraocular muscle that cranial nerve 3 is supplying, never forget pupillary constriction too. They will test you on oculomotor nerve a lot. They can put, if you notice the question we solved, you see a lot of questions that are related to oculomotor nerve in one way or the other. Please note this. Pupillary constriction is also helped that. So if there is a damage to it, the patient will have pupillary dilation. Then again, high lid opening. So if there is a damage to it, the high lid will not be able to open very well. You say the patient will have something like ptosis. Now, this is now where I'm coming. USMLE will hide for you. They know ptosis. You've heard about ptosis before. And probably your brain has registered it that once you are reading question and you see ptosis, be thinking towards Horner syndrome. Now, anytime you see ptosis, there are two possibilities. It's either you are dealing with Horner syndrome or you are dealing with oculomotor nerve. What you are going to use to tear them apart is pupillary attitude. In oculomotor, you have pupils narrowing. In Horner syndrome, you have the narrowing of the pupil. In oculomotor, you have the dilation of the pupil. How many people got that? With lesion, I'm talking about lesion. How many people got that?
I did.
Yeah, I do.
Yeah, lovely.
Please, can you come again?
Okay. Ptosis, you know that now we have brought out two conditions that are related to ptosis: Horner syndrome, then oculomotor nerve injury. So anytime you see ptosis, those are the two possibilities. The way you are going to tear them apart is to go and check for pupillary attitude. Is the pupil dilated or constricted? In Horner syndrome, it is constricted. You call that miosis. In oculomotor nerve injury, it will be dilated. Once you see that, you just say that even though I have seen a ptosis, this is oculomotor nerve injury. Shikena headacheless analysis. No issue. Do you get it? All right. So that's that about the oculomotor nerve. So trochlear nerve, you already know what is supply, superior oblique. Then abducens, you know what supply lateral rector. So let us clean this one. We are done with this. So let us look at the trigeminal nerve. Trigeminal nerve supply the muscle of mastication. Then it's also for facial sensation of thalamic maxillary mandibular. There is also one thing about it too that it has. It helps in dampening of the loud noise. Someone that is making a very loud noise, it can dampen it for you. Just dampen it. So you are not supposed to be having that loud noise because you supply the tensor tympani. But just for you to note it, you can take it with one, just put it on your left hand. I can bet it with you, I don't think you are going to ever use it. Use that point at all. Then we've talked about the, with respect, sensation to the, I drew something the other time. People that have been following me will know that we wrote letter T, letter S, we now put 90, 75, cranial nerve 10, cranial nerve 9, then 7 and 5. They ask you which cranial nerve, this is about the tongue, which cranial nerve mediates sensation to the anterior two-thirds of the tongue. Someone that has mastered this diagram, just say cranial nerve 5. Which cranial nerve mediates the taste to the anterior two-thirds of the tongue. Someone that has mastered it, we just say cranial nerve 7. Someone that has mastered this, we say cranial nerve 9 mediates the taste to the posterior one-third. While the cranial nerve 10 mediates the taste to the extreme posterior. Shaking now. So no issue, no problem. Just this diagram, just draw it. I just put T and S, and it helps because if you want to arrange this number in order of increasing, you say 5, 7, 9, and 10. If you want to put the letter 2, you also first of all write letter S, then letter T. ST. So instead of, I just wrote TS here. Do you get it? So if you want to be like, let me, I just wrote 10, 9, 7, 5, 90, 75. So you want to know, is this theory, this side for the taste, is this one for the sensation? Just for you to have an idea of the nerves that are important in taste. You just put, okay, this is number 5. I will get to 5 before going to 7. I will reach S before going to T. Shikena, you can use that. It will help you so that you don't have to cram a lot of things and start thinking that which cranial nerve supply this. This diagram will give you a deckless. If they give you 100 questions on this, you will get them right. Without you overthinking. So that's that about this. All right, let's look at the facial nerve. Facial nerve helps with facial movement. Then what I want you to remember is this auditory follow modulation stapelius. Do you get it? Then high closing, orbicularis oculi, then lacrimation, salivation. Never forget, it doesn't supply the parotid gland. It doesn't supply the parotid gland. It doesn't supply the parotid gland. What of vestibulocochlear? Hearing and balance. Glossopharyngeal, taste, sensation, posterior one-third of it. Then swallowing. Glossopharyngeal will help you. Then apart from glossopharyngeal helping you with swallowing, cranial nerve 10 will also help you with swallowing. So you can just be looking at them in a way together so that you don't start putting a lot of differences in your head. Because if I thought they would test cranial nerve 9 and 10, it's likely going to be tested together in a way. You shouldn't have too much differences. But just for you to note one thing or the other, 9 supply the parotid gland, vagus nerve supply the uvula. If the question talks about the uvula is deviating cranial nerve 10, If the question talks about maybe respiratory talk about the heart, something supplying the heart, something. So figures now, we've done all these things in cardio in one way or the other. So the same thing for the glossopharyngeal. So those are the chemo and baroreceptor. We talked about them. So no issue. All right. So glossopharyngeal elevates the pharynx, larynx. Everything is about pharynx, and larynx in them. So that is glossopharyngeal. So that's okay. So you can use that to master that. What about the accessory? Head turn, you can turn your head, no issue. Accessory is working well. Shoulder shrugging, you can raise your shoulder against resistance, no pain. That's okay. What of hypoglossal? Tongue movement. Talk about tongue, can go in, can come out, can go to the side. That's for hypoglossal. Which of them is motor? Which of them is sensory? Which of them is both motor and sensory? I don't think you should bother yourself with any of those stuffs. Just look at them and go. Don't bother yourself. Just note this. Don't sit down and cram this table. It has nothing to do with just little simple way that you have been using to analyze it. Despite the fact that we've not gone through this table, we could still answer questions. Keep it that way. Practice around that. It will be very good. All right. So let me just show you one or two questions on this, just for you to have an idea. See this. A 55-year-old man comes to the clinic due to headache and progressive facial weakness. So definitely this patient is having facial nerve injury, cranial nerve 7. All right, the patient's headache began 2 months ago and are characterized as throbbing. They are typically worse in the morning and when he bears down or coughs. He has had no recent head trauma or loss of consciousness. The patient has a history of hypertension for which he takes lisinopril. He does not use tobacco, alcohol, or illicit drugs. Vital signs are normal. Docky, on physical examination, there is flattening of the left nasolabial fold, cranial nerve 7, and drooping of the left lower lid, cranial nerve 7. The patient cannot fully close the left eye, cranial nerve 7. We are not talking about the eyelid. Close your eyes, close it obliquely openly. Blow whistle, you can blow it to the one around the, what do you call that? What do you call the one around the mouth? That's his own name, the muscle there. Cranial nerve 7 supply. Don't open that door. So MRI of the brain reveals, what is it? All right. So MRI of the brain reveal a well circumscribed homogeneous enhancing mass in the posterior fossa that is compressing the left facial nerve root. In fact, even before they mention, you already have an idea that, okay, this is about the facial nerve. Which of the following additional findings is most likely present on this patient neurologic examination? Is there any other thing here that has something to do with cranial nerve 7? That's all. Does cranial nerve 7 move the eye down and out? Nope. Hoarseness of the voice, does it have anything to do with the cranial nerve 7? Nope. Loss of facial sensation, does it have something to do with cranial nerve 7? Nope. That's for 5. Loss of hearing, does it have something to do with the cranial nerve 7? Nope. That is for 8. Loss of taste in the posterior tongue. Which cranial nerve is that? Cranial nerve what?
9.
9 and 10.
Look at 9 and 10. Sensory loss in the posterior tongue. Cranial nerve, what is that?
10.
9.
Posterior tongue. 9 and 10. And look at
9
it.
and 10.
Lovely.
9 and 10.
Then tongue deviation to the left. Which cranial nerve is that? Cranial nerve.
12.
The answer is
Wow.
increased sensitivity to sound. We call that hyper.
Acusis.
Just pick that and you go. No headache. So you don't need to have complete analysis. Just do the little you can because you are not a specialist. Don't overdo yourself. A 12-year-old boy is being evaluated for worsening headache for the past several months. He also has had paresthesia, weakness, and stiffness of the extremities. MRI of the brain reveals an expansile mass in the lower pons, as shown in the image. Which of the following is most likely to be observed in this patient due to direct involvement of the nerve nuclei of the brain lesion? So let me project the image for you. Let me see one. So this is all what they gave you in your exam. You can see a lesion. Where is this lesion located, everyone?
In the pons.
What are the cranial nerves we have in the pons?
5, 6, 7, 8.
And
So
8.
those are the okay. Now the question is now saying, just be looking at the diagram. The question is saying, sorry. The question is saying that which of the following is most likely to be observed in this patient due to direct involvement of the nerve nuclei? I can have them. So this is a 12-year-old boy that's been evaluated or was near deaf. He also has had paresthesia, weakness, stiffness of the extremity. Paresthesia, weakness, and stiffness of the extremity. MRI is revealing what you are looking at. So how do you think this patient will present? Do you think this patient will have something like trapezius weakness?
No.
Do you think this patient will
No.
have tongue atrophy?
No.
No.
Do you
No.
think this patient will have something like um vertical diplopia?
No.
No.
Right?
6.
Vertical
Cranial nerve
diplopia
6.
will come
No.
from which cranial nerve?
3.
Cranial nerve 3.
Lovely. You
3.
guys are good. You are good. You are very good. You are very good. Make sure you collect your money back. This patient, something like spontaneous nystagmus.
No.
We are going to do all those nystagmus later. So we are going to do that. At least spontaneous nystagmus or something related to what do you call it? Um, just nystagmus is just talking about abnormality with all these what do you call it? Extraocular high
Vestibular
movement.
system.
Yeah, so that's what. So,
Mm.
which one do you think is likely? This patient is likely to present with? Just tell me. This is the pons. Which cranial nerve is affected there? That's going to cause nystagmus. Just mention it.
Cranial nerve 6.
Okay, cranial
6.
nerve 6.
Lateral and rectus
Yeah,
paralysis.
exactly. So cranial nerve 6. So don't forget. So that's that. Then asymmetric pupils. Do you think this patient will have something related to pupils?
No.
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 So the only thing that is related to the pons there is just nystagmus. Shaking and you just pick your answer. All the other they have nothing to do with pons, and that's all. So that's that. So you can see that those stuffs they are quite easy. I want you to listen to this question and just answer it from there. 1 week after being involved in bicycle or in a bicycling accident, a 32-year-old woman comes to the physician because of intermittent double vision. Why are you having double vision? They now tell you, sorry. So they now tell you that she reports worsening symptoms when she tries to type on her computer. Wherever your heart there, can you try to type there and see the movement that you see with your heart? Just try to type. Or why
Superior.
botany are checked? Where is the button? Sorry, where are the buttons? Where are they
Down on
located?
it was. Down on it was so superior oblique paralysis.
Someone has already answered the question before we finish it. And you're right. Physical examination shows a slight right-sided head tilt. Her left eye is deviated upward, which becomes even more prominent when she attempts left eye adduction. These are just related to all the other one that I don't think you should really be of analyzing, but you can analyze it, you can bring them out. I've already drawn the diagram for you over and over. So just cancel the one that is paralyzed and try to see the movement that the patient can be having and the patient will be having symptoms. This patient's symptoms are most likely due to impaired innervation of which of the following muscle? Which muscle do you think is innervated? That his innervation is impaired in that patient I read, in that question I read to you.
Superior
Superior
oblique.
oblique.
Okay, now just pick your answer and go. Now, who want to answer this question? Who want to signify to answer it? I've not read it, but who want to answer it? Who want to just be like, I will answer it and I will get it?
I will.
Dr. Antonia. Doctor, but
Both.
other people, you just kept quiet. You think the question, do I ask difficult question? I don't ask difficult question.
Sometimes, so
I don't.
you
I
do.
don't. I hate them. So I don't ask questions to confuse you. So, Dr. Antonia, let's go. Okay. A 56-year-old man comes to you because of worsening double vision and drooping of the right eyelid. Are you noting one or two things down?
Yes.
Also, for 2 days. He has also had frequent headache over the past month. Physical examination shows right eye deviation laterally and inferiorly. The right pupil is dilated and does not react to light or with accommodation. The patient diplopia improves slightly on looking to the right. Which of the following is the most likely cause of this patient finding? Which cranial nerve do you think is affected in this patient?
Okay,
Oculomotor.
she has right.
No, Dr. Sylvester,
She
you
has right.
coordinate yourself.
She
Sorry.
has right. She has right drooping of the right eyelid. She also have double vision. Also has right eye deviation to the lateral. That means the medial rectus is affected, which is the third nerve supplying all of them. Also have dilated right pupil, no light. So I think the cranial nerve 3.
That's
Also
very
have
correct.
diplopia that improved when improved. So cranial nerve 3.
Your analysis is professorial in nature. That's good. So,
Dr. Festus, please, you said something about deviated downward, and I don't know if you said something like that.
yes, she has already said it. She has analyzed it.
So,
Because when there is cranial F3 palsy, that's what you saw, and you were also right. When there is cranial F3 palsy, so the eyes will deviate down and outward. Do you remember?
okay.
Yeah,
Yeah,
Yeah.
that's
yes,
just
that.
process there. So, what do you think is the likely cause of that cranial F3 palsy? Based on what we've been doing, we've been talking about, I've talked about them over and over again. What do you think is likely causing?
Trauma or aneurysm of the posterior communicating artery.
That,
Something there.
sorry,
The
did we
lesion.
talk about trauma? Okay, did we talk about trauma?
I meant lesion around that area.
Okay,
Posterior communicating
so
artery.
you are right, actually, aneurysm of the posterior communicating artery.
Mm-hmm.
Okay, now. So, and that's just the option. Just pick your answer and go. So, can you see that it's actually quite easy? Don't complicate the matter for yourself. So, let me remove this image from your site and show you some other detail. So we are done with this page. We come down to cranial nerve reflexes. I don't actually have any questions to justify this area for you, but just want to show you one or two things. Accommodation and pupillary reflex, they are all related to the eye, right? All these eye, pupil, and the likes. So let us put them on cranial nerve 2 and 3. 2, 3, afferent is 2, efferent is 3, afferent is 2, efferent is 3. We are done with the accommodation and the pupillary. Cornea. Cornea is related to first branch of the trigeminal, then cranial nerve 7. You can look at that first branch of trigeminal as something that look like 6. So like it look like 6. Feel one. Then look like 6, then cranial nerve 7 bilaterally. So if I want to touch, something want to touch your right eye, whether before the thing will touch it, the two eye will shoot, will close. The two eye will just close. So that's the power of your corneal reflex. What of cough? Figures and figures. Afferent I just then the Mr. JJ, George Jack, the mandibular branch of trigeminal, mandibular branch of trigeminal. both afferent and efferent. Just practice around this and you're okay. Gag reflex, afferent is 9, efferent is 10. That's why I used to say that just look at 9 and 10. Just look at them together. Don't give yourself too much headache. Now, this is mastication muscle. It's not their job to start bothering you unnecessarily on things. There are just be expecting two categories of question here. It's either the question is testing the muscle of the mastication that will close the jaw, or the one that will protrude the jaw, or the nerve that supply them. Shikena. The muscles of mastication that actually close the jaw, they are this masseter temporalis media. Okay, let us pronounce letter M. M. Let us just look at it like you are closing the mouth. Masseter temporalis media pterygoid. What of lateral? The lips are not even coming together. Lateral. So lateral. So lateral pterygoid will actually protrude the jaw. It will bring the jaw out. So if they ask you that this patient's jaws are closed, masseter temporalis media, you start thinking towards them. The last thing is the nerve supplying those muscle of mastication, the muscle used to chew, and just the mandibular branch of trigeminal nerve. Never forget this V3. V3. If you don't know the V1 to go to, which of the V do I go to? Is it V1, 2, or 3? Just go for your V3, mandibular branch of trigeminal. Chicken. You don't know. They just give you the question. You don't know which V do you go to. Just pick that and go. You may be wrong, go, but at least you know you pick something. So let me just give you one question, just for you to have an idea of the way the question will be given. A 26-year-old woman comes to the office due to several weeks of pain and muffled hearing in the left ear, along with a sensation of jaw clicking when chewing food. The patient has had episodic headache and left-sided facial pain for several years. That is worse when moving her jaw. She also has been told that she grind her teeth while asleep. Which phase of sleep do they grind their teeth? Anyone?
Stage
Then
2.
two.
N2.
Never forget that. And you see, you guys are good. You are very, very intelligent. You are very, very intelligent. On examination, the patient is unable to fully open her mouth and report pain with passive movement of the jaw. Just bring everything together about the muscle of mastication. The external auditory canal and tympanic membrane are normal. Disorder affecting pterygoid muscle contractility is suspected. Involvement of which of the following nerve is most likely contributing to this patient? Here's symptoms. You start thinking towards what?
Mandibular
Mandibular nerve. Chicken. So there is no too much unnecessary stuff there. Just put that. So these are the spinal nerves. I won't bother you here. Let's come to the spinal cord. Spinal cord. Now, there is something I just need to show you under the spinal cord. And I want you to pay attention to it. It's not stuff, just a concept, and you won't forget it. So, you want to note this, where the spinal cord terminates in adults. You want to note where it terminates it's likely to terminate in children. In adults, it terminates around L1, L2. That's actually where you are likely to see L1, L2. So subarachnoid space extend to lower border of S2. That one still extend down, 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 down. Do you get it? So then in children, I think it gets to around this L3, L4. Anyways, for the children, still go down, down. As the spine enlarges and extend, elongate, the thing will be moving up. So now, anytime they want to pass needle through the spine, so they just want to come lower down to where the needle can penetrate the spinal cord. So if they like, they can come to around this S2 level. Do you get it? So where they can easily, or go to around S1, just put their needle and bring their CSF and forget about it, or they just stay around the L4, L5. And what the term, most essentially, did I say S2? L4, L5. The reason is this: as they go down from the S1, S2, and the likes, the needle cannot pass again. So you just need to stay between either, now look at it, either L4, L5, L3, L4, L2, L3, because as they put it, they might not be, those people that are in anesthesia will understand better. They may want to pass it and they can't pass it. They can't just move a bit higher, they move a bit higher, but they don't want to go and get to this level of L1, L2. Because when they get to that L1, L2, the probability that they are going to penetrate the substance of the spinal cord is very high. So they are very careful of that. After a while, they might say that they don't bother to go again. So they perform their lumbar puncture around this L3, L4 or L4, L5. Just put it and they get it. Do you get it? So that's what they do. L3, L4, L4, L5. Don't forget, this is where they perform there. They may ask you. It's dangerous if you forget it. L3, L4, L4, L5. What the structure the needle will pass through, these are the structures. You may not really bother yourself about this structure, listing them out. You may not really bother yourself, but occasionally they may ask. But it's very easy to write them or imagine them. Let us look at it together. This is the skin. The needle will pass through the skin, from skin to the subcutaneous tissue, where you have all the fat and the like. Now you now come to the spinous area. On top of all this spine, vertebral spine, do you get it? You see a particular ligament there. Okay, let us give it a name. And this ligament is actually on top of the spine, spinous process. You call that supraspinatus ligament. We leave the supraspinatus. We come in between this, in between every two spine. We can also see ligament there. We call that ligament interspinatus ligament. Did I say interspinous ligament? Anyhow they call it. Interspinous or spinatus, anyhow. Oh, that one is for the muscle. Okay, interspinous ligament. Just between these two spine anyway. So you leave this area. Then you leave this between these two spine. You leave that area, you now come like outside. What you are going to, the structure you are going to meet after the interspinous ligament is the ligamentum flavum. This ligamentum flavum is very high yield for you to note. You must just note it. The reason is that if this ligamentum flavum become thickened, is the one that will be compressing on the spinal cord and start giving the patient all manner of neuropathy. Ligamentum flavum. Don't forget that. It can easily become thickened. It can become thickened and it start compressing on the spinal cord directly. So from there, you can go to the dura, epidural space above the dura. You pass through the dura mater. From dura mater, you can go to the subdura. From the subdura, you can go to the arachnoid mater. From arachnoid mater, you go to the subarachnoid space. Do you get it? So that's just how you go. And it is within the subarachnoid space you aspirate your CSF. Because that's where your CSF is. So you can easily think about it. Just forget about what they wrote here. Pick your needle and just say the needle will pass through the skin, from skin to the subcutaneous, subcutaneous to the supraspinous, supraspinous to the interspinous, interspinous to the ligament of flavum, that one to the epidural space, epidural space to the dura mater to the subdural space to the arachnoid mater to the subarachnoid space. Then you absorb. You aspirate your CSF. Shaken up. So in case they ask you, and if I thought they would test you on any of them, they love to test the ligamentum flavum a lot because it can easily become thickened and compressed on the spinal cord. So just let me see. I think this question is about compression ligamentum flavum. Then this one is what people that used to aspirate CSF normally use. Iliac crest. Do you get it? So this is an anatomical structure. You just place there. You have all seen the way they pass their needle, they pass do all those lumbar stuff. So they will just try to palpate the what do you call it? The crest, the iliac crest. Once they palpate the iliac crest, then they trace it horizontally. You can go and check it online. They trace it horizontally. So it's an anatomical landmark you can use to just locate this region, your L3, L4, L4, L5. All right, so that's all about that. Let's continue. This is the spinal cord and associated tract. Please don't give yourself headache. Always remember that statement. Don't give yourself headache. There will always be one or two questions you can solve, but not all. You will solve a lot of questions and you get them right. This is a diagram that probably maybe you think they expect you to be able. Let us see how this diagram look. Let us draw our own so that you have an idea of how they drew it. So this is the spinal cord. Then we have the gray matter. Anterior. On. So these are the gray matter. So we have tract. All this white area, they are tract. What you have there, they are the tract. All this gray matter, what you have there are the cell bodies. You have axons here. That's why they are white, because they have myelin. All right. So you have white matter here. These are the gray matter. So what happened is that, let us divide this into two. You just divide it like this. Do you get it? So which region here do you think? You already know this is posterior colon. We call this region posterior colon. This, you call this lateral colon. You call this anterior colon. So now, how do you think? We have all manner of tract, ascending tract, descending tract, all manner, they are all there. They are there. So how do you think the patient is arranged, or the woman body is arranged amidst those tracts? We should have tracts that are related to the cervical region, to the thoracic region, to the lumbar region, to the sacral region. How do they arrange themselves? So the rule is this: the head love the gray matter. The head love the gray matter. The head love the gray matter, because that's where you have the gray hair. So your gray hair is not on it's not on the feet. So they are on the head. Definitely the head will move towards the gray. So if they give you this diagram, you can just hypothetically just draw human body and bring the head closer to the gray matter, then fling off the other part of the body. It shows that this area, you will be mediating the nerves you will be seeing coming from this innermost region will be from either head or neck. While the nerves you'll be seeing around this region will be coming from either trunk or chest. The one that follows it may be around the pelvis. The one that is outermost will be for the lower limb. All for you, by you already know. It will not look like you know a lot about the spinal cord. The only thing you remember in what Festus was saying is just the head love the gray, because that's where you see the gray hair on the head. So this is the gray matter and this is the white matter. So if they give you now, let us draw this one I've not drawn now. How do you think this one will look like? You just bring the head closer here, then the other part of the body will fling out. That's how they were arranged. So this first region, let us call this one region 1. Let us call this one region 2. Let us call this one region 3. Let us call this one region 4. So region 1 will be carrying information around the head and neck with respect to this tract. Which tract is that? This is lateral spinothalamic tract. Do you get it? Why this region 2 will be carrying information maybe around the what do you call it? Maybe around the chest. Region 3 maybe around the lower abdomen, pelvis. Region 4 maybe around the lower limb. And that is how the information will be carried. So it's not just scattered. So you now imagine that they tell you that, which they can give you. I don't even need to tell you that. So that's just how they arrange themselves. So if you put the gray matter here now, you put the gray matter here, head here, neck, just come towards the midline. You draw the same thing here. This one will be for the cervical head region. This will be for the thoracic. This will be for the lumbar. This will be for the sacral. Shikena. So what are the ascending tracts? The ascending tracts now, Okay, before we talk about the ascending, now one of the ascending tract is dorsal column. Can you see this dorsal column is an ascending tract? There are two tracts you see them talk about: fasciculus, gracilis, fasciculus, cuneatus, gracilis. Okay, I love the way they put it here. Gracilis, lower body, cuneatus, upper body. Oh, which region is for my lower body, which region is for my upper body? Once you quickly draw this diagram there, you already know that this is for the upper body, this is for the lower body, then this will be for the gracilis, while this will be for the cuneatus. Shikena, without you doing too much. Just say L in gracilis is for the lower body, U in cuneatus is for the upper body. You draw your diagram here, you will not mix them up. Shekina. You come to the intermediate horn. I've told you something about the intermediate horn before. Is where your sympathetic outflow occur. What about the ascending tract again? Which other ones? Lateral spinothalamic tract. The lateral spinothalamic tract carry pace and temperature. So you can also use that division. Anterior spinothalamic tract is for the crude touch and pressure. Then you have the descending tract, lateral corticospinal, anterior corticospinal. Why don't you just say corticospinal? Yes, corticospinal tract is corticospinal tract. Descending tract. I mean the descending tract. All right, we leave that one. We now come to spinal tract anatomy and function. Just 3 important tracts. We just want you to note them. So you don't need to overdo your stuff. Spinothalamic carries pain and temperature. At least you can see P in the name, T in the name. Spinothalamic, pain, temperature. That's what they carry. Dorsal column, I usually write PVT, 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 pressure, vibration, touch, proprioception, pressure, proprioception, vibration, touch. What of corticospinal tract is for voluntary movement. So you don't need to sit down and start cramming a lot. What you want to know is that spinothalamic, this is spinal, from the spinal cord to the thalamus. This is ascending tract. This is dorsal column 2 is also going to be ascending tract. So these first two, they are the ascending tract. This corticospinal, from the cortex to the spinal cord, this is a descending tract. So this is a descending tract. Now look here, the diagram will help you out. This 3 diagram is all you need, and you don't need to cram anything here. All you want to see is that for this spinothalamic tract, what you have here is that immediately that nerve and that neuron is entering the spinal cord, immediately it is crossing. Shikena. It just crosses. It just crosses immediately. Spinothalamic has no patience. Immediately it crosses. So it's now going to ascend on the lateral spinothalamic tract. Spinothalamic tract. It now goes to the thalamus. So that's why I drew that the thalamus nuclei there, just for you guys to remind yourself. We'll be looking at that later. What about the dorsal column? So what happens in the dorsal column is that when this neuron enters, it first of all ascends up to the medulla and now cross. So it's going to ascend up to the medulla and cross. So what is now the difference between these two? First thought, can you tell us? This one that you are shouting cross does not cross immediately. What is the difference? What's the meaning? What does it stand for? What does it tell you? It tells you that if you have a lesion here, a lesion on this side, at that side, in as much as below the medulla, the patient is going to manifest with a contralateral loss of pain and temperature. So let me show you how it's going to. Okay, let me put the lesion here. This is one lesion. So if there is a lesion here, this patient is going to manifest with contralateral loss of pain and temperature on any region below it. However, the patient will be having loss of pain and temperature too. Now, okay, let me explain that again so that you will get my point. There is a lesion here. There is a lesion here. Sorry. There is a lesion here. This patient will manifest with contralateral loss of pain and temperature in any region below it, below this lesion, this point of lesion is going to be contralateral. However, the patient will be having ipsilateral loss of pain and temperature on that same area. Okay, let me remove this lesion here and I'll bring it here for you so you will get it better now. Let us put a knife here. Pam. So this patient will be having ipsilateral loss of pain and temperature on this side. Because you are also cutting this first neuron. The nerve might have damaged it too. You are cutting it. So you call it ipsilateral because it's still on the same side. It is while it was trying to cross, your knife cut it. So it's going to present with ipsilateral loss of pain and temperature at that side. However, the patient will have contralateral loss of pain and temperature at any other region below that region. So the patient will also be having loss of pain and temperature around this side, just lower part around this side. Because the information coming here crosses immediately, then they ascend. So as they are ascending, your knife might have cut them too. So the patient will now manifest contralateral loss of pain and temperature. So all you want to remember with respect to spinal thalamic is that it crosses immediately. You can now try to do your calculation and be doing all manner of extrapolation there. However,
So Dr. Festus,
dorsal column,
okay. So,
however, for the dorsal column, that one immediately as it's entering the spinal cord, it just starts rising. And it's going to rise till it gets to the lower part of the medulla. It's around that region it crosses. So if there is a knife, you put a knife to this patient here, the patient will manifest ipsilateral unless that lesion is located around the medulla. Everything within the spinal cord will be ipsilateral, 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 ipsilateral for the dorsal column. Unless that lesion is in the brainstem. It is when the lesion is in the brainstem, you start thinking or seeing something contralateral. Because it is in the brainstem, they cross. Okay. You wanted to ask a question.
yeah, with the spinal thalamic, so you have, like, on the first lesion, you said ipsilateral on that side. But when it gets up below the medulla, it's ipsilateral and on the contralateral too.
You can even, this is just one neuron they are drawing. You have
Mhm.
neurons, so there are so many. Some of them are already, this one is only coming from the left. Let's call this side left, this side right.
Mm.
This neuron is only coming from the left. So this patient will be having left ipsilateral loss of pain and temperature at that
Mhm.
region that your knife is cutting.
Mhm.
Then this patient will be having loss of pain and temperature at the right side of the body that is below that area where you are cutting.
Okay.
Because
Okay.
those ones also
See, that's where I don't get
cross.
to, Dr. Festus. The
What do you
second
say?
part is where I don't get. I said the second part is where I don't get. I
Okay,
get the part where you say there's left ipsilateral loss of pain and
okay.
temperature.
Let me
On the
draw
same side.
another neuron here for you to now see. So this is it. Likely. So this is another one. Enters here, cross immediately, and now start ascending. Can you see them now?
Yes,
And this
please.
is your knife. You cut this. So when you are cutting at this level, you are cutting this red neuron here. Do you agree with me?
Yes, please.
It has not crossed before your knife cut it. So this patient will have ipsilateral loss of pain and temperature at that level.
Mhm.
However, there are some neurons that have crossed that your knife has also cut. They are this green one that are ascending. Where are they coming from? Contralateral side. So this patient will have contralateral loss of pain and temperature at the region below where you are having that lesion. However, the patient will
Mm,
be having ipsilateral loss of pain and temperature at that same level. Do you get it?
yes, please.
All right, let me assume that we have forgot. That's for the spinal thalamic. Just
Okay. Dr. Festus.
yes, I can hear you.
Okay, so I think I get now. So you are saying that below the lesion, below it will be contralateral because they've already crossed. But at the level of that
Exactly.
lesion, it is ipsilateral because
Exactly.
it's still on that
You
line. Okay, I
stay
think I
at
get
that
it.
level.
Level.
So there is
Okay.
nothing there.
So you have to look at the level of the lesion
You
before
need
you
to
know what
look
to
at the
do.
level of the lesion. So if they tell you that someone is putting a knife on the spinal cord at L2, that patient at that L2, let us talk about Brown
It should be
sequencing.
reversed. Mm.
So at that L2, with respect to spinal thalamic, the patient will have loss of pain and
Reverse of
temperature
pain and
at that
temperature at the
level,
same side, L2.
that same
But
side.
below, it will be contralateral on the
Whereas
other side.
below will now be contralateral. You get it. Okay, in case they give you question on that, just for you to have an idea, you don't need to know more than that. Just pick it like that. What about the dorsal column? This basket.
Chief, sorry, I'm still confused. I was trying to hear you the last time you spoke, please.
Okay, where is your confusion coming from?
Is the ipsilateral control? I know that if there is a lesion above crossing, I know it will be contralateral.
Okay, let us
And
even leave above.
if
Let us
the
leave above out of it.
okay,
Let us even leave above out of it. Just look at this. This is where you are putting the knife. You just put the knife
oh,
here. So this level, as you are putting the knife, it is picking this red neuron. Do you get it?
yeah,
On that same
yeah,
side. And this red neuron
yeah,
is just bringing the information before
yeah,
crossing. So it's not, crossing has not occurred here. Do you get it?
yes,
Crossing has not occurred. Do you get it? So this patient is going to be having loss of pain and temperature at this level on the same
yeah,
side.
yes.
At the same time, don't forget that this is not the only region in the spinal cord. You still have some area below where that is also bringing pain and temperature, but those ones have crossed and they are now ascending.
Okay.
Do you get it? They are already
Yeah.
taking the information and going to the brain. Do you get it? So
Mm,
your
yeah.
knife is also going to cut those ones, but don't forget that those ones have crossed. Do you get it? So
Okay.
this patient will now be having contralateral loss of pain and temperature at the region below where you are having the lesion.
Okay, so that means the ones that have crossed are coming from below.
You get it? Those ones have crossed.
Okay. Okay, I
So
get
let
it.
us
Thank
come
you.
to this region now. Let me assume that this is where you are dropping your. You just put your knife here. You put your knife here. This patient will also be having ipsilateral loss of pain and temperature at this level, then contralateral loss of pain and temperature at any region below the lesion. Shaking. All right.
Yeah,
You get
makes
it?
sense.
Yeah.
Yeah.
Okay, now let's look at dorsal column. That one crosses immediately. Then the last one is the corticospinal. This one just brings the information. Immediately you get to the medulla, it crosses, it decussates. We call it decussation. And where is it decussating? Say around the pyramid of the medulla. Okay, let us call it pyramidal decussation. What is pyramid? Pyramid is just all these bumps. Do you get it? Just cross, and that's all. So when it crosses and now starts moving as the corticospinal tract. Now, I want to explain something to you so that you understand. There is a time we have been seeing. The origin of it, I want to show you. Which time is that? Internal capsule. This one is descending tract, bringing the information. Another descending tract, bringing the information. Another descending tract, bringing the information. They come together, and there is now this region where all of them come together as a bundle. They now form a capsule, and that capsule is what they call internal capsule. The same thing as all these stuff. That's why majority of the manifestation you see with respect to internal capsule, most most especially, let me show you like three major parts of the internal capsule, so you will be able to get it very well. Internal capsule, this is how the structure look like. Can you see this region? And also like this. These are the part of the internal capsule. The posterior horn, the anterior horn, and the genome, the elbow, the angle. Do you get it? Now, look at this diagram I was trying to draw before. So as those neurons are coming together, they are forming a particular part of the internal capsule and they descend. These ones, as they are getting to the thalamus, they are leaving the thalamus and they are also ascending. You start having something like this. I'm coming, let me land, please. So you start having something like this. Just like this. So this is the way this one that are ascending will look like. Why this is the way this one that are descending will look like. They give all of them a name. We call them corona. Corona. Coro. Someone is saying coronavirus. Corona radiata. Because they are like radiation. Look at them now, like they are radiating out. Do you get it? And this is also, they just have all manner of different kind of stuff that. So these are the corona radiators. Can you see them? Radiator, radiator. So they are the one that come together and they now start forming what we call the internal capsule. So there is a particular part of the internal capsule that majority of what we see there are the descending tracts. There is a particular part of the internal capsule that where the majority of what you are going to see there, they are the ascending tract. Do you get it? But internal capsule is internal capsule. They are not, just for you to have an idea of where the internal capsule is. What the internal capsule is related. All right. So let's leave this area so that we don't complicate it more than this. When you get to neuro, you will be learning a lot there. The last point here is this. We'll talk about three neurons here. You talk about two neurons here. This is 3. This is also 3. I hope I'm saying yeah, they are mind. So this is 3. So why are they 3? You call them first order neuron, second order neuron, third order neuron. Here, you only talk about 2 neurons. This is first neuron and this is the second neuron. First order neuron, second order neuron. This first order neuron for the descending tract, you call it upper motor neuron. Upper motor neuron. This second neuron for the descending tract, you call this lower motor neuron. So you can put your knife here, you call that upper motor neuron lesion. You can put your knife here, you call it lower motor neuron lesion. Whereas for these ones, don't bother whether it's first order neuron lesion or second order, don't bother yourself. This is the one you want to put on. Upper motor neuron, lower motor neuron. So lower motor neuron, if at all you need to snap, the nerve will just, the neuron will just come out of that tract. You call lateral corticospinal tract. It's just going to come out of it and enter into the anterior horn, snaps on the cell body of the anterior horn. The lower motor neuron of that cell body will now emerge and coam meets the muscle, innervate it. So let's just leave it like that. So let's come to the reflexes. Reflexes, they don't expect you to know much about the reflexes. Not think much here, unless you just want to be looking for highfalutin stuff. Achilles, patella, bicep, and brachioradialis reflex, then triceps. Dr. Antonia has a way of going through her own. So she has a way, she was trying to tell everyone the song she used to sing for her children. Is that not what you were saying that day, Dr. Antonia? That's what you used to sing for them early in the morning? Early in the morning.
1, 2, 1, 2, buckle my shoe. 3, 4, knock at the door. 5, 6, pick up stick. 7, 8, let them stretch.
Okay, so that's what she says she used to sing for her children early in the morning. They don't pray. So before they pray, they will have sung that song. It's all right. That's just by the way. Thank you so much, Dr. Antonia. That's just a joke. So this is Achilles reflex. Where is your Achilles? Around your hip. Your Achilles tendon is there. So you can use that Achilles is like Achilles. If you want to write it, you can write ACHILLES. yes, Achilles, S1, S2. Patella, I wrote my patella like this. La, this A sound is looking like 4, L4, L2 to L4. But the main thing you don't want to forget is L4, patella. Those that did musculoskeletal with horse, they will remember that on the patella we were talking about L4, 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 L4. What of bicep and brachioradialis reflex? You start thinking towards C5, C6. Count the total number of letters in the bicep. They are just 6, C6. Then you can remove one and just say C5, C6. C5, C6. What about the tricep? Count the total number of letters there. Say C7. You can remember your C7, C6, C7, C8. But they are just likely to just be picking one of them. Sha. What of cremasteric reflex? L1, L2. Say testicle moves. Anal wing reflex, S3, S4. Now, that's just that. You just need to pick a paper and pen, write this thing down. Not all of them, just the way we are saying it. Achilles S1, patella L4, biceps C5, C6, triceps C6, C7, C8, cremasteric L1, L2, anal wing S3, S4. You just want to go and like anal wing sheets. You want to go and sheet your sheet away. So S3, S4, wings galore. So now we have the reflex grading that all of you will agree with me. When we were in school then, they used to say, okay, reflex is grade 0, reflex is grade 1, reflex is grade 2, grade 3, grade 4. You don't need any grading here. You only need to remember number 2. 2 plus. That's the only thing you want to remember for all your questions. Why is that so important? You don't want to put a lot of junk inside your brain. You won't remember them. Any number less than 2 is low. Any number greater than 2 is high. So you are reading a question. Number 2 is all what you will be using to analyze it. You see this reflex is just 1. Your brain automatically will just tell you that the reflex is reduced. You see the number they are giving you there is greater than 2. Your brain automatically will just tell you that the reflex is increased. Shikena. That's all. No headache. Don't go and be doing excessive stuff. You just look at it that way. You already have an idea of what is going on with the reflex. Okay, so that's just by the way. Let me show you 1 or 2 questions just for you to have an idea here. Well, this is just about biceps. Okay, we've solved this question before in musculoskeletal. These are the primitive. I'm not going to bore you with the primitive reflexes. When the baby is born, the reflexes are there because the frontal lobe is still developing. They are not yet myelinated very well. You will see all manner of reflexes there. Moro is there, rooting is there, sucking is there, palmar is there, plantar is there, gallant is there. Out of all of them, it's only the plantar I want to talk about. The rest, you can go and be mastering them, but they are not going to be testing them like that. When you see it, you know that it's a reflex. But the plantar reflex is very important because we are going to be using it also with respect to upper and lower motor neuron lesion. Now, God is wonderful. I'm coming. Okay. The way this um reflex is, I'm coming. Let me show you something. I want to project something for you. Just give me 1 minute. Okay, let me just project this the browser. You will see it directly. So you'll be able to see what is going on and understand it. So this is the browser I have here. All right. I just want you to look at this diagram and this diagram. So this baby is actually having what we call Babinski reflex. He's having it. This reflex is positive in the baby. Why? Their upper motor neurons are not yet well myelinated. The baby is still growing. God put that reflex there so that the baby will be able to, at least even when the baby wants to start walking, the baby can easily grasp. So the baby will not be falling. They can easily hold on things and just plant their feet very well. That's why the reflex is there. And as the baby grows, they lose that reflex. That plantar reflex is, the Babinski sign is not really going to be there again. So now see this Babinski sign reflex here. When they strike the stuff, if you take your stuff and you just like strike it, you notice that your big toe will be elevated, it's going to dorsiflex, and these small toes will fan out. Do you get it? That's what you are going to have. That is normal. It shows that you are not having any problem with your upper motor neuron. Do you get it? So you say that the Babinski reflex is actually, you can try to do it now. Oh my God. You can try to sorry, let me project
Like
this.
but if you do it like in a normal person, it gives you like plantar flexion, not
It
dorsiflexion.
okay, maybe I switch it right
Like in
now.
an adult.
So well, you can try it, Sha. You can try to maybe elicit the reflex anyway. But that's the only reflex out of all of them that we just need to focus on. So look at this image. Let us use this image. So Dr. Antonia said that our own is just more of plantar flexion. Okay, now
In an
let me
adult.
use that to in an adult. Now let me use that one to explain this now. I will use that information to explain what I think I switched them off the other time. You know, babies, when you just give birth to them, they are not yet walking. Do you get it? They are not walking. So when they start walking, when they start standing, so myelination of their upper motor neuron is already taking place. So their feet will now be appearing like this. Like it will start, their toes will be appearing like this diagram, this first diagram here. It will be able to grip the ground so that they can easily start walking without falling. Myelination is already taking place. Whereas before they start walking, this is how it's going to be. You imagine you trying to walk like this, you are going to fall. Do you get it? So you are going to fall. So this is the plantar normal response. Thank you, Dr. Antonia, for bringing me back. So this is the normal response. Why this is going to be the abnormal one. Do you get it? So this is the normal response. This is the abnormal one. So when you try to elicit it, and you are now getting something like this, the big toe is dorsiflexing and is fanning out, it shows that there is something wrong with the upper motor neuron. But if it's gripping, you are having that plantar flexion of those toes, it shows that the upper motor neuron, they are doing very well. We are going to be using this a lot when we get to upper motor neuron lesion, lower motor neuron lesion. I want you to remember myelination problem. The reason is that they can relate it to babies for you. You just know that, okay, babies, they are not having their neurons well myelinated. As they grow, myelination takes place. Then they are going to start having a normal response of plantar reflex, and that's all. Okay, that's for the Babinski reflex. All right. This is the normal plantar reflex, and this is the abnormal one. This abnormal one is what you call the Babinski sign. So this is the normal one. This is the abnormal one. The abnormal one is what you call the Babinski sign. All right, let me remove that and quickly explain something else so you can go and sleep. Just go and sleep. Make sure you solve some questions, but to sleep. All right. So these are the landmark dermatome. C3, just around the uh, What do we call that? Just see where it is, like around the upper part of the neck. Do you get it? C4, the collar. Can you see? C4 collar. T4 is for the nipple, teeth, the teeth of the nipple. Then T7 is for the C4. T10 is for the belly button, the umbilicus. L1 is for the inguinal ligament. L4 is for the knee. Don't forget that. So that's just what you want to rehearse. T3, T4, T7, T10, L1, L4. Just rehearse that too. You are good. So by tomorrow, when we meet, we are going to be starting the pathology in the neurology. So please, the few things we've done, I want you to go and try to master them very well. It's going to really help you so that when you are done, we are done. I pray that we are done by maybe Thursday, Friday. So let's see how it goes. So I hope you've learned something, everyone.
Very much. Thank you so much.
Thank you, Doctor. Other people, I hope you've learned. Dr. Precious has learned. Dr. Kenny has learned.
Thank you. Thank you.
Thank
you.
So
Thank you.
let's go and practice question. Don't go and sleep on it. For those people on our normal class, Dr. Kenneth, we won't be able to meet tomorrow.
Okay.